is okay, but the standard devices what we use nowadays is amplified vascular plug, the ADO, the amplified duct occluders, or the similar types. The VSD devices, MFO multifunctional devices, or the conar device. Coils are still got a place. We have closed a lot of in our setting also, a lot of coils have been used. The approach to closure, after making the diagnosis, the indication is right, so you have decided to close. Then you have to planning is important. You have done a lot of imaging, you have know the sizing of the where exactly what kind of the device you need to use, what size of device, all these things you should have pre-planned, because you should not try to do all that on the table. Many times, of course, the angiography will help you, but you should have taken enough care before that. So approach to closure, the various, these are the four which we have done: femoral arterial approach, venous approach, internal jugular vein approach, axillary. So everything has got a place, and I'll give you one or two, 4 or 5 examples. We'll discuss the examples of these approaches. So this is a 3-year-old boy, failure to thrive. Echo was showing a fistula. So this is from the left sinus. You could see in the left main, it's predominantly in the area of the left anterior descending artery. We have done the CT, of course. We made sure that this fistula is opening into the RV apex. So this is the femoral approach. This is a guiding catheter. This is not a very difficult one. This is a straightforward one, not much of curvature. So we use the 6 of guiding catheter, and we use this conar device. This is a very, you can see the straight wire, no difficulty in engaging that fistula, passing the wire, passing the catheter, passing the, this is a guiding catheter, and putting a device is not very difficult. So it takes some time for the complete closure. So this is probably immediately after the procedure. So I think it's occluded more or less fine. So this is done through the femoral arterial approach. This is not the case in majority of the cases. Always, almost always, if it is opening to the right atrium, it is very easy to snare the wire and come through the femoral vein approach. But there are sometimes difficulty we face even to the femoral vein. There's another case which I'll tell you. 40-year-old female, hypertensive. So, there is a lot of symptomatic issues, like in dyspnea, continuous murmur, once again fistula. You see, this is the left sinus injection, the selective injection of the catheter, diagnostic catheter. This is from the left main, opening into the RA. So here the AV loop was formed. This we decided beforehand to close from the venous end, the femoral venous end. After snaring out, put the sheath into the fistula from the femoral vein, IVC, RA, and into the fistula. So this is, we have used here a muscular VSD occluder. Probably we didn't have the proper size of the AVP, so we use, I think it works as good as any of the device. This is fairly simple. So what I want to tell you is that if the fistula is opening into the right atrium, this is fairly easy to snare it out from the femoral vein and the IVC and to the RA. So you can put a sheath on the venous end. So you don't have to put a very long sheath, large sheath to the arterial side, and you don't have to go meddle around with the ostium of the left main, the sinus, and the coronary arteries. So 54-year-old lady, similar fistula, LV dysfunction. You could see LV dilated and LV dysfunction. On the right hand side, you can see such a big fistula. You can see the CT angiogram, the narrowest part of the fistula. This is the EBU catheter. Unlike the previous fistula is opening to the RA, here you can see a lot of circulations and undulations which are opening into the RA. This is one fistula, this kind of fistulas where you see the multiple irregularities, multiple circulations. It is not very easy to pass our regular thermovies or Teflon wires. Here you have to take the help of our coronary guide wires. You have to use many times. If the coronary wire, it is not very easy to snare this wire. So we used a microcatheter here. After this is, so we had some difficulty in getting, directing it towards the femoral vein. So we took the venous approach. Though we had taken the femoral venous approach, we took the interjugular venous approach. So this is a braided sheath going there. Once you snare it out, the microcatheter was snared out, put a regular wire, then put it out. So this is very, very simple. This is an amplified vascular plug, 18 mm, which was closed. Similar fistula, opening into the RA, but we use the interjugular vein. So this is the final result of this fistula. So once again, one more, case 4 is a failed femoral artery approach. We use the axillary approach. So 18-month-old child, that is tachypnea and difficulty in feeding. This is LMCA to the RA. So small child, difficult to pass the, first of all, we don't want to use the arterial femoral artery, mess up the arterial access. So here a lot of difficulty using the microcatheter and all those things, spend some time. Then because of the curvature issue, once again, here we use the axillary approach, it becomes very easy. So this is one case where you use failed femoral artery approach, so use the axillary approach. So this is another case. This is not actually a fistula, this is the tunnel. See the shunt, you see everything is going to the pulmonary artery. This is opening from the aorta to the RV tunnel. So once again, if it is opening to the RV, snaring and putting the sheath becomes a bit difficult. We tried that. It was a lot of splinting of the thing going on. So some of you see that curvature. It is not a very happy, not a very good, great curvature. If you get like this, is not very easy to put the sheath. So we immediately switch over to the axillary because we could have done this from the femoral artery. Child is only about 9.5 to 10 kilo. We didn't want to put a 7F sheath. So this was used axillary approach via 7F sheath. The conar device was used, 14/12. It becomes very easy. So this is basically to save the arterial access, one thing, and to ease of the procedure. Some residual shunt, but costly okay. This is another very giant tunnel, once again, which we have showed you in multiple forums. From this aorta to the LV tunnel, we made sure that coronary is okay. So just a minute. Yeah, sorry about that. So we attempted disclosure of from the femoral artery. Entering that fistula was not difficult, but orienting the device to put the device, a large device, was difficult. But let's negotiate. Once again, we switched over to the axillary. It was not very difficult. It's a muscular VST occluder. So post procedure of this, any of these fistulas, antiplatelets, we do start doing antiplatelets, anticoagulation, how long, rationale and duration, especially in a small child or an infant, you have done this. Also, how long to give the issue, that's a controversial issue, that's a commonly asked question. The diuretics for some time till they do well, especially if there is a large fistula, AC inhibitors in elderly people, older people, and if there is LV dysfunction. So how do you differentiate the fistula and tunnel? The CT angiogram will give us a lot of clue. Balloon occlusion angiography, selective coronary angiogram. Indication method is by and large do not vary in both. So I don't want to go into the detail of those things. Take home points: the multimodality imaging accurately delineating the anatomy, size, and course of the fistula and coronaries. Transcatheter closure will be successful if you use the right approach is chosen. Axillary approach is by and large we are using in our team is using. If there is an issue of the axis or the curvature of the sheets, a problem, selectively many times we have started doing this. Patency negative coronary should be demonstrated post device closure in majority of the cases. Thank you very much.
Thank you, Jay. I think we'll do the. Please, Srinivas, do you want to say anything?
No. Dr. Shivkumar also joined. He can introduce you. Your co-chair. I think he joined now. He can introduce you. And is he there?
Yeah, he's there.
Yeah, it's. Can you hear me?
Yeah,
It's
yeah,
a
please.
pleasure to listen to Dr. Krishna Kumar, a mentor of mine, who is going to talk about pulmonary AV fistula. We look forward to you, KK.
Right. Thank you, Shiva. Can you see my screen?
Yes.
Okay. So I'm talking about the true term is pulmonary arteriovenous malformations. And a very closely related condition called the PA-LA communication. So I'm going to show you some examples of this extremely rare condition, which is 2 to 3 per 100,000 population, mostly congenital, rarely acquired in the context of liver disease. Mainly, the congenital can be sporadic or associated with hereditary hemorrhagic telangiectasia where it is diffuse. Otherwise, it's solitary or multiple. Commonly involves lower lobes, especially left lower lobe. It's often asymptomatic despite fairly significant cyanosis in some of these patients. There is dyspnea on exertion in those patients, but generally it tends to be, if it's small, it's often not so significant until there is a neurologic episode. In fact, one of the commonest reasons they present is from brain abscess and a host of neurological symptoms. Rarely you have hemoptysis. You can suspect it clinically, but it's very difficult to pick it up clinically. You have a cyanosis with a normal echocardiogram that tells you that that could be a possibility, and you can do a contrast echo to confirm the possibility of this condition. Typically, after 3 cycles, you see it. A chest X-ray is very useful, actually, because it's abnormal in the majority and especially useful in solitary or discrete fistula malformations. And of course, you can do a host of imaging. In fact, in the beginning, in the early era, I used to just diagnose it and take the patient to the cath lab and try and close it. But now we prefer to do a CT to get a better roadmap. So this is a chest X-ray. For example, you can see in this particular example, this is the first case I remember having closed nearly 20 years ago, a very large pulmonary AV malformation that had recurred after surgery and produced a brain abscess. This is the diffuse sort, which really you can't close in the cath lab, but you need to look elsewhere. And if you look at, often some of these patients have Abernethy malformations, which then can be closed in the cath lab, and these patients can get a whole lot better. This is a recent publication of ours where we published our collective experience with congenital photosystemic shunts, where we've got several examples of these conditions. It used to be a situation where pneumonectomy, lobectomy, etc. used to be done. My first case was a patient whose lobectomy missed the fistula, and the patient was persistently blue. So transcatheter occlusion is absolutely the treatment of choice when it is feasible to close them, when they're a discrete or solitary fistula. It's necessary to do an angiography in as many views as required to identify the fistula, but you have to be absolutely sure of distinguishing the native supply from the fistula supply or the malformation supply. And I have got a trick for this, which I'll share with you guys. So you do an angiography. This is an example of a 26-year-old. But if you use a balloon catheter, it automatically finds its way to the fistula. And you can do a balloon occlusion angiography, and you see this in 2 views where you can easily identify the feeding vessels. In this particular example, it's quite straightforward. But here, once you get that, you put you get into a very distal position with your sheath, and then you put in a vascular plug of appropriate size, or even coils. It still has a role, especially when you have numerous pulmonary AV malformations. You need to have coils because it will become very expensive. And then you should try and do a complete job. Sometimes you need to do it in 2 or 3 sittings. And I have one example where I needed 3 sittings. I'll show you. And then you must be very meticulous because you need to try and eliminate, because you will leave behind a substrate for brain abscess. So here is an example of a patient, and I described this technique quite some time ago in this publication, which Shiva and Kannan are all co-authors of. And you can see basically this is a case which is very interesting. An infant who was referred to me by a pediatrician after the cardiologist insisted that this patient does not have heart disease. They said, I can't explain the cyanosis. And this X-ray was abnormal. So this child was actually very blue, 55%, because the entire cardiac pulmonary blood flow was being sucked into this malformation. So the technique is very interesting, which we sort of devised here. We take a balloon catheter through a long sheath. We put in a long sheath and take a balloon catheter. Typically, a Berman catheter is a good idea. And that would automatically find its way into the fistula because that area has the maximum pulmonary blood flow. Once it finds its way into the fistula, it will occlude the fistula. So now you inject, you will not see the fistula. And then all you need to do is to advance your sheath, which has already been placed. And once you advance your sheath, you can actually demonstrate the malformation. And you're absolutely at the site where you'd like to put your whatever you want to put. In this particular case, this was before the era of plugs. I took multiple coils with bioptome, and this patient had a very good result. And on table, very gratifying, 95% as soon as the fistula was closed. You confirm that, you make sure that there are no fistulas in other parts of the lung. And that usually allows you to be fairly sure, and then you can. So this is another example. More recently, we've kind of, for the bigger fistulous communication, bigger feeding vessels, we tend to use occlusive devices. So here is an example of an adult patient who had a brain abscess, where you wasn't particularly desaturated, 92%, but he had a brain abscess, and you can see this particular feeding vessel. You need to be inside that vessel. But then once you put your guide wire, and you can often get the guide wire out from the venous end of this, all you need to do is to advance a guiding catheter. In this particular case, I've used a 8 French guiding catheter. And once I've got the guiding catheter, I use the Konar device because it's uniquely suited for, because of its low profile, you can insert it through a guiding catheter. And all you need to do then is to be inside the fistula, but you can pull it back and make sure that you've got it well plugged into the vessel that is feeding. So that usually completely closes the fistula, and the patient almost instantly shows an improved saturation. They're often multiple. This is my most challenging case thus far. This child who was actually saturating at 60% and unexplained cyanosis had numerous pulmonary AV malformations. So I took 3 sittings and 24 or 25 coils and devices of various kinds to actually occlude all of this. But this was 10 years ago, and the girl has done supremely well. Even now comes with good saturation. So very gratifying, but it did take a lot of effort to actually get rid of all of these fistulas. But there isn't any other option in these kind of situations. A closely related condition is PA-LA communication, which is a discrete communication between the proximal pulmonary artery and the atrium. This is the first case, I think, of transcatheter closure that was ever reported, that we reported long, long ago. And again, Shiva and Edwin are authors of this paper. Until then, surgery was what was thought of, but it was quite easy. In this particular case, this child had an ASD. So we went through the ASD and created a wire loop across the fistula. And then all we did was to take a PDA device and close it. And again, on our way out, we closed the ASD as well. So this was a very, very gratifying case, but much more challenging was this particular example that I did in another institution, where we had a 26 very large communication and an intensely desaturated 17-year-old, where we used where the communication was between LPA and the LA, which is extremely rare and doesn't have a great. I'm not sure about the embryologic basis of that particular lesion. Anyway, we managed to close it, and again, this can be done quite easily in the cath lab. Another example that I did, again, a PA-LA communication that we used. This has been published recently. So essentially, it's a rare cause of cyanosis. You have diffuse variety with portopulmonary syndrome, a small fraction of which have Abernethy malformations that can be closed in the cath lab as well sometimes. But when they are discrete, when they are, having identifiable feeding vessels that are approachable and in reasonable number, we can actually do it all in the cath lab. Needs a meticulous approach, but the results are very rewarding. Thank you.
Thank you, KK. That was a wonderful talk and quite informative. We will go on to the next speaker, another one of the most illustrious interventionist and a great mentor for many people, Dr. Bharat Dalvi, to talk on challenging ASDs.
Thanks, Shiva, for that kind introduction. And I've been asked to speak on complex ASD device closure, tips and tricks. Really, I'm exhausted with all tips and tricks. So those of you who have listened to me earlier probably may take off and have a cup of tea or coffee. Most of the tips and tricks are known to you, but just to recapitulate some of them and probably discuss some of the indications where these tips and tricks could come handy. The most important question is, why do you need these tips and tricks? And the answer is very simple. Routine technique does not work in all the patients all the time. Even in the so-called simple cases, you may be successful in maybe 75 to 80% of the cases using the routine technique of deployment of the ASD device. And if you look at the more complex cases, I think the success rate would drop down to 50%. So definitely there is a role for knowing tips and tricks. Now the thing is, which are the conditions where there is a likelihood of failure? So when you deal with large ASDs in adults, like ASDs more than 34 or 35 millimeters, or large ASDs in children, where the device size is more than twice the weight of the child in kilograms, or those associated with rim abnormalities. And the whole problem is that these large ASDs are not uncommonly associated with rim abnormalities. And these include just adequate rims, or what we call as deficient rims, or floppy rims, or malaligned rims, where there is a malalignment of septum primum and secundum. Some of the clinical issues can also make device closure technically quite demanding, and they include spinal deformities or cardiac malpositions like dextromesocardia, or those with congenitally corrected transposition of great arteries. Now, no matter how many tips and tricks you know, if you see a ASD like this, which is humongous in size, 38 millimeters, with hardly any rim on the posterior superior aspect, hardly any aortic rim, no posterior inferior rim, and probably the SVC and IVC rim are also absent. Now, this ASD, you just cannot close given the current technology. So you cannot close this in the cath lab, and you necessarily need to send this patient to the operating room. However, I'll show you some of the examples of large ASDs which can be closed in the cath lab. So this is one such case where the ASD is around 38 or 39 millimeters in 4-chamber view. And if you look at the short axis view, it comes down to nearly 40 millimeters. Now, this is another example of a very large ASD which we closed in the cath lab, was measuring around 38 to 39 millimeters. And these are the examples of large ASDs in children, which can be closed, in the cath. kg child with the ASD, which was measuring around 17 millimeters. Now, these are some of the examples of rim abnormalities. This is the absent aortic rim, which is not uncommon, and it's not a very demanding situation for using tips and tricks. This is an example of a deficient SVC rim here. This is an example of a deficient posterior inferior rim here. And this is an example of a deficient IVC rim here. And all these patients were closed successfully in the cath lab. Now, this is an example of what I call as a floppy rim. You can see the septum primum, which is quite floppy and redundant. And when you have a defect which is reasonably large sized, then probably these floppy rims can come in the way of technical success. If you have a small defect with a floppy rim, probably you may get away. But when the defect is large, at that time, probably you may need to use some of the tips and tricks. And this is an example of what I call as malalignment. This is a septum primum, septum secundum. You can see the malalignment in short axis. This is a malalignment in 4-chamber view. And this is a huge malalignment between septum primum and septum secundum. You can see the amount of malalignment in the bicaval view. So these are really very demanding cases, and some of them you may actually fail despite using all tips and tricks. So if you look at all these cases, I think there are two basic mechanisms which result into failure of the routine technique of device closure, opening the LA disc just outside the left superior pulmonary vein and then bringing the device back and then opening the waist and the right atrial disc. The most important mechanism is inability to align the left atrial disc with the interatrial septum, and that's common in adults. And more common in children is inability to accommodate the left atrial disc within a small left atrium, especially in children with large ASDs. And this inability to accommodate the left atrial disc results into secondary malalignment, and the whole device actually herniates across the defect into the right atrium. So this is an example of inability to align. You can see this is the left atrial disc. This is the plane of the interatrial septum here. So instead of the disc aligning itself with the plane, it is almost perpendicular to the plane of the interatrial septum. And this can really be sometimes a pain in the neck. And every time you open the disc, it kind of malaligns itself with the plane of the interatrial septum. So what are the solutions that you have? You can change the mode of delivery. Instead of coming from outside the left superior, you can come from outside the right superior. You can change the delivery sheath, or you can use an additional support. And all these three things can help you in getting, acquiring the technical success. So this is an example of the left atrial disc being opened just outside the right superior pulmonary vein instead of the left superior pulmonary vein. And we were successful in aligning the left atrial disc with the plane of the interatrial septum. Then we released the waist and the right atrial disc. And once the device was in good position, we have released this device. As I said, you can change the delivery sheath, either use Hausdorff sheath or a side cutting or a Fustar sheath so that you can align the left atrial disc properly. And then there are people who have used multiple additional supports, guide wire, diagnostic catheters, guide catheters, long dilators. And as all of you are aware, that we are fond of using the sizing balloon for supporting these large defects. So this is an example of a 39 millimeter defect, which requires a 40 millimeter device. And you can see this is the circular balloon coming from the left femoral vein. And this is a 14 French delivery sheath coming from the right femoral vein. Then we inflate the balloon and just jab it across the interatrial septum, then open the left atrial disc. And you can see that this balloon prevents the herniation of the disc across the defect and gives you enough time to really release the waist and the right atrial disc. So you don't have to be in any form of hurry. And once you have delivered the right atrial disc, then you can slowly deflate the balloon and the device forms beautifully across the interatrial septum. Once you're happy, then you can remove the balloon, followed by removal of the wire. And once you're happy with the lie of the device fluoroscopically as well as on transesophageal echo, then you can release the device. So this is a 40 millimeter device closing a 38 or a 39 millimeter defect. The same technique was modified by the French group, and they used the same balloon, but instead of placing it at the level of the interatrial septum, they pushed it a little further into the left atrium and probably got similar kind of result with a technical success of nearly 98 to 99%. However, there are problems with equalizer balloon. It's a very large profile balloon. The tip is not pointed, and that's why getting it through the skin and subcutaneous tissue, especially in children, can be quite challenging. Hemostasis is an issue because many times these large balloons with blunt tips can cause some trauma to the vein. And lastly, the tip of the balloon is such and the de-airing port is such that it's not very easy to de-air this balloon. Lastly, this balloon is not very easily available. And that is why I think Wahab and his colleagues started using the sizing balloon from Amplatzer. And what we have seen is that over the last 5 to 6 years, we have also moved on to using the Amplatzer sizing balloon, and you can use it as safely and as effectively, if not more effectively and more safely than the equalizer balloon. So this is that large ASD measuring around 38 millimeters. And you can see that most of the rims are just a small, tiny sliver. You can see this, even the IVC rim, and this is the 3D picture. And you can see it's a huge hole with just a little bit of a rim around there. So with the help of balloon assist, probably you will be able to position the device reasonably well. And this is that elongated balloon. This is the left atrial disc, which is a 40 millimeter device. That's the waist and the right atrial disc. And then we deflate, and you can see that the device is sitting beautifully. The beauty of this technique is that it is a very predictable technique. You don't have to mess around recapturing the discs and keep on redeploying the discs. Most often within 1 or 2 attempts, you are able to get the device in position. And because this patient was little elderly, we had to perforate the device in the cath lab, and you can see the posterior-inferior perforation, and this is the anterior-superior perforation. And this is in the bicable view. You can see the inferior perforations rather well. This patient did brilliantly, came to us in NYHA class 4, and almost walked out of the hospital. So this is one of the largest ASDs in a very small kid. This is a 6.3 or a 6.4 kg child with a 17 millimeter defect, but the surrounding rims are quite good. So we decided that we are going to use a device and try and close this. This is a 18 millimeter balloon stage diameter. So we decided to use a 18 millimeter device, and the same sizing balloon was used to assist. So this is the 18 millimeter amp-larger septal occluder, balloon in position. We are slowly releasing the waist and the right atrial disc. But when we try and push the right atrial disc while deflating the balloon, sometimes the right atrial disc may get pushed across the defect and go into the left atrium, as it happened in this case. But the beauty is that the left atrial disc was so well aligned to the plane of the interatrial septum that our job was simple: just recapture the waist and the right atrial disc and deploy them all over again. And then this is how it looks. Once we are happy with the position on transesophageal as well as fluoroscopy, we have released it. So this is the 18 millimeter in a child who is around 6.3 or a 6.4 kg. Now this is the second problem. Large ASDs in small children, inability to accommodate. You can see this. Even before opening the left atrial disc, it is almost prolapsing across the defect. So this is a small left atrium and a large left atrial disc of an 18 millimeter device. You can see just coming across. So lack of accommodation resulting into lack of alignment and herniation of the device. So in order to overcome this, we described a group of techniques, what we called as left atrial disc engagement, disengagement techniques. The principle is simple: engage the left atrial disc, release the waist, followed by the release of the right atrial disc. And because of the tension of the cable, there is a spontaneous disengagement of the left atrial disc with the device capturing all the rims and sitting beautifully across the defect. So this is the left atrial disc being engaged in the left superior pulmonary vein. We release the waist, then we release the right atrial disc, and the left atrial disc has spontaneously disengaged itself, and you can see how beautifully the device is lying across the defect. And this is a real life picture of this left atrial disc engagement disengagement technique with engagement done in the left superior pulmonary vein. So the thing is that there is nothing sacrosanct about the left superior pulmonary vein, and you can engage the left atrial disc into RSPV, left atrial appendage, or left atrial roof. Sometimes this happens accidentally, and I'll show you some of the examples. So this is how it looks on transesophageal echo, the engagement disengagement technique. I think this is a very important question. When there is a failure to disengage the left atrial disc spontaneously, should you be pulling on the cable or pushing? Majority of the folks will say that pulling on the cable is logical, and that's usually what you do as an instantaneous reaction. You see that you are pulling, but in doing so, you lose the alignment of the right atrial disc with the interatrial septum, and both the discs now are malaligned with the plane of the interatrial septum, and they drop across the defect into the right atrium. So what we do actually is a little contrarian. Rather than pulling, we push on this disc. And you see now the vector of this force, which is looking downwards, helps in pulling out the left atrial disc from the left superior pulmonary vein. And not only left superior pulmonary vein, you can help by pushing on the cable to get the left atrial disc out of the right superior pulmonary vein. You see here, but this push has to be extremely gentle, and it has to be in the upward direction and not facing towards the pulmonary vein, because then you will be traumatizing the pulmonary vein. However, despite all these tips and tricks, you can have problems of left atrial disengagement technique. You can have failure to disengage. Sometimes there is a premature disengagement. And sometimes while pushing on the cable, both the discs may get pushed into the left atrium. So I'll show you just a couple of examples. We were trying to engage in the left superior pulmonary vein. There was a premature disengagement, but the disc got engaged into the left atrial appendage. And we used that engagement to deliver the device. Similarly, while coming out of the right superior pulmonary vein, we came out a little prematurely, but it got engaged somewhere in the roof. And we use that engagement to deliver the waist and the right atrial disc. And here it goes. So the device sits beautifully across the interatrial septum. The same case, when we are trying to make use of that accidental engagement while pushing on the cable, both the discs went into the left atrium, like it happened with balloon assist technique. Here again, the alignment of the left atrial disc is so good that we just had to pull it back. And that was how it looked. And this is a beautiful placement. And then we release the device. These are last two slides. So these are some of the complications of left atrial disc engagement, disengagement, failure of the procedure, as I said earlier. You may knock on the AV node, cause AV blocks, or injury to the pulmonary veins, acutely resulting into bleeding and chronically in pulmonary venous stenosis. Fortunately, we did not have either of them. In conclusion, ladies and gentlemen, routine technique of device deployment has limitations. There are multiple techniques available. And given our current experience and expertise of large number of groups across the world, I think technical success is coming close to 100%. However, all technical success does not translate itself into clinical success. Embolization, arrhythmias, thrombus formation, and erosion continue to remain problems. So I will leave you with this message now that we can, or rather this question, now that we can, whether we should. Thanks for your patient hearing and sorry for this delay.
Thank you, Shiva. I think you can start your lecture. Nageshwara is ready with the live case. You can, you can give your lecture, percutaneous pulmonary implantation with Melody valve, and then we'll go to live case.
Thank you very much, Dr. Srinivas, for the invitation. It's a pleasure to see you and to be in your meeting, which I enjoy a lot. Two different settings of percutaneous pulmonary valve implantation will be in the conduits or in the native RVOT. Conduits have a combined stenosis and regurgitation. They account for about 1/4 of the patients, and native RVOT is predominantly regurgitant, and they account for almost 3/4 of the situations. The various valves that are available include Melody valve, which has been the oldest valve, oldest transcatheter valve, which now has around 21 years of age. And then came the Sapien valve, our own Indian valve, my valve, and the venous valves and various other valves. Melody has got the maximum experience in the world, made of bovine jugular vein conduit on a CP stent. It needs a 22 French access. This was the first case in India, a patient who had a Ross procedure. Then there was a Ross autograft failure. He had an aortic valve replacement. And during the second surgery, the surgeon identified tremendous sternal adhesions that he felt subsequent surgeries are going to be difficult. This is a calcified conduit. We balloon test it. And here we are using a coronary to interrogate so that the coronary is not compressed. Then pre-stent it with a CP stent. And this is followed by Melody valve implantation. The valve is mounted on a bib balloon and it is inflated through expansion of the outer balloon. And this is the final result showing a competent valve, no significant PR and no significant residual gradients. What are the lessons learned from the large use of Melody in a large number of patients? Stent fractures occur and hence pre-stenting is important. Coronary compression may occur in about 1 to 2%, and so coronary interrogation is mandatory. Conduit rupture may occur in 2 to 3% of the patients, and so use of covered stent is safe. All distal pulmonary artery stenosis should be addressed to avoid higher pressure in the pulmonary artery, which will facilitate early millimeters of mercury to protect its longevity. So pre-stenting becomes a second step. Unlike other designs like Sapien 3, pre-stenting is important in Melody to avoid stent fractures. Now, can we do it without pre-stenting? This is an example of a conduit which is stenosed, as well regurgitant, and now the balloon sizing is being done and coronary occlusion is checked. Then subsequently we move on to direct implantation of the melody, but cover the melody with an andra stent. You can see that there is an andra stent covering the melody, and it is deployed in one step. So this is a one-step deployment of melody and a pre-stent together, and hence this can simplify the procedure. Sometimes RVOTs are reconstructed with bioprosthetic valves, wherein we can use a valve-in-valve implantation, and this is an exception. There is no need to pre-stent. We need to remember that certain valves like Hancock and mosaic valves are not suitable for post-dilatation. All the other valves can be dilated 1 or 2 millimeters by a high-pressure balloon. So this is a 21 millimeter balloon being dilated by a 22 millimeter Atlas Gold. Coronaries are being checked, and then the valve-in-valve implantation of a melody, and subsequently you are able to see a competent melody valve within the bioprosthetic tissue valve, showing a good result. Increasing complexity will be whenever there is a distal branch pulmonary artery narrowing, and if we don't address the distal branch pulmonary artery narrowing, the longevity will be affected. This is an example of a tight LPA origin stenosis. I have frozen the still frame. You will appreciate it when the stent is going on. You can appreciate the severity of the LPA origin stenosis, which is being stented initially using a large stent, and subsequently after the large stent is inflated, then you balloon occlude the RVOT and check for the coronaries. And once the coronaries are not occluded, the next step will be to pre-stent the conduit. So this is the pre-stent, and that is followed by melody valve implantation. You again check the coronary to confirm that the coronaries are not affected. So this is LPA stenting followed by pre-stenting of the conduit followed by melody valve implantation. The melody valve is functioning very well. The last problem will be dense amount of calcification. So here there is a circumferential calcification almost to the tune of 330 degrees, and the calcium is pretty close to the LCA origin as well as RCA origin. And suppose if you are putting in a stent here, it may compress the LCA or RCA. So the mandatory step will be to assess the coronary. So we have 2 coronaries simultaneously wired and we are checking. And here we are identifying that at 20 millimeter, there is no compression. However, on a 22 millimeter, there is a tight compression because of movement of the calcium. This was anticipated, and hence we changed our strategy to deploy a 20 millimeter valve. So this is a 20 millimeter valve. Again, as I told, it's a one-step procedure. We have mounted an andra stent around the melody valve, and this is being deployed. And here you can appreciate that the coronaries are being monitored, and the coronary flow is completely normal. And here again, the coronary flow is completely normal. So Indian experience of melody valve has been with about 20 patients, which has been published. Sapien valve is another valve that can be used. The advantage is that it can be used in native valve as well. This is a native valve pre-stented, and then we are having a Sapien valve in position, which is a balloon expandable valve. The next valve that is available similar to Sapien valve is the My valve. Again, we have about an experience of 10 patients so far. This is a tight conduit stenosis, which is pre-stented, and this is the My valve in position. So the My valve is producing good competence. The next valve that is available is a straight venous valve. Straight venous valve has been used in about 7 patients so far. This is a tight conduit stenosis, and this is pre-stented, and this is the post-venous valve implantation. The last valve that has been used in India in large numbers is the venous flared design valve. And this is the example of a venous flared design valve with the competent pulmonary valve shown on a transesophageal echocardiography. This is the Indian experience of around 29 patients. The last valve that has not come into India is a self-expanding Medtronic Harmony valve, which is FDA approved now. To summarize, pulmonary valve implantation is an emerging intervention, as most of the patients who have been operated in the 90s and 2000s are now having a dysfunctional RVOT. They are coming up for a redo procedure. Melody is the most time-tested valve. The other new entrants are Sapien, My valve, and venous valve. It has helped around 70 Indian patients so far. To tell the difference between the systems, Melody is the simplest valve to implant. You don't need a technician at all. You can crimp on you with your own hands. It's handled completely by the clinician. It's a very flexible delivery system and the most user-friendly among all the other valves that are available. Thank you very much.
Thank you, Dr. Shiva, for finishing on time. Sir.
Yeah.
Okay.
Sorry, how much time do we have for questions and discussion?
Live case is supposed to start at 4, sir. You can have a few minutes questions and then we'll go to live case. The questions can continue in the live case also. Originally, we designed it 12 minutes for discussion, sir, but talks exceeded. No, that's how.
Talks exceeded. That happens often. And we had some technical challenges also midway through.
You can have maybe those 3 minutes left discussions.
Okay, just 3 minutes. So few questions, and please, Bharat and others, any questions for the speakers? Dr. Kavita, anything that you want to ask?
One question for you, KK. What's your experience in recanalization of these AV fistula occlusion, and have you ever had to go to the LA, not the LA PA that you've shown, but the regular fistulas? Have you ever had to coil the distal part of the vessel?
Recanalizations, we've seen a couple of them in the coil era. They haven't happened in the device era because I think mostly it's devices allow for complete occlusion. So we don't have recanalization. You may miss a small fistula that may grow subsequently. And your second question is getting into the LA. I couldn't understand that.
I mean, do you ever have to occlude the draining vessels?
No. We don't. For PALA, yes, but not for fistula. For fistula, we always go prograde into the site, identify the feeder vessel and occlude it. It's very hard to get to that fistula from the pulmonary venous end. I haven't tried that and I don't think that's been described.
Thank you, sir. I think we'll go for the live case. Dr. Dalvi actually was out of station, but he requested he's doing his presentation somewhere from other end. That's why it looks a little darker there. Thank you, sir, for joining. Can you connect to Rainbow Hospital, Dr. Nageshwar Rao? AV team? We saw them already, no? Just unmute them. Yeah. Nageshwar, we can see you. Welcome again. You're part of TCT. Thanks for organizing all these pediatric sessions. All the stalwarts are there in front. You know all of them. You worked very closely with them. And we have Dr. Krishna Kumar, Shiv Kumar, Bharat, and Kavita Madam, others, Jairangnath sir, to moderate on this side for your live case. Over to you, Krishna Kumar sir, and you can take over and conduct this live case. Thank you, Nageshwar, again.
Thank you very much. Good evening, everyone. Dr. KK, Dr. Bharat, Shiva, Jairangnath, Dr. Kavita, thank you very much indeed. It's a great meeting from adult TCT point of view, but they requested us to conduct a couple of talks and then live case, even though I know it's a pandemic, a bit difficult, but in view of TCT theme, I thought we will show one case. So can I show the audio visual and then Dr. Bhargavi will present the case. Before that, I would like to introduce my team members, Dr. Shweta Bakru, Shweta, Dr. Pawan, and my chief cath lab technician, Pawan, Hemant, Naveen, and Raghu. We have a senior anesthetist, Dr. Patil and Dr. Yogesh here. So, Bhargavi, I request you to present the case details and show the details.
Yes, sir. Good afternoon.
I'm very happy Nageshwar has become entrepreneur, also part of the hospital. Video is also coming good, and after that we'll have his presentation.
Good afternoon, everyone. Today, I'm Dr. Bhargavi. I'm presenting a case. So we have an 18-month-old child who is asymptomatic, referred in view of murmur. Pulse was regular, normal volume, heart rate was 90 per minute, saturations are maintaining at room air, blood pressures are 104/60, and weight of the child is of 10 kilos. And there is an ejection click and ejection systolic murmur 3/6 is there, and faint continuous murmur. So we can see the X-ray, which is having normal CT ratio with normal pulmonary vascularity. And the ECG is also showing sinus rhythm and normal QRS axis with RBBB is there, and there are S waves in V5, V6 also. So here is the echo where the four-chamber view is showing dilated left heart, and there is mild mitral regurgitation. And here we can see there is coronary, left coronary system is hugely dilated. And in the second video, we can see that there is a track going downwards posteriorly, and it is open almost near the coronary sinus. So this is the picture where we are seeing the track, fistulous track from LCX. It is coming and joining in the coronary sinus with a Doppler. So this is the child, and this child also had a doming pulmonary valve with pulmonary stenosis of gradient of 50. So CT angio we have done. So CT showed it's a coronary cameral fistula from left circumflex to the coronary sinus, which is going all through the AV groove and running into the posterior coronary sinus. So it said the fistulous tract was measuring around 6 mm. And these are the CT pictures imprinted, which is showing the LCX, and this is the fistulous tract going posteriorly. And from above, if we see, it's posteriorly and draining to coronary sinus. So this is the schematic diagram, which the LCX is going down posteriorly and then to CS. So we have done prior cardiac catheterization, which showed there is a valve gradient across pulmonary valve is 20. So blood pressures 104/56, FA pressures with mean of 72, and QP QS, which is most important, is 1.5. So our diagnosis is a coronary cameral fistula, circumflex to coronary sinus with a QP QS of 1.5. So now our plan was to go and do the transcatheter closure of the coronary AV fistula. Next to Naishro, sir.
Yeah, thank you very much, Bhargavi. We will show you the pictures what we have done. We have right now child is anesthetized, general anesthesia, intubation. We have 6 left femoral artery and 4 femoral artery, and right 6 and left 4 femoral, and jugular vein we have taken. Our plan is to go and close the fistula as distal as possible using a conar MFO device. We'll show the pictures and we'll take the plan from you also. Show the angiogram, first angiogram. Yeah. So you can, is it seen? Yeah. You can see this is the AP view using the pictal catheter. You can nicely see the fistula which is going through the AV groove and then to the coronary sinus at its opening into right atrium. There is a left coronary artery we can see nicely. We can't see OM branches from the circumflex artery here. So next. So yeah, go, yeah, stop. So run that. So what we have done is we took a 6 guide catheter and we advanced guide catheter as distal as possible, and we snared the wire so that you will get a good support without damaging the coronary vascular system. That's the whole idea, not to deploy from the jugular, but still you can deploy from the jugular as well. Put an additional PTCA wire and we put the 4x12 balloon there. This is a coronary balloon. Next angio, show the next angio. So that is the balloon occlusion angio in AP view. You can see the balloon occlusion angio in AP view. Left coronary LED is seen, circumflex is giving branches as distal as possible. The last OM4 also I can see there, and that is the mouth there. Show in lateral view. So this is the lateral view is quite encouraging here, because we have a space there, landing zone, where the last OM to the constrictor segment landing zone is there. So that is what encouraging me to put the device here, taking conar MFO, because we want to do that, but we can take opinion at this point of view. KK sir, you can please discuss and suggest also.
Yeah, that's a reasonable option. You want to go through the vein or you want to go through the artery?
We want to go through the artery.
Why did you take 6? You could have taken 5. This is a small child, right? You could have taken a 5 guiding catheter and you
Yeah,
would have
10
done the same
kilogram
thing.
and 18 months baby. I do agree with you. 5 will take 7.5 conar MF device as well. But it was taken 6 at that point of time.
Okay, that's fine.
Yeah.
So you want to go via the arterial approach or the venous approach?
We would prefer to go arterial approach here at this point of time. We can still go from the venous
Would
side.
you retain the coronary wire while you're doing that, or would you take out everything?
That is one of the reason why I kept 6 guides, sir. Because if I keep coronary wire, the 86 device will not go, whereas 7.5 device can go. So that's the reason I thought we'll keep a 5-6 guide catheter in case of eventuality body wire technique and all. That's the only reason.
Does anyone else have an alternative thought
Nageshwar,
how to do this?
Nageshwar.
Hey, good evening. Nice to hear your voice. I'm seeing you also, luckily.
Yeah. Okay. Thank you. No, why you did not think of doing only from the venous approach? Why did you electively have taken the 6F?
Yeah, venous approach we can do from the jugular vein. I do agree, but I can't do from the femoral vein because this is a posterior.
No. Femoral vein is not at all the option here. We also had a couple of them. I think we have done through the jugular only.
I will tell my viewpoint why I want to do from arterial side.
Yeah.
Venous side, I want to put a disc and pull as much as possible close to the coronary fistula. I don't want to occlude totally the coronary sinus. So I want to leave a little bit of space there so that the coronary venous flow, even though people say it's not an important aspect, but I prefer a little bit of coronary space, venous space there so that it can drain. That's the reason I thought I'll pull the device as much as possible close to the arterial side. And then we can push, once you pull this, we can push the arterial disc away from the OM. If you are doing from the venous side, I will not have much options of, pushing the low pressure disc close to that because it is a non-centered disc. So that is my thinking.
The device, the exit point, sorry, please go ahead, Bharat.
Can I make a comment?
Please.
Yeah, the only comment I wanted to make is that when you close these distal fistulae with such dilated proximal tracts, with the vessels, branches being given right up to the end, be careful about slow flow and no flow following plugging these distal holes.
Yes.
You may get into serious problems sometimes. So you have to be careful that you don't cause this kind of a complication.
I will definitely take your point, sir. And also we have experienced one of the case a long time back at a care hospital closing a LAD fistula. We had to give procedure intracoronary urokinase as well. That's a very valid point because this fistula is distal fistula and the entire circumflex is uniformly dilated and ectatic.
And one more point I wanted to make, Nageshwar, is that if you look at the world literature on coronary fistulae, the long-term follow-up of patients in whom the fistulae opened in the coronary sinus, the incidence of sudden cardiac death in the follow-up period has been maximum. So when you counsel these families, you need to be a little tactful what you are actually telling them when you close this fistula. This is just to...
any idea why coronary sinus fistulas are?
I don't know. This is just an observation. If you look at the series of patients which have been published from various centers, Cleveland Clinic, or if you see the series coming from Boston Children's, if you get together all the data, you will find that in the long term, the maximum incidence of accidents happening in long-term follow-up has been always a fistula opening into the coronary sinus. Just an observation. I don't know the logic.
That part I don't know, but whenever there is a, as you said, that distal fistulae with the ectatic segment, I have also noticed in some of the published literatures as well as people, Shaq also presented one of the case, developed thrombus and all. I do agree. I will take that point and definitely will keep the child on oral anticoagulants. So,
okay, go ahead.
Yeah, we'll go ahead with the procedure.
Yeah, I think we should sit with the
we'll not waste.
Go ahead. The 6F arterial sheath, please finish the procedure quickly.
So we'll just hold the thing, pull that little bit. So we'll deflate the balloon and then remove the catheter. Then I will remove that wire. Yeah, hold this. Yeah.
Election.
I'll remove this arterial catheter also. Once you do that. Okay. So Pawan, little bit loose the wire there. I would like to go a little bit high up. Okay. Now can you remove the other wire as well? Push, push, push the wire. Yeah. Okay, please load the device. 75 MFO. Okay. P2 on. Give P2. So please show the device. Shweta is loading a 75 device, 75 MFO.
Nageshwar, show which end you're going to load.
Yeah.
That's also very important. So you're going to load the.
So there are two discs. The people, adult cardiologists who are not familiar with this device, the device has got two discs. You can see that one is called as a high pressure disc. It's a conical end connected with a narrow segment to the low pressure disc. So low pressure disc, any arterial, any venous structure we can put it wherever the pressures are low. Whereas the other side, her right hand side is the high pressure disc. Since we are doing from the arterial side, we are loading to the arterial side. This device has got retention screws on both sides. So you can deploy either from the arterial side or from the venous side without adjusting the device or tilting the device, unlike your muscular VST or PDA device.
You've chosen 7.5 because you measured 4 mm as your exit point?
Yeah, absolutely correct, sir. So we will try to go through this buddy wire. Hopefully it allows us. If it doesn't allow, then I am willing to remove that buddy wire.
You know, what would have helped a little bit was to snare the buddy wire at the jugular vein. You would have had greater control in this situation. But
yeah,
it's okay.
that also an ideal option, but the small wire snaring, yeah, can be done. Oh, it's going easily. So that's a good thing.
That's the biggest advantage of your device is the profile. You can take it through guiding catheters, and that gives you tremendous flexibility in a number of situations, which is why I use it very often nowadays.
So can you show the lateral angio also? Please go.
Please show the angiogram. We are only seeing the groin.
Okay, please show the angio.
Yeah, it's good. Now we can see live. Don't worry. You can see live. Your device is reaching the middle of the circumflex, and it's going
Little
to
bit
come out.
tightness she is feeling, but however manage.
You will feel, because at this point is where you feel the maximum resistance when you have buddy wire, and that is the slightly difficult part of it. And you will also experience difficulty in taking out the wire once your device comes out, Nageshwar, and it can be very challenging. So I would encourage you, as soon as your wire device is slightly out, to remove the wire.
Just go
Because
gently.
it becomes very difficult to take it out once your disc expands.
So what we'll do is we'll show the lateral and go to lateral, remove the buddy wire.
Yeah, go to the lateral and remove the buddy wire. That's correct. You have to go a little more inside.
Yeah.
Little more inside.
Show the lateral angio by that time. Lateral angiogram. Yeah, you can see the lateral angiogram.
Yeah. Go ahead now. Table down. Yeah. Down, further down, table down. That's good. Now you're in pretty good position. Just need to come out a little bit more. There's a little bit of a challenge out there. Yes, excellent. Now you can pull out the wire if you can. If it's coming out, please pull it out.
Yeah. Shweta, you can pull out the wire and then pull the entire assembly. Then we can do the, unlock this and pull.
Yes, that's good. You know, it will really, I've had trouble pulling out the wire once the device is deployed. Excellent.
So we will do one injection once I snug the device to the disc. Little bit table down.
Too much.
Down, table down, and push towards that. Yeah, table up now. Cut. Yeah. Are you ready to give injection? Yeah.
You have space for the injection? That's good.
Yeah. Ready? Yeah. Contrast. It is contrast. Okay. Ready?
I think you're in good position.
So what do you feel?
Angiogram where we had the baseline angio, so that you know exactly where you
Can
are.
you? Yeah.
It's like you're deploying it, but go ahead. Anyway.
I'll just deploy a little bit here. I'll not
The
pull
only concern
anymore.
I have is your retention disc on the other side may occlude the coronary, because it's a long device and it's not forming.
Yeah, I expected that. Device will not be formed because the track, the device will adjust as per the requirement of the fistula.
Than what you have.
Now can you do the angiogram here? BP is okay, heart rate is fine. Ready? You can you can use contrast only, don't use injections. Ready? Okay, let me, I'll come back.
Yeah, withdraw the catheter so that we see how the coronary branches are.
Now, ready? Contrast only. Take 5 cc. Ready? Yeah, the device always will be, what is that?
There's one branch that
yeah, I agree. The last,
which probably could not have avoided. That is absolutely at the very end. You can see that branch, Nageshwar.
I can see last OM is getting occluded.
The high pressure disc between the stem and the retention skirt, you have the small branch coming out. Other than that, you're okay, I guess.
So what, Bharat sir?
Only concern
what
is
about others? There's like a pretty stony silence. Bharat?
Yeah, my only argument was you will never know the exact.
Bharat, you're not audible.
Oh, I'm sorry.
Jay?
I'm not on mute.
Shiva, others can just.
Yeah, I can hear you, sir. Shiva is there? Shiva? Shiva is there? Jay?
Hi, yeah, I'm here.
Jay, the last OM, the distal OM, that is OM4 is small.
Yeah, very
So that
small.
is getting occluded.
Yes,
So
yes.
can we
Yes.
remove the device or we'll accept it?
It's a very small branch. It's the last branch. I think it's
No,
okay.
you are probably going to sacrifice that.
Yeah.
I don't know. I mean, at this point, I'm not.
Maybe
very
we will
interested.
ask adult cardiologist, adult interventional cardiology.
Nageshwar, you should not remove the device because you'll do a fair amount of damage at that position if you want to retract the device, and you have to start all over again. So you have to take a call. And
So
I think it's a small child to go through that fistula again and again.
Okay.
I'm not going to advocate removal. Can I have comments from Shiva, Bharat, Kavita, others?
Would something with a single disc work like an ADO?
Yeah, so I would have actually personally used the ADO AVP4 in this situation because it's a little low profile, but I think that's fine. I think the choices
I
are
thought
okay.
AVP4, but we are not using, we did not consider that because of a high flow embolization may be possible. It's a very low profile device. So
Yeah,
I
it is
thought
low
about
profile.
that.
The other option would have been to use ADO2 additional size. It would have worked very well for you because it's much.
Otherwise,
much more
KK,
compact.
even the AVP4 around 6 mm or 8 mm,
Yeah,
6
would
mm
have
device
done
would have done a good
Yeah,
job.
would have done the job
it would
because
have,
what I use
would
it
have
as
formed.
yeah, it forms. But
It
at
would have
this
formed.
point, I
Jay,
think
the device will never be formed.
No. See, here what is happening in your case is that 7.5
Retention.
device, but what is the retention skirt? Retention skirt is plus you have to add, no?
Plus
7
it is
plus.
2.5.
No, I know, 2.5. 2.5 means how much it comes on both the
2.5,
sides?
it is 9.5.
9.5 to 10.
Yeah.
So use a 6 mm or 8 mm device, AVP, it would have certainly formed.
Yeah.
Because if you see, the very fact that you used a coronary balloon to occlude it, a 4 mm balloon, it cannot be more than 4 or 4.5 millimeter, that narrowest part. You could upsize by say to 6 or 6.57.
So we'll give one angio now after 5 minutes. Can you please give one more angio? Yeah, what I mean to say, to avoid that small branch, is it possible with AVP2 is the question. AVP4, I agree with KK, but I did not consider that because of the low profile. But it is possible, you can position it also. I am not disagreeing with that. Angio. So that is the issue. I will pull the catheter more and then see how the left system, entire system is failing.
Nageshwar, I don't think you should do anything more. I think you should.
Yeah, one angio I am doing here, the last angio. Ready? Yeah. So we will deploy the device here.
You should deploy it here.
Okay. Hold this. I will go catheter little bit in. Child is moving.
Yeah, you should go in before you release it.
Yeah, you can deploy now. We'll just wait for 1 second.
Put some traction towards the device so that will enable you to be more in alignment.
To adjust the table. Okay, just wait. Yeah, please deploy.
It's going to take a little longer because there are quite a few twists and turns in your catheter. So it will not be easy to unscrew it. You have to pull it a little bit. Yes. No, I think you should stay there and do an angiogram.
Okay. We'll do one here, one angiogram, and then we'll think about. Is there contrast in that? Okay. Yeah. Ready? So I think position wise, as we are thinking, because device cannot be formed in this particular situation of retention disc of what Jay was telling, 9 millimeter cannot be. Whereas AVP2 maybe one disc this side, but still you will have same disc. Suppose AVP2 you put 8 millimeter AVP2
No,
because it can.
Nageshwar, I don't recommend AVP2. AVP4 is what I would have used. I would
Okay.
have used the AVP4 6 or 8 mm, and I would have had one Hershey chocolate inside the right ventricle, in the right ventricular side, and one Hershey chocolate will be inside the on the left side.
Yeah.
And usually with that, between the two discs, you can get a reasonably good occlusion. I think for the coronary fistula, I have found the AVP4 is the best suited because it doesn't have retention discs. So it just plugs very nicely. And, but otherwise, this is a reasonable result. I mean, I don't think it's a bad result at all. It's just one very small distal vessel, which I probably shouldn't matter. All the points raised by Bharat are very valid. You have a fairly dilated coronary which could thrombose, and you need to watch this very carefully.
No, I just want to give a comment that coronary MF device adjusts as per the vascular structures. So whenever we are using in any collaterals, fistula or any veno-venous channels, please don't expect the device will be formed. Device will be adjusted as per the anatomy, morphology of the vascular structures. So that's why it is behaving like that. We cannot have a bigger device in a small vessel and have the device which is formed. So that is happened in this situation because constriction portion is only 4 millimeter and other area it is 6 millimeter. We put a retention disc of 9 millimeter. So if it is okay, then we will come out then.
You have to come out.
Yeah. Thank you very much for your valid comments. Thank you, Bharat sir. Thank you, Jay. Yeah, please put the wire. We'll remove the thing. If there are any questions, Dr. Srinivas Kumar, are you there?
What is going to be your antiplatelet or anticoagulant regimen in this patient?
This patient, I think because it's a distal fistula and a lot of aneurysmal segment of circumflex, I would prefer to give warfarin for 6 months. After that, we will give lifelong antiplatelet medication. You may ask, sir?
My other question, Nageshwar, is that since the device is not well formed and it is kind of got elongated, what are the chances that the residual shunt might persist?
No. I already told you device will never be formed. Even you take AVP2 device will not be formed. It will configure to the vascular structure. Unless we put like a VST or AP window or PDA, this device in vascular structures will never be formed. It will be distorted. Now the residual shunt, because there is no fabric in this, there is no PTFE or what is that Dacron in up to 86 devices. So the occlusion rate is very fast. Within 24 hours, more than 95% will be occluded. In the first week, close to 100%. Recent Philippine data showed that 99% occlusion rate in the first week itself. So occlusion will be very fast. There is no problem. We think that
it always occludes. That's not actually. It's a good thing to have a period of slightly residual flow in these situations. It allows the flow to happen till such time. I think it's not a bad thing at all in this situation to have residual flow, but it doesn't matter, I guess.
Because you were going to use warfarin, that is why I was a little concerned with without PTFE use of warfarin and a residual flow. That's the reason. I take your point on that.
We will definitely do the echocardiogram and see that residual leak is there or not.
Excellent.
If the residual leak is there in worst case scenario, then probably case to case basis we will consider. We will give only antiplatelet aspirin. We don't give dual antiplatelet in children in our institute. Aspirin will give 3 to 5 milligram. If it is closed completely, then definitely we'll give warfarin in the distal fistula, like this entire segment is dilated.
So on hindsight, let's go back to that question on should we have closed this fistula, because you're balancing 1.5:1 shunt with having to give aspirin and warfarin for some period of time in a small child. I just wanted to bring it up only because I thought we can't just shy away from this argument. Some of us would have closed it, but we really have to think.
I agree that point. Coronary fistula transcatheter closure indications. Obviously, if there is a heart failure, any age group, we should do. Asymptomatic patient, if the QPQ is lesser than 1.6:1, we have to wait till 10 kilograms or at least a reasonable age where catheterization technique should not harm the child, like 2 years above. So we are also closing. This baby is grown reasonably well, 18 months plus and then 10 kilogram above. That is the reason why we actually indicated. We are following this child right from the birth actually. So we have been following, and then we thought we will do appropriately this particular age. I definitely endorse and agree that in infants and young children, before you doing the fistula, justification and indication. On the other side, I would like to tell one more point. We had a coronary fistula child, it's an adolescent, not child, and following for long time, developed one day, came with MI. So that patient actually we had to give thrombolytic therapy. Subsequent, it was actually fistula to pulmonary artery, small fistulas, many fistulas.
Anyway, let's take a vote amongst the people who are present here. Bharat, would you have closed it at this stage, or would you have waited?
Maybe I'm a little more conservative. I'm not as eloquent as Nageshwar in handling the catheters and all in small babies.
Jay?
I would have probably waited a little longer.
Jay, what would your approach would have been? Close or wait in this child? This is a real borderline. I want to tell you that.
No, really borderline. I agree with you. Maybe.
Actually, it's easy to know when you have the data 1.5:1. Often we don't have the data. You take the patient to the cath lab and then you don't want to catheterize again. So personally, I might have actually closed such a fistula. I'm not trying to say that, I won't do such a fistula. It's like totally borderline. But I think we all have to collectively acknowledge, for the sake of the audience, that this is a case where it's a bit tricky to take a decision. Where we're balancing benefit versus harm. I think
because you can be damned either ways.
Yes, either ways you can have a problem.
Because remodeling of the arteries, sometimes the remodeling of the arteries and the aneurysms growing very rapidly in children is not uncommon. One of the reasons why these fistulae are closed early is for that, because the remodeling of the arteries is huge.
And also I want to tell that if it is a end artery fistula like this, the aneurysmal segment is going to be a continuous process.
Absolutely.
If you close,
that is the point, I think, which justifies you doing it, Nageshwar, now.
Yeah.
Because you take another couple of years, this will become completely aneurysmal. Then the likelihood of thrombus is even higher. So by closing it now, you prevent subsequent dilatation. I think that may be a reasonable justification in doing it. But I have to say the jury is out. All of us are not sure. Let us be honest about it. Collectively, we have to acknowledge that this is a bit of a tricky situation. Kavita.
Yeah, I would agree with you, but maybe, wait a little longer for the child to get a little bigger.
Okay. All right. So I think, I still think it's a very well done job, Nageshwar. Device, truly multifunctional device, which you can put in a variety of situations. Good technique that you demonstrated that everybody can learn from. The point of making a wire, snaring the wire, but yet delivering from the artery, using a buddy wire, getting as distal as possible. All those things beautifully demonstrated, and great case. Thank you. Very well done.
Yes, sir. Thank you, sir. Thank you.
Thank you, Nageshwar.
Thank you, Kavita.
Thank you, Nageshwar. See you.
Thank you, Jay, Bharat sir, all. Okay.
Can we leave?
Yeah, I think we have finished with our session.
Can we move to Dr. Elvin presentation, please?
Hello? Hello, hello.
Doctor, we can hear you. You can
Yes.
start presenting and
Well, thank you for inviting me again. I would like to share with you some ideas about the combined use of FFR and OCT in clinical practice. My name is Selvin Katie. I'm an interventional cardiologist in Belgium and a professor in Poland. So the FFR concept evolution started with a deferred trial where non-ischemic lesions do well, that prove that non-ischemic lesions do well on optimal medical treatment. But although here, PCI patients had similar outcomes to the FFR-guided defer group. And the real concept of FFR started to get ground when, after the FAME trial, which showed that the PCI treatment of only ischemic lesions is better than PCI of all angiographic lesions. So basically, only when we went to study this, to do FFR assessment in multi-vessel, we saw a benefit, and that's where the FFR concept got ground. And then there was a transition of the concept of the FFR from a tool that defers to a tool that mandates revascularization with the FAME-2 trial, which showed that the revascularization of the FFR positive lesions was better than optimal medical treatment alone. But then again, we have to say that this was driven by the need of revascularization in about 20% of the patients. So basically, the FFR concept is a smarter way of revascularization that definitely reduces the need for PCI while reducing angina. However, as you could see here in the FAME-2 trial, the MACE was lower in the patients who had PCI, but this was driven mainly by the revascularizations, as you could see on the upper part of the screen, while death and myocardial infarction did not change. And this was not the only study that showed it, but a larger study that was based on treating the ischemic lesions also failed to reduce MACE for a primary outcome of cardiac death, myocardial hospitalization, myocardial infarction, and hospitalization for unstable angina, as well resuscitated cardiac arrest. But also here, we saw again that there is about 20% of the patients that will come and require revascularization in the group that had a optimal medical treatment arm. So how to interpret this 20% crossover? These patients that really need revascularization. And these are two types of patients: the ones who were severe already at the baseline with very severe ischemic lesions. And there was also patients who might have had intermediate lesions, but that had plaque progression and that were positive at FFR, that become FFR positive during the follow-up, but were negative at baseline. So if we look to the FAME-2 5 years result, we see though that on a longer follow-up there is a benefit in myocardial infarction, although also the patients that have PCI, they also have spontaneous myocardial infarctions, and there is, as you could see here, a reduction of about 30 to 35%. And the same thing, if we look on a long follow-up also for ischemia trial, also here we have exactly the same type of reduction. So it was 65, the hazard ratio was 65 in the FAME-2, and it's 0.67 here in the ischemia trial. So exactly the same amount of patients have it, but also the patients in the invasive group have myocardial infarction. So where do they come from? Are these coming from vulnerable lesions? And we look here that this is still something that happens also, as I said, in the invasive group, where we addressed all the ischemic lesions. So this remains an unaddressed issue for the moment. Now, if we look to what we know from the anatomopathologic studies, there is the progression is that we have a plaque that becomes vulnerable, it ruptures, it creates a thrombus, and this will either give an occult or overt acute coronary syndrome. If the blockage of the thrombus is not complete, the plaque will heal, and the healing of it will create a stenosis, and that's where the patient will have stable or crescendo angina eventually. And this is exactly when we will perform the FFR. And we know that if we perform an FFR, about 1/3 of the patients is positive and will go for revascularization, while 2/3 of them are negative and will be treated medically. So we know that medical treatment gives plaque stabilization. However, some of these lesions, they remain vulnerable plaques, and the prevalence of those is about 20 to 40%. Now, what is the relevance of it? And as I said, if we look to the pure maths, we say that 1/3 of the patients is positive and 2/3 is negative. So it means that 2/3 of these potential vulnerable plaques that could be in either positive or negative FFR lesions, so about 70% remains untreated. And that's exactly what we see also here. It's exactly this difference that we saw of about 30 to 35%. This is the unaddressed part of that could originate from vulnerable plaques. Now, how does this translate in the data that we have till now? We have a very nice study from a collaboration from Korea and Japan when they look to FFR positive and negative lesions and plaque vulnerability. And as you could see here, as I said, 1/3 of the FFRs will be positive and 2/3 of them will be negative. This is also what they found. And as you could see, there is a large number of vulnerable plaques or plaques with high risk, because this is a CT study, also in the FFR negative lesions. And of course, as the lesion becomes more ischemic, the higher the chance that the plaque will be vulnerable. However, in absolute numbers, how you could see here, also the FFR negative lesions will have vulnerable plaques that then remain unaddressed. So how do they behave? Of course, as I said, this is the prevalence of them, the incidence of these high plaques. But if we look to the totality of these plaques in the FFR negative, they are higher than in the FFR positive lesions. And indeed, as you could see here, the majority of the events during the follow-up comes from these high-risk plaques of FFR negative. So they have an event rate close to 50%, while the FFR negative plaques that have no high-risk features, they have a very benign outcome. And as you could see, this difference starts already to be noticed at 2 years and continues between 3, 4, and 5 years. Again, here, I'll show you that the majority of the events during the follow-up occurs from plaques that were FFR negative rather than from plaques that were treated. They were FFR positive and were treated. And these were plaques with high vulnerability features. Can we identify vulnerable plaque in the cath lab? Yes, we can. And actually, at the moment, the OCT is the only one who could really look to the thin cap fibroaderomas. And we had the chance to do in Europe the combined trial where I was a PI of. And we showed that actually these high vulnerable lesions, the TICFAs, they had a much higher rate of MACE than the rest of the FFR negative. So if you have a thin cap fibroaderoma and you have a FFR negative, you're still at high risk of having a future adverse event. And this, the primary endpoint was cardiac death, target vessel MI, clinically driven target revascularization, or hospitalization. So you could see here, it's a 5-fold event rate if you have a TICFA versus not. Is the combined the only study saying this? And I say no. because you could see clearly also the study from Takashi Kubo. He see that the lipidic plaques seen on OCT, especially the lipidic plaques in TICFA, they were the only ones that gave events during the follow-up in these patients. And he clearly showed that, of course, the lipidic plaques in general, they are higher, have a higher event rate than the patient, the event rate of having a new acute coronary syndrome than patients without a lipidic plaque, but particularly the thin cap fibroaderomas almost double the event rate. And if you have a lipid-rich plaque and a thin cap aderoma, then the event rate is clearly much higher in these patients, and is exactly what we also found in the combined trial. Now, coming back to where we started, what is the impact of these persisting inflammation vulnerable plaques? What is the relevance of it? What we also learned from the combined trial is that when the plaque ruptures, it's not that it heals and it becomes stable. You have a progression, longitudinal progression of these plaques, and within the same lesion, you can have a progression of atherosclerosis. So you could have TICFA on an old rupture plaque, a healed plaque, all within the same lesion. So there are some plaques where the inflammation persists, they could have a higher rate of events. And this what will, again, as shown from the combined and also the study from Dr. Kubo, this will give, again, a new acute coronary syndromes, either acute or overt, and that's where physiology alone is not enough and imaging should be considered. So the take-home message is that the FFR-guided revascularization significantly improves symptoms of angina, however, not sufficient for significant reduction in acute coronary syndromes, MIs, or mortality. And we know now that the lipid-rich plaques and TICFA lesions are at the high risk for future events independently from ischemia. And now the question is, we identified these lesions, so what to do with them? Should we treat these lesions? We do not. Should we put them on stronger medical treatment? We do not have this evidence yet, and that's where we should be looking in the future. Thank you.
Thank you, Elvin. You raised, we've heard you present the combined data earlier, and we understand that combining the two is always an advantage to have more than physiology, also having an imaging support. But practically, just seeing how much is imaging used all over the world and how much is physiology using all over the world, and to try and see whether we have answers for the large number of people who are out there getting MIs, it is not something which is truly practicable. It is not. So we still probably have to find better biomarkers or better non-invasive modalities by which we can supplement this information. Very truly, you've identified very well that the same unmet need exists in the FAME data as well as in the ischemia data set. And really, adding imaging would help us. And we also should understand that FFR is a continuous variable. We should not get around by just having a yardstick of 0.75 and 0.80 in our interpretation. So thank you very much for a very nice presentation. Ajit, would you like to say?
Yeah, okay. Hi.
Hi.
Can you hear me?
Yeah, very well.
Thanks, Anil. I hope you can, I hope you can see my slides. And my topic is basically on the wireless RFR in terms of simplifying physiology with the use of wireless RFR. And as Elvin correctly said, I think physiology is one part of intervention. I don't think it has always been a debate whether you see a lesion, whether you would like to treat it because you don't know the morphology of the lesion. And there's been, and that's a very gray zone when it comes to that. And as Anil said, I think we need more biochemical markers which tell us what lesions to treat under these circumstances. Having said that, with limitations that we have today, we know that we have to depend upon physiology in certain situations in multiple cell disease and on a different subset on imaging while doing our interventions. And the fact remains that when you do an angiogram, it only detects 5% of the total coronary tree. The rest of it is all in the microcirculation. A lot of it has to do with the smaller vessels also, which are not demonstrated on routine coronary angiography. FFR has been upgraded to a class 1A indication in the ESCPS guidelines, and most of us are aware that in terms of borderline lesions, this is probably the best way of deciding whether to treat or not to treat.
Dr. Ajit, can you
You
please
need to
share
upload your slide. Your screen has not started.
Sorry?
Your screen is not.
Oh, I'm sorry. It's not started?
No.
Oh, I'm sorry. I don't know what happened. One second. Give me a minute. Is it seen now? Can I see it now?
Yes, we can see it now.
Oh, sorry. Okay. I'm sorry. So FFR has been, again, this is the earlier slide, because the current evidence, as said, I think we all know that there are various trials which have demonstrated that there have been significantly lower MACE rates with FFR guided PCI as compared to routine angiography only PCI. And it's a mandate that FFR guidance of multivessel PCI should ideally become a routine practice if possible. But in multivessel disease, we had issues with giving adenosine to in multiple stages. So the issue, the thing that came up was the IFR, which is a Phillips patented ratio, which is basically found in the defined FAIR study, that it was equivalent to FFR. And by extrapolating that evidence, and by certain of the trials which have been used to compare RFR and IFR are significantly similar in performance, and the area under the curve remains the same. It also helps us in guiding treatment in infarct-related arteries in ACS patients, whether we should treat certain other vessels or treat only the infarct-related arteries, and this definitely has proven a boon to those patients. What is the benefit of non-hyperemic pressure ratios? One, of course, is that it can reduce the use of hyperemic agents, reducing procedural time, saving cost to a certain extent, not much in our settings. And that may also help to a wider adoption of physiologic lesion assessment, because the use of adenosine is in multiple vessels does push people back into not using it in some circumstances. The IFR basically believes on the fact that there is a wave-free interval, and that is where the lowest PDPA ratio exists. And this is normally averaged over 5 beats of data collection. And the clinical evidence on the use of the IFR has been with a defined flare, in which there was a 1:1 randomization to FFR guided revascularization, IFR guided revascularization with 3 groups in that subset, which basically was a trial which is powered for non-inferiority, and which showed that at the end of 2 years, IFR was equivalent to FFR. And it's non-inferior to FFR for MACE at 1 year, definitely. And the 2-year results also show that it is relatively quite a non-significant difference amongst the two. The limitations are that it assumes that the maximum flow and minimal resistance occurs during a fixed part of diastole, and historically requires ECG gating. So the newer modalities have done away with ECG gating, and you can still get an IFR without the ECG gating, specifically in the newer machines. The question that was raised was, should we look only in diastole, because the lowest PDPA ratio may be different and may exist somewhere else in the cycle, especially in some situations, it may exist in the late systole and early diastole. So thereby the concept of the resting full cycle ratio, flow ratio, which is basically an unbiased identification of the lowest PDPA in diastole or systole and independent of the ECG, and sensitive to small pressure changes during pullback. So it calculates the PDPA throughout the ratio and takes the lowest value throughout the ratio, depending on after using certain anti-noise filters. So this is the flow chart as to how it calculates the RFR, and the RFR is derived from the same aortic and distal coronary pressure signals used to calculate the current physiologic indices. There have been certain studies which clinically validate the RFR, and these are the list of all those tests, all those studies on RFR. And of course, the validated RFR study, which was basically a retrospective study of historical data from the Verified 2 and the IRIS FFR study of 651 RFR measurements made using the genuine IFR waveforms, and they studied the same data using the RFR signals. And they tested the diagnostic accuracy of RFR versus IFR. What it did show that was in terms of equivalence testing, the RFR is equivalent to IFR. And there was no significant difference in either of these two. And it's almost significant, similar in about 98% of these patients. There is significantly high accuracy, sensitivity, and specificity. The RFR distribution across the cardiac cycle was that in the right coronary artery, there was a certain amount of reduction in those heart cycles with RFR and diastole. And that was seen that occasionally in about 6% of patients, the RFR in the right coronary artery may be in late systole, which may be missed by the IFR. The revalidated RFR demonstrated the real world evidence that RFR is clinically and diagnostically equivalent to IFR. And in terms of all accuracy, all the points of accuracies, the diagnostic accuracy, sensitivity, specificity, PPV and the NPV is basically has remained the same. If you look at the prognostic performance in terms of deferred lesion failures, all resting indices, including the RFR and IFR, had similar outcomes in lesions deferred by any of these measures. And in the FFR French sub-study, it showed that again RFR and IFR have the same prognostic value in predicting MACE in 435 patients. The Illumine-1 plus predict analysis shows that RFR is accurate in about 94%, is 94% accurate versus FFR. When you use a gray zone of 0.86 to 0.93, and all of us know that below this point, you need to treat, above this point, you differ. And in between these two, it's always better to check using a FFR and compare it with the hybrid approach. The RFR is advantageous in that it does not have a direct connect to the machine. It has got a wireless interface. So basically you zero the guide wire by turning on the transmitter, and once it shows, once the transmitter function indicator displays a stable green light, when it is successfully zeroed, and the RFR snapshot kind of captures the lowest PDPA across 5 consecutive beats. Pullback option is definitely there. That's there in the IFR also, and the height of the step denotes the severity of the lesion in contributing to the functional significance of the lesion. And of course, you can use the same wire, the same system, change the mode, and measure the FFR, which is the same as in IFR also. Just a few things again. The question mark about the anatomy of the lesions and the substrate of the lesions still remains. But this is a gentleman who came with a acute coronary syndrome, and of course had a nearly totally occluded circumflex. LED lesion looked significant angiographically. We did not do any imaging in this patient, but we did a RFR in this patient. The RFR in the LED was 0.86. This is a pullback of the RFR in lesion 1, lesion 2. We did an FFR with 140 mics per kilogram per minute for almost 4.5 minutes of adenosine. We achieved maximum hyperemia with significant symptoms. The FFR was 0.82, so it is found prudent to leave this lesion alone. But being an LAD, we would definitely follow this lesion with regular stress test, and probably call the patient back in about 6 months for a repeat angiogram and image the lesion at that point of time. This was another gentleman with a positive stress test, having undergone an angioplasty about 5 years back for the distal circumflex. The distal circumflex tendon is occluded. The LED did not look majorly significant. The inferior wall, in the inferior-basal segment, and the inferior wall here is completely infarcted as far as the echo is concerned. It's akinetic and it is thinned out. So the question was, what do we do in these lesions? So we basically did a RFR to the lesion, and to our surprise, the RFR came as 0.73. So that decided that this is the pullback of the wire in the proximal, from the distal to the proximal. Multiple areas of changes in the pressures, and of course the ostial lesion was not very significant, but the proximal, but the mid LAD lesion is significant in terms of the RFR. The RFR was done for the circumflex. We did not infuse adenosine in this patient because this patient was an asthmatic. But the RFR here was 0.88, and again in a gray zone. So we decided that both the lesions would be treated, and we're given the options of treatment to the patient. And this is the last slide that I have. This again, a gentleman who came with a lateral wall MI, and lesions in all the vessels. This was basically we did a physiological assessment to the RCA and to the LAD. The RFRs came as 0.93, 0.92, did the FFRs. The FFR values, and I'm not showing it in this, but the FFR values in both these were 0.9, decided to treat these lesions medically. And we just treat the circumflex and converted a triple vessel disease into a single vessel angioplasty. And this is a 2-year follow-up on this patient to date. So basically what I would like to impart is that physiology is still the gold standard in treating and identifying ischemic potentials of lesions. And evolution of resting indices would make the process simpler and faster. But we would be happier if we had some more light on these resting indices and their contribution and their comparison with FFR and certain specific values that we can say that these values are normal, these values need to be investigated, these values can be left alone. And of course, wireless FFR is easier in handling the wire compared to the conductor pressure wire, though the Philips has improved its wire in the current systems. And of course, the 0.014 wire with the RFR pressure wire is a soft tip wire, and it can be used for a simple PCI too. Thank you very much, and I hope I was well in time. Thank you.
So great, Ajit. You've actually raised a lot of questions, and I hope Elvin is there. I think he's already moved out, but it would have been nice to hear his view, whether he would have liked to take your first case for a combined study and do maybe an OCT at the same index sitting itself. And I have only one question: that do you think that the pan cardiac cycle advantage of RFR over the other resting non-hyperemic indices confers a distinct advantage? Do you think we should test it? Is it applicable only to the right coronary artery, or should we test it in all the coronaries? And well, I still think that one step which probably Abbott has still got to do is to get automatic co-registration so that more precision PCI can be done with their system. And then they have an automatic co-registration for the OCT, and if you can get the same thing done even for the RFR, it will become a more robust system.
I think you're right. That's where they probably fall back on, because Philips already has its automatic co-registration for the IFR system. And though they say that there is a issue with the PDPA as far as the right coronary is concerned, I think they still require a lot of data to come out on this before we say that's the only reason why we do an RFR. Otherwise, there's little much to compare between RFR and an IFR as far as I'm concerned. I think like I said,
we were taught since first MBBS, we were taught that the left coronary artery fills only in diastole and the right coronary artery fills in systole and diastole. So, and here is a pan cardiac cycle technique which uses non-hyperemic pressure indices. So that's a good question, but I think we need to prove it.
But I mean, I'm going to ask you a question because I had a very funny patient where the RFR was 0.8 and the FFR was 0.92. I mean, I did multiple runs and I still got the same answer.
So here is the role for doing imaging, because you probably understand, because there are limitations for both hyperemic and non-hyperemic indices. It could be that there are a lot of variables and there are a lot of assumptions we make. There are a lot of mathematical assumptions at every stage. And so this is one place where we can figure it out, is by adding imaging or by actually using other things like CMR and IMR. I mean, I always say this in every meeting, but if you instill chilled saline and you put a standard PDCA wire and you connect a crocodile clip, if you see ST elevation, it is significant. So you don't need to have fancy gadgets and fancy devices. We've tested this out time and again. It correlates very well with a positive FFR or IFR. So it all depends on what you want to, how much time and energy you want to spend. Getting an insight, getting a passport and a visa is okay, but you still have to enter the country. So once you get that, do imaging, proceed to your work. So that's how most people would plan their workflows. But a great presentation, and it was good to see you.
Same here. Always good to see you. Thank you.
Right. So we move on. Saurabh.
Wanted a comment.
Yeah, Jay.
Ajay Swami here. So I think the elephant in the room is the microcirculation. There's a massive part of the circulation that we are not interrogating either with FFR or RFR. And I think that would account for a large number of the discordant readings that we get. And of course, another thing is the amount of myocardium that is kind of interrogated. I think the maximum discordance is seen in the proximal LED most of the time, assuming that the microvasculature is out of the picture. Just something small that we're working on for now.
So Ajay, look at his case, which had a subtotal right coronary artery occlusion, and I think that the LED positivity possibly came because there was a subtotal right coronary artery occlusion, and very truly that's why there is still place. I personally think the FFR has made life too simple. So if you are going to calculate the CMR and IMR, you're probably going to have less reason to dispute and use FFR, RFR, or any IFR, any of these as gold standard. Ashish, are you there?
Yeah, hey Anil, how are you? So great to see you.
Good to see you. Hey, you lost a lot of weight, man. What's it?
I've lost some weight, but it's all good.
You've been working out, huh?
No, just, managing this
pandemic.
Diabetic. So I'm a non-insulin dependent diabetic because of a strong family history. So on good treatment, I think I've lost some weight, some of it due to metformin and Jardiance, and then rest of it is working out. For sure.
All right.
Great to see you, and thanks for seeing everybody. I wish I could be there, and I wish we could go back to normalcy. So I think you guys have all brought it up and have laid out the stage perfectly for what I'm thinking is the next step. To make a diagnosis is one thing with a non-hyperemic pressure index, or with all the indices that Ajit presented, or even with the old-fashioned FFR. But the next game, the next step in the game, if you will, is to act, because I think that what we're missing is post-PCI assessment, and defined GPS is going to answer that, and because 20% of cases that have a PCI that we think is adequate angiographically, even if we've identified the right lesion by physiology, still is not a complete result. And patients have recurrent angina, and oftentimes we're perplexed as to why that is. And the bottom line is that I think we're not doing a good enough job. And I think hopefully this presentation sheds some light on how we can further perform precise PCI and improve outcomes, not just to pick up lesions that need to be treated, but use it iteratively during the case to help optimize your results. So let's start with the case. As you know, it's always the best learning opportunity. So this was a 58-year-old guy that was referred to me, about a couple of weeks ago, and he'd had previous intervention to his LED and circ in 2015. He underwent a myocardial ischemic perfusion scan, which is ischemic both in the LED and the inferior lateral walls. His ischemic mass on the LV was estimated to be 20% or so, his EF was 45. He undergoes coronary angiography at another facility. They referred him to surgery. The surgeon turns him down because he feels like he's got a poor LED target. And then he was referred to me for consideration for potential PCI options. So before that, I'm just going to show you the angiograms, the 3 angiograms, and then we can ask some questions and keep it sort of interactive. I'll ask Anil, and then Anil can sort of delegate the questions and see how other people would do things, since I don't have access to the names of the other members of the panel. So here you go. This is the AP column view. This is the LAO cranial view. And this is the right coronary artery. Okay, so we'll move on to what I would then consider, how would you approach this patient? He does have a diagonal artery CTO. Unfortunately, that doesn't really project as well in that LAO cranial, but believe me, he does. So how would you treat this guy is the question, right? I mean, nothing jumps out at you as being clearly ischemic. Nothing jumps out as severely narrowed angiographically. And so, Anil, what would you do?
Let's have Ajay. Ajay, well, how would you like to approach this?
So, Dr. Ashish, is it possible to look at the magnitude of ischemia in the various territories? you said you had a nuclear medicine scan that showed some percentage of reversal.
So it was 22% total of the LV mass. I
Right.
didn't have it broken
Distribution?
down.
Yeah, if you have a distribution, that might help us.
No, don't have that.
Right, then probably the next way to go would probably look at, the FFR of all the three vessels. I think the ripcord had shown that there's a significant discrepancy between the visual assessment angiographically and the functional assessment. And I would actually look at the options for revascularizing the diagonal, because that is a definite CTO, and probably begin the decision from there. It also appears to be gross microvascular disease. So, it's IMR is something that I'm fond of. It's possible to do. We'd actually like to. That's why I wanted to look at the nuclear medicine scan, because it will tell us a great deal about how much of the ischemia is distributed in which territory.
That's a great point. That's a great point. I mean, I think that the bottom line is, I think nobody here should be fooled into believing that this is intermediate disease all along. And that would be something that one would get tempted to do if you were just believing in angiography. And the bottom line is, I think that's a thing of the past. I think using
if you did not have a nuclear scan and you got this angiogram done, most of us would have put this patient up for medical management, for optimized medical therapy.
Exactly. I mean, that's fine. That's the challenge we run into every day. And look how high risk the scan is.
22% ischemia is actually a confounder. But anyway, I must say, I would love to have this interactive, but I've been just told by the organizers that the live cases are getting ready. So let's go on. We won't bug you too much.
Yeah. So in general, my principles of revascularization are as follows. I mean, I would want, when I revascularize patients, the goal is to get a residual syntax of less than 8, based on the syntax data that was clearly dichotomous at an 8. Obtain comparable results to surgery, we have to give up doing angiography-guided PCI alone. It is just not enough. And then combining anatomical and physiological surrogates is really important, but it requires multiple, not one, multiple IFR and IBIS measurements during the case. And then the beauty is, as interventionalists, we have the luxury of staging procedures. And the beauty is, that's the advantage over surgery, because we can use that and treat 2, 3 out of lesions at one time, and then bring back, for example, if you have lesions that are left behind, either due to considerations for contrast or for treating chronic total occlusions. So here's the way I approach this. We did a quick IFR of the right coronary. The IFR was completely normal, not surprising. The lesion doesn't look impressive at all. And I had the wire distally down in both the PDA and PL, just in case somebody felt like I was only assessing the proximal vessel. And once you got that squared away, then the big first question I looked at was the lesion in that first OM. The first OM was not even considered in the whole scheme of coronary revascularization with bypass surgery. But with PCI, we have the opportunity to take care of lesions, in some ways even do better than surgery when it comes to quality of life and symptom relief. Sure, taking care of a small OM is not going to impact his life expectancy. I mean, that's obviously hinges on left main LAD and proximal disease, but it can be pretty bothersome with angina. So bottom line is, make sure that you don't forget about vessels that look smaller than 2.5, because we have stents now with late losses of 0.1, 0.2 that allow you to treat lesions in the distal vasculature with comfort and with ease. And so here's a case where we initially now were treating a vessel that we thought was essentially untreatable with angioplasty other than with POBA or a drug-eluting balloon. But here we are deploying a 2.5 drug-eluting stent all the way into the distal OM. Again, it's really important to visualize this in 2 projections to make sure you have full balloon expansion, full stent expansion, because otherwise you're going to be left with a big problem. And here you go. The first OM now is completely revascularized. And now we're still focusing on that second OM. I typically will buddy wire with the IFR wire, put in IFR wire after I put in the workhorse wire, the idea being I can normalize in the aorta so that I don't invoke any false positives related to proximal disease within the left circ or even in the left main or LAD. And in this case, where is the significant lesion? You can't really tell. The only thing we know anatomically was 6 years ago, it had a stent in that distal OM just proximal to the radio-opaque marker within the wire. So on the right panel, you have both wires and you did an IFR pullback. The IFR was 0.87, which is positive, and the pullback is got a clear spike right distal to the previously implanted stent. And within the stent, it has that big spike. And you know that that's the problem. So this is what was missed on IVUS. So the same image using combination of anatomy and physiology here demonstrates that distal stent, this plaque distally, and boom, you have this. A clear example of an underexpanded stent within calcium. This was 6 years ago and is now positive. It probably was positive then. It was never assessed. And then proximal disease is all intermediate. So that was that focal underexpanded region within the stent all the way down right distally past that small dinky branch of that second obtuse marginal. Again, knowing what to do with an underexpanded stent is important. Luckily, we have lithoplasty now and could use that for management of in-stent restenosis from underexpansion within a calcified segment. Here it is, a 3.0 vessel fully expanded with a fresh stent implanted distally within plaque using the ultimate IVUS criteria as to where you would land it. And lo and behold, boom, here you go. You have the IFR is normalized now, but now you have some haziness proximal to where that lithoplasty balloon was. And you can see using intravascular ultrasound, we identified that there was a edge proximal dissection. And so I had to tack that up with a 3.5 fresh stent. And this is your result after getting both the proximal and distal stents and lithoplasty of the previously instented segment. And your IFR is now at least within the normal range at 0.93. So here's how you complete your assessment at the end of intervention. What about the LAD now? Similar situation. The LAD has a stent in the proximal segment, diffuse disease distally, and where do you start and where do you stop? And this question happens and is asked every single day. You also see that diagonal CTO on the right panel, which is a relatively small vessel with a non-ambiguous cap, but I don't see any distal filling. So I chose to leave that alone completely. I didn't think that was playing a role in what's going on. We managed the edge again using imaging. Clearly, the IFR was strongly positive. The image on intravascular ultrasound, in the interest of time, I'm not showing it, but had lesions both proximally and distally. The proximal lesion, using that MLD max algorithm that describes morphology, length, and reference vessel diameter for deciding pre-procedure outcomes, is 4 millimeters for proximal segment, 2.5 millimeters for the distal segment. The instented segment had a 3 and a 3.5 millimeter blood vessel that needed a lot of neointimal hyperplastic expansion with an NC balloon and a scoring balloon. And that's what that shows. Didn't really have any issues. Again, the pre-IFR was 0.8. The post-IFR was 1, demonstrating an acceptable outcome within the vessel. So the takeaway for me in 2021 is angiography-guided or IVUS-guided PCI is not enough. And the interesting thing is that post-PCI FFR is superior to even the residual syntax score of 8 that I quoted earlier in differentiating the risk of target vessel failure. And this comes from the post-PCI FFR registry, and clearly with a log rank p-value that was highly significant. So my takeaway is that some form of post-PCI physiology is absolutely mandatory. If you wanted to use a chart in your lab, this is a good chart to follow. I essentially would do a non-hyperemic pressure index after you finished. And if the results are acceptable, you're done. If the results are not, then usually the non-hyperemic pressure indices, for the reasons we mentioned earlier, are more susceptible to false positives and negatives related to the enhancement of flow after repeated balloon dilatations that you get as a reflex, as well as more susceptible to alterations from no reflow or situations like that, especially when atherectomy is used concurrently. In those circumstances, I think going to a FFR assessment is probably required. And then if the FFR assessment is adequate, then you're done. If the FFR assessment is inadequate, then it becomes the big elephant in the room as to whether there is focal disease or diffuse disease. Before we incriminate IMR as being the only issue related to unsatisfactory outcomes with PCI, we have to invoke the potential consideration of diffuse disease. And I think there's going to be a lot of work done in the next few years related to the delta FFR post-PCI in the segment that was treated versus that was left behind, to determine what percentage of the lesion ischemic burden comes from the lesion that was treated versus the rest of the artery that has what looks like intermediate disease. Or another way would
Ashish,
be
I would hate to
percentage.
interrupt you, but we are getting reminders that the live cases are ready. You've invoked some great points, and we all realize that one of the greatest studies that has come, which has made us think, is the defined PCI study, which tells us that 1/4 of patients that we take out after a PCI are probably not done enough. And you've made this point truly, truly eloquently. So we thank you for the time, for the consideration, and we'll now move on to Ajay. And Ajay, can you just make a quick presentation, because the organizers are telling me that the live cases are absolutely ready. Great case, Ashish, and great to see you present something other than CTOs.
All right, sounds good, buddy. Take care. See you around. Yeah, bye. Take care. Bye.
Okay, so I'm going to share my screen. It says host has disabled attendee screen sharing. So,
hey, listen, somebody get Dr.
I'm doing it. I'm doing it.
all right, so before I begin, my salutations to my teachers, some of whom I see on the panel and some of whom are not. If I can ever begin to share screen, which appears to be sometime in the near future. My topic is to look at null culprit vessel revascularization in a patient with STEMI.
So you're going to be all flowers, right? Okay.
Dr. J, you can share your screen now. Can you try?
This is Dr. Swami here, and I still can't share my screen. Saurabh?
There's an access been already given, Dr. J.
I don't see it. I keep clicking on share screen. It says host disabled attendee screen sharing.
Give me a minute.
I've stopped screen sharing on my side, so
No,
it's not my fault.
your fault. It's not your fault. These are presenter rights to be given. He must have been included. I mean, he must have joined as a panel, as a attendee, not as a panelist. I hope you clicked on the.
Can you try now, Mr. Ajay? Mr. Swami?
Nope.
Because I didn't change any settings.
Otherwise, what you can do is you can just sign off and sign in again with the link that Srinivas.
So we have to start with Dr. Kirti first.
All right, Kirti.
Dr. Kirti, you're on mute.
You seem to be good in the waiting process.
We've got everybody in waiting. That's the best part. so this is.
I could have completed my talk.
Yeah, you could have. I'm so sorry.
That's right, Ashish.
Several centers
So
of
hard
excellence,
feelings,
and one such which I can highlight is cardiology, and in specific our cath lab. We are the only cath lab facility in the country having
Saurabh, can you hear me?
end-to-end equipment and devices, and on the top of it, the best of the cardiologists are associated with our hospital. Thank you.
Good afternoon, colleagues. It's indeed a pleasure to meet you from the Bridge Candy Hospital in Mumbai. I wish this particular process and its live telecast great success, and we hope to remain in touch, bringing to you from the Bridge Candy Hospital innovations and improvements in the space of healthcare. Thank you, all of you.
Bridge Candy Hospital Trust is 213-bedded NABH accredited multi-speciality hospital. The specialists on this hospital panel of doctors include some of the most distinguished names in the Indian medical profession. Thank you.
Hello.
Hi, Kirti.
Hey, Anil, how are you?
All good. We've been waiting for your case. We had to put Ajay on hold. So
Oh,
Ajay,
man.
there's going to be an introduction of the cases. Then we're going to go back to your talk. So just be a little patient.
All right, sounds good. No problem.
Ajay, I'm so sorry to do this to you, but may I start? I just want to, this is the first time we're going live from Bridge Candy Hospital into a major conference like this, and I thank Srinivas Kumar, the TCT, to have me. And it is so comforting to have people like Ajay around there, Anil, you on the dais, and all the others.
Oh, you've got a lot of friends. You've got Ajit, you've got Ashish Prasad, you've got a lot of people here.
I know, and
All
I'm
your
blessed.
friends.
I'm blessed. And let me introduce you to some of my absolutely amazing staff, without whom I am almost nothing in the cath lab. To my right is my nurse, whose name is Jeenu, and she's been ours for many years, and she can independently just set up just about any device you want in the cath lab within 60 seconds or maybe 120.
Don't let the secrets out. People will come and steal her.
I want you to, our head technician is Dennis, who is absolutely amazing. Sagar and Ram, one of them is missing, Akash. We don't take any industry help in this cath lab for any devices, right from Impella to whatever. We're a very self-sufficient cath lab. Today we have also the presence of Sagar. Then my anesthetist who's there with me, the cardiac anesthetist, Dr. Sharmila Nair. Thank you to her. And so with that, let me just introduce my case, if I can have the first slide. In June last year, our gentleman, presented with 81 years old, presented with unstable symptoms, with very debilitating angina. And in the past 20 years ago, I had looked after him when I was at Bombay Hospital, and he had come with an acute coronary syndrome, and I'd done an angioplasty to the right coronary artery and put in a stent in the proximal LAD. And we put in those, I don't know if you still remember, we put in those bare metal stents, which I can't even remember the name of right now. The ejection fraction at that time was 45%, inferolateral hypokinesia, fairly well preserved LV thickness, and he's hypertensive. And go to the next slide, please. This is the picture of his left coronary artery. Can you appreciate the angio there? The left main looks great. It's slightly on the longish side. Then there's this one large circumflex branch which comes out. And the ostium of that circumflex looks pretty much impeded around, to me, appeared 80% narrowed. It gives out a very early branch OM, and then that atrial branch, and then is diffusely diseased. We'll show you our current pictures as well. Go to the next slide, please. Next. This is his left coronary artery, left angio in the areocranial and the areocaudal view. You can see that retroflex takeoff of that circumflex, which looks diseased. Just after that ongoing circ in the mid segment, you can see there's a little more disease in that OM branch. But the LAD, there's a moderate sized diagonal which is diseased, but the flow is well preserved there. In the areocaudal view, it appears that there is something beyond that septal branch in the LAD which looks hazy. And just between that septal and the diagonal, that's where the stent is, the previous stent is. There's a little bit of a narrowing there. I'd love to get a view on what we should do. Next. So last year when he came, and this was his right coronary artery, which is totally occluded, calcified over a long segment. We ended up doing an angioplasty to that. That time it was a pretty long procedure, around almost lasted us 2.5 hours. We went antegrade, and we were able to put in 2 stents, a 3/48 and a 3.5/28 Science Expedition at that time. And we wanted to stage the circumflex for a later date. So we staged it for a little later date. And let me go ahead. Yeah. So this time he had recurrence of symptoms starting from June 2021 now, last month. He's had a few episodes of angina, very much like the symptoms in the past. His echo is almost preserved, was done this morning. That's his ECG there. And you can see the vitals, his hemoglobin, his creatinine, BNP, everything's there for you. Our plan was to review the right result and then, if required, proceed to a PCR of the circumflex ostium, do an FFR evaluation of the LAD, and then decide. And based on imaging, we'll decide whether we need to go and how. Let's do the, what do you think? Is that a good plan or?
Yeah, I think you would have done the imaging by now. I mean, you would have done at least the angiogram. So let's see today's angiogram.
Let's play the angiogram.
Then we can refine we can get an idea of your plan.
Can you see my screen?
No, not really. We can see you.
Yeah,
now we can see.
Yes. So that is that's my angio from today. You can see the right coronary artery looks fairly good.
Yeah.
A little bit of a narrowing down there.
That's okay.
Yeah. And next. So when I look at this view, I kind of come to think that in that one frame, that right looks a little narrower than I'd like it to be. There's a very good bifurcating PDA, and there's a large branching PL branch, which are all looking quite good. The rest of the RCA has some plaque, but nothing major to write home about. Would agree, all of you?
Yeah, so this is a focal ISR.
Focal ISR, yes. And now the left side, please. So we go to the left side, and that's the left main again, and you can see that tight narrowing there. Can you see that tight narrowing? Right at the
but your LAD ostium suddenly appears much better than what it was in your diagnostics done previously.
Exactly. So that's why this angio again, right? So you know, everybody has to. That's why. That's with a diagnostic catheter. This is a guide catheter. You've given a little bit of vasodilators, and they all look good. So that's the next picture there, please. Right, and the next. And that's my stent from 20 years ago, where just up next to the diagonal branch, I pinched that diagonal branch, and that has remained pinched ever since. I have the 20-year-old angiogram with me as well on my laptop, but it is exactly the way it was from then. So what do you think, guys? What should I go ahead and what should I do?
I do not know what the vote is. I'm sure that everybody's going to say, let's do a functional assessment, even for the right, do imaging, assess whether the restenosis is biological or physical, treat it, come back to the left system, do a functional assessment, because frankly, this angiogram itself may not really, OMT may be a very good choice. If you are done with treating the right, you may be over in the case very fast if your functional assessment turns out to be a negative in both the LAD and circumflex, because the tightest appearing lesion appears to be in the diagonal, which you say you left this way 20 years ago.
Absolutely.
What do you say, Ajay?
Couldn't improve on that.
Ashish?
No, I mean, I think, Kirti, you'll be surprised. I'm actually going to take the contrarian view. I'm thinking that ostial circumflex, although you haven't really imaged it in the multiple views that the patient presented with the ACS.
Yes.
And I have a feeling that when you IFR it or FFR it is going to be positive.
Okay.
And then that changes the whole game, because the angle of the left main bifurcation is not obtuse, it's fairly acute. And yes, the disease in the ostium of the LAD is not dramatically appetizing angiographically, but I promise there's going to be a carinal shift, the left LAD. I'm thinking you're all in. You're going to end up doing a bifurcating distal left main in this guy. And that's my take after you get
you would agree, Ashish, that the functional assessment will decide that, right? So the
No, I
physiology
think more the
will
functional
indicate.
assessment of the circumflex will decide
Yes,
that.
yes, yes,
But I wouldn't
definitely.
stop at doing just the functional assessment of the circ. I would also IFR the LAD. Don't be fooled, because when you have plaque within the ostium of the circ, remember, it usually affects
We know, and Akiko's data, we know that.
Yes.
We know that. Yeah. So
yeah,
we
so
know
it's
that.
got to be, I think you got to image both and then decide.
Anand, your comments?
Sorry, I
Okay, then we'll take
I
you
just
later.
joined. I just
Okay,
joined.
we'll take you later then, because we have. So Kirti, this is what we have to say, and if it's okay with you, you go ahead and do your functional assessment of the right and then the left, and we'll join you back. In the meantime, we'll take a
So
tour to
do
the other lab.
you want me to complete this assessment and then let you go, so that you can then, if at all you need to, you can always come back, or should I?
All right.
Would it make sense, or what do you want?
Have you already done the?
I'll be happy for you to go and come back. I mean, how long will you take to come back? That's all.
Okay, you show us the functional assessment, then we can.
Okay.
We
So
will be actually most interested in the functional assessment of the left system, but,
Okay, great.
that is going to be possibly not going to be the first thing that you do.
Okay, so this is what we did, and I just want to make sure that I save time for all of you, and I'm going to tell you exactly what I did. So what we did was we wired that right coronary artery, and the one slide that I think Jasmine didn't put up was in February of this year, and we can put that up for you. In February of this year, because we were originally we'd done the RC angioplasty, and we were planning to stage his left main bifurcation lesion at some time earlier this year, like March. So in February, we actually did a nuclear stress imaging, and that turned out, gave us a surprise, and it had a fixed defect a little bit in the inferior leads, but no reversibility was demonstrated at that time. And the ejection fraction was pretty much very on lines with what the echo showed. So that allowed us to keep him on medical therapy for a long time till he got back. So we had that little thing in the back of our head that after having opened the right, his functional study was normal. So we didn't want to just jump into this. So when he had this angina pain again, I was quite convinced that his angina is coming from this ISR of this right coronary artery. So we did an OCT, and I'm going to play you the OCT of the right coronary artery. Are you able to see, and can you see the nuclear stress imaging from Feb of 2021?
Yes. But all interventionists are going to be more keen to look at the
excellent. So
imaging
let's switch to this to our OCT, please. And this was our OCT, and if you realize, I mean, what we've done is we've looked at the entire stent, and the entire stent looks okay. There's a fair bit, a little bit of endothelium. It's endothelialized just partially, but almost completely. But that one area which was left over there, and I'm going to show you what I found actually. Let's go back to the area of interest and show them the tightest area. We made some measurements, and at that one spot, if I look at that one spot, see what happened to, this was a 3.0 stent that we put in. We took a 3.0 balloon and went up to 18 atmospheres last time. And if you show them the stent diameter, take a stent diameter, take a length from the strut to the strut at that spot. Over here, it is around 2.5, but at the tightest spot, go to the tightest spot. It's around 2.2. Now come back proximally to 22. Yeah, that area. Now do the struts over there, please.
2.7.
So this was a very well expanded. We had expanded it to 3.2 almost everywhere and 3.0, but that distal remained that one spot. Somehow we missed it, or what, we had not expanded it. And you know how the theme is, like you don't expand one little spot and it comes back. Go back to that area of interest, that small area. So if you look at that small area, you can see there's layered neointimal layered plaque, which is a very characteristic.
So this is layered neointimal hyperplasia.
Absolutely.
So Elvin, you're here. We can. I thought you had left us. So maybe some comments from you, Elvin.
No, I see this. and it's very nice. And then I have to say, it's a beautiful case because you have ischemia, you have lesions, you have OCT, you have stress test. So we can discuss a lot about it.
Yes.
But at this focal point, it looks like I had the impression that can you go a bit back more? If you
just go back and forth a little
this
bit
is
so that Elvin
few
can see it?
instant restenosis, but it looks to me that there was still some underexpansion due to some calcifications under there.
Absolutely.
And that's what can trigger the early calcification. And most of the time what we see is that, okay, we put a stent, but when we dilate these lesions, there is some harder plaque rupture at that point. So that will also create some thrombus, which by healing creates also the first layer of the restenosis. So it could be both.
Stop that. What do you think is that little shadow at 10 o'clock? Can you see that? Behind my lumen, behind my, right there. No, inside. You know, that little dark shadow just between behind the layers, between the strut and the intima.
Yeah. I mean, I'm looking here and I don't see it as big as you, but
yeah. I mean, I guess,
but it looks like
areas. So would you call it layered new intimal hyperplasia?
No, I think it's vascularity within the plaque, I think, and these are vessels in the plaque that you can see, and it almost
but
indicates.
It looks like you have two stents. It's not an overlapping of the stents. It looks like you have.
There's one area of stent over here. There's one layer of stent. We had taken a 48 millimeter stent. And if you go back 48 millimeters, which is right, you can see the overlap. Go right to that 50 mark and you see the overlapping right over there. Can you see the overlapping starts over here at this point? So this is not the area. This is the far distal end. It's in the, whatever has happened in the last 10 millimeters of my previous stent.
Here.
Come back to the area of interest. So I think this is neo vessels happening in the plaque, and it is an indication of a complication of that plaque which has happened, and that's what made him symptomatic probably at some stage. But I'm just guessing, Elvin. What do you think?
No, yes, it is, and absolutely, and that's why this is what we see often when we do open CTOs. You have perfect result, and at a certain point, you have sometimes, and I have it very often, focal spots of restenosis, which are very easily dealable. And let me guess, if you do FFR here, will probably even be negative. But despite being negative, you still have to treat it because this will progress.
Exactly. So I did not think it was of any value to do an FFR in this because he had angina, and the angina was relieved when I opened the RCA. Now he has angina, which is classical, and we've got an ISR lesion, which is likely to progress with this layered, with the layered area and the complicated plaque. So I thought it was best to treat it. And Sagar, can I go next, please?
Yeah, please.
Let us go back to the angio. So here is, go back. Yeah, now show them the angio. Where we started.
Sorry, I was stuck in the other hall. I think everything is going fine. Please go ahead.
Yeah, okay, great. So we did this also. Go next. Don't leave this place. Okay, so we took in a cutting balloon. That is a 3.0 by 6 cutting balloon because our stent was 3.0. So we took in a cutting balloon and we went in. Go up next. This is at.
Why cutting balloon? It doesn't look like it's very, very tough.
This is at
12. Why not
trying
a normal balloon first?
So this is a 14 atmospheres. This is at 14 atmospheres. This is a Wolverine, and it's still seen that just at 14, between 12 and 14, it gave way. So Elvin, this is what I thought, and correct me if I'm wrong, but when I have these focal stenosis, I like to use the Flextome or the Wolverine because it's the only balloon which is 6 millimeters, which is not going to ping pong when I'm inflating it and damage intima beyond and before. And it stays in place. I can see it. It works well. And at 18, show me the expanded balloon, please. Go next. We went up to 18 atmospheres and expanded that completely. It looked like it's well expanded. There, it's completely expanded now. Next, go next. And this is our little fluoroscopy. We did a high resolution fluoroscopy. We did a stent boost, and we could realize that we've actually got an area. And the reason we did the stent boost is because all of you, I would love to have your opinions. When we do these CTOs and we do these calcified arteries, we can fracture the stent sometimes because of calcium and whatever. So I just wanted to establish continuity of that stent area. And it looked like there was no fracture, no distortion, nothing. It was just an underexpanded area. So we expanded it. Then we went back and if you can see the OCT now, it was a 12 millimeter narrowing that we had seen. And therefore, can you see the next thing? Go ahead next. We've taken a guidezilla all the way down and we're positioning that right over there at the right spot, which was one strut from the distal end of the stent, which is what my OCT told me. So I positioned it exactly one strut inside with my guidezilla there for me to be able to manipulate, withdrew my guidezilla, dilated it. Go next. Go next. Go next. This is my stent going up. What pressure did we go to, please? For the stent, we went up to 12, I think 12 or 14. And that's it, going up there. Next. Next. We took in a shorter balloon. Next. This is a high pressure balloon. Go ahead. Next. Went up and dilated it to a high pressure. Next. Kept our guidezilla part there and did an OCT with that so that we could limit our contrast. Go ahead, show me the next OCT run, please. Can we get the OCT on screen, please? So this is our OCT run post stent. Can we identify the area of interest?
Yeah.
And when we looked at it, and when we look at it, we see that we've almost got an 85% expansion at that site. And our distal, both our edges on both ends of this new stent are looking quite good. And we've not done much to damage any intima there on either side. We've expanded it well. And I thought that this was reasonable to leave it at this point because I've established it. I mean, and this is a very pointed focal angioplasty to this area of interest. And
would you have considered using a drug-eluting balloon instead of an additional drug-eluting stent here?
Yes, I debated that, and for two reasons. I mean, when I look at the data, I still am convinced that for this guy is 81, 82 years old. The last thing I want to do is have him come back, and I somehow have a lot of confidence in a new stent in this area, and we're only in the second layer of stent, and I think a stent is better than a drug-eluting balloon as far as I could be wrong.
I think third time if they come, I think we can consider.
Yes, I think so. I think so.
That's a little arbitrary, Srinivas.
But how Kirti is doing, it doesn't happen to him. Don't worry.
Yeah, Kirti's done it the first time.
I don't want this man to ever have to come back to me, okay? And that's the whole idea. So let's go ahead. So we got a great result. Kelvin, Anil, Srinivas, you're happy with that result? You'll assign that OCT?
Yes, I would have put it a stent too.
All right. No, so would I have, but it's a matter of discussion.
Excellent. Right. So now we go to the left side. So before we went to the left side, it is very important that every time we do a left main, I do a left ventricular end diastolic pressure. And my left ventricular end diastolic pressure at this time was around 12, between 10 and 12 millimeters of mercury. This is a very important step. It is almost a habit before we do any left main to kind of recognize this, especially when the LV function is slightly on the lower side and he's 82 years old. So it was perfectly okay for us to use OCT if we have to now, because otherwise I would switch to IVUS. Next. Next. As I said, this is my FFR wire going into the LED. Go next.
You have shown already the baseline angiographic pictures. Go ahead.
Yeah. So this is our FFR. Shows the FFR of the LED. Any bets? Kelvin, you owe me dinner because I'm going to show you what we found. LED FFR.
We can take wagers still. I think the FFR is going to be 1. So especially with the proximal LED.
This is the RFR 92 in the LED. Go next. Go show me the FFR. This is the resting PDPA. And show me the FFR of the LED, 0.88. Go to the next image. It's better where we come back to the neutrality. Yeah. Yeah. Can you see this? This is my LED pull back from the LED into the left main, and you can see that it comes back to a unity of 1. And this is 0.89 after 120 seconds of adenosine given intravenous at 140 micrograms from a large bore. So then we moved on to, we said if this is very important, because having got this, if I had to do the circ, it really changes my perspective, because my circ becomes a very simple lesion to do. I would do a rotablator into that circumflex and put a stent from the circ into the left main and finish it off. So I said, let me just do an FFR of that circ as well. Next. And we did the same. Go ahead, next. So we had an angio showed that there was a lesion downstream as well. So we went and took the entire, go all the way down, please. Yeah, there. And this is my next, go next. On the FFR, so this is my FFR on the circumflex, 0.88.
So, Elvin, would you like to combine an imaging here?
Not when we are 82 years old. If
No,
we are
I wouldn't
42,
either.
maybe yes.
Yes, I wouldn't either. But here we are actually relieved that we don't have to treat this osteal circumflex. Because if we did, we would have to make it into a very complex procedure.
Well, I would have bet it was positive, but
yeah, it's
on angiography.
I know Ashish and Elvin can just pay me my wager later, but I think we have an 82-year-old and we are looking at functionality. It is important to understand that last time when we opened his RCA, he was completely without symptoms for a while, and then he had symptoms again, and we had an intervening nuclear stress imaging which did not show reversibility. And then for this complex PCI, I need enough on my hand to go ahead and do that complex PCI. And if I had an FFR which was significant, which is mortality changing FFR, yes, this person required an angioplasty, and I was ready to go ahead and do the entire complete 9 yards. But I think at this point, the lesson I'm trying to convey is that it is okay. We need to use technology to make sure we do the right thing for the patient. And for me, I think this patient is, Anil, as you mentioned, should be on medical management beyond this point.
Only one question after all this. Do you think you should extrapolate the defined PCI and also check the functional assessment of the right, since your FFR wire is already open?
I think he's already come to the left, sir. Let us go now.
I wouldn't. Srinivas is more hassle because the other team is waiting on the other side.
No, I think you tell us.
I was just making an academic point.
I wouldn't mind doing it at any point in time, but I wouldn't do it in an 82-year-old. Every time you instrument.
Right. I think you've done a great job.
Every time you instrument an artery, remember, you can do many things wrong. You could.
You made a seemingly very, very complex case look so eloquent and so simple. So that's the art of PCI, of modern precision PCI, that sometimes what we are worried about, we need not be, because divinity does not want you to enter there. So it's okay.
Thank you, sir.
I know you would have done a great job if that circumflex had been positive and that LED been positive, and you would have shown us some fancy gadgets and devices. But I think it's better for the patient. What do you say, Elvin?
Absolutely. I think I cannot add more to your comment. It's a perfect case where this imaging and physiology helps are doing a simple job.
Yes, I think so. And we should use it liberally and generously to make sure that we're making the right decisions in the cath lab, I think.
So, Iti, I'm going to thank you, and because I can see Srinivas is looking very anxious. He's got a team waiting in Apollo. So we're going to thank you for a great case. Thank you very much.
Anil sir, before he closes, one specialty of this person, what I have noticed is, when we do cases, we have juniors, other colleagues around. This man does with one sister besides, and some people others.
I can tell you that I'm a little bit involved. If I did not have to do an RT-PCR, I would have been there with them today. But all the same, yes, it is a point that he does it all alone. That's correct.
But it is quite commendable. But other point which he makes sure is the preparation of the patient prior to taking for sick patients. Like he always told me, he should consider left main PCIs and doing complex scenarios like almost equivalent to CABG, and we should prepare the patient well to avoid complications on the table. He was stressing about LV, EDP, which was normal, and doing anything complex, it always helps to prepare the patient properly and do a good job on table. Otherwise, sometimes doing complicated procedures, you land in trouble. And congratulations, Kirti, for showing an excellent case of ISR and how to tackle it in imaging. We wish we could have seen the other one also, but many times what is good for the patient, that's what is the top priority. Thanks for, he took special permission from Breach Candy and made this possible for TCT transmission. Thank you.
And Srinivas, I wanted to say one thing. I just want to say one thing. You know, my girls, Ginu and Jinxie, both are just equivalent to any fellow that you could have anywhere in the world. They are so good. They're like my right hand in the cath lab. And of course, my eyes and ears are my technicians over there who are just absolutely amazing. You know, before I can get on to anything, they're up with the IBIS images, they're up with the OCT images, they've already got everything on screen, which is amazing. And I must, before I close, I must thank Abbott for really supporting me through this. I must say thank you to everybody in Bridge Candy Hospital, because you have no idea, to do the first live case ever from this cath lab, it was actually, it was like a tsunami going in here and there, and we had to face it all. But Srinivas was so rock solid with me, and I wanted to kind of thank you. Srinivas, thank you so much for having me.
Thank you. It's an honor to have you. Thank you, sir. Thank you for making it possible.
Thank you.
Yes.
Yes.
We'll move to the Kolkata.
Thanks a lot, guys.
Thank you.
Bye, bye, Kitty.
Bye.
Dr. Srinivas, Dr. Rajesh Swami here.
Yeah.
Do you think we'll have time?
Are we moving to Kolkata?
Srinivas, Ajay has to give his talk because we moved to Mumbai because the cases were ready.
Okay.
So
we
had actually hoped that we would just introduce the cases and come to Ajay's talk.
Yeah, just let me.
Hello.
Yeah, go ahead.
Hi, can you hear us?
Yeah.
Yeah, so we were waiting for you all to come back and we had kept a lot of work pending. So just to start with the case here, just introduce my team here. I'm Dr. Aftab and this is Dr. Bikash Majumdar. He's a senior colleague of mine. We also have two more senior colleagues of mine, Dr. PC Mondal and Dr. Devashish Ghosh. And of course, not to mention the cath lab team led by Bala Subramaniam. And of course, there's the anesthetist, Dr. Devashish Panigrahi, and our two nursing staffs, Mampi and Polan. So this is a case that we thought we should discuss here. And can I see the first screen, please? The first slide. So this is a 71 years old lady. She's been a poorly controlled diabetic and a long-standing hypertensive. She's had an angioplasty to her circumflex and her OM done way back in 2008. Unfortunately, over the last 12 years, she has no data or no procedural details of the same. She used to have this angina on of what we normally now label as chronic coronary syndrome. But now, since the last few weeks or last few months, in fact, her symptoms had worsened. And she was now having crescendo angina and even rest episodes, which were interfering with her activities of daily life. Her labs were pretty normal. Her echo was normal. Troponin was negative. Renal function is normal. And she underwent an angiogram here with us 3 days back. Next slide. Are you able to see the angiogram there?
Hello?
Yeah.
Yes.
Yeah. So you can see that this is a left dominant circulation. And you can see the two stents there. Now the ramus stent looks patent, but there's some mild in-stent restenosis. The circumflex stent shows a total ISR. And there's a critical lesion in the proximal part of the LAD. And it's a pretty calcified aorta. I don't want to understand, I mean, I don't know if you can see, there's a porcelain aorta there. You can see the outline of the aorta there in the angiogram. Next slide. And this is the other view also, showing that the LAD is pretty calcific in its entire course, right from the proximal and the mid part. And this is a left dominant circulation. Next. The circumflex, it's totally, there's an in-stent restenosis, and there are intracoronary collaterals filling from the same side, the homocollaterals which are there, which fill up almost till the distal part of the stent. So we had a heart team approach, and the surgical opinion was that they would be able to put a graft to the LAD But because of the porcelain aorta, they said that they would not put in any venous grafts. And the patient, of course, refused CABG at her age, and she was absolutely unwilling to go for a procedure of a surgical procedure. We had to make sure that we at least did what was decided by the surgeon, that is to put in at least open up the LAD. But if we could also open up the circumflex, that would become an additional bonus for her. We were, of course, counseled against the long-term restenosis rates, and of course the cost and the risks involved during the procedure also. So I'd like your comments upon how the approach that we would take for this case.
Dr. Anil? Anand? You're muted. Anil, you're muted? Yeah.
Yeah, so I think you've had a hard team going in already into decision making, and the patient with a porcelain aorta is not keen for a surgical revascularization. We would say imaging and physiology guided PCI would be an answer.
Although Anil, this is Ashish here, Srinivas. So
yeah,
this is now left dominant system, porcelain aorta. We have to go back to what Kirti said in the previous presentation. Planning is everything. So before we get started, you need an ED. You first got to decide access, radial versus femoral. You got to decide EDP assessment, contralateral groin, if you want to make sure you have a 5 French sheath, and if you're planning to decide that you need support, impella versus balloon pump, all of these things have to be planned before you walk into a case like this. Otherwise, this is a disaster waiting to happen. And I just feel like that has to be emphasized. And in the Optimum clinical trial, which was done, and we are pending results, where Dave Kenzari and Ajay were national PIs, and we contributed a ton of patients. That's a specific trial that looked at patients who were surgically turned down for PCI and underwent PCI for whatever reason. And I can tell you off the cuff that the outcomes in surgically turned down patients for whatever reason are a lot worse than patients who are not surgically turned down. So when patients get surgically turned down, they get turned down either for comorbidities like renal function, liver function, end-stage renal disease, extra. But there are also other reasons, for example, that make them surgically difficult, like a porcelain aorta, for example. The patient has normal renal function, normal liver function, normal LVEF, but they just technically cannot perform surgery. Even in those patients, for whatever reason, high-risk PCI carries higher procedural morbidity and mortality when you compare that to the STS predicted risk, and it's independent of their syntax score. So it's important to know that.
Yeah, those are great learning points, and I think this is what we do each time. Just to recapitulate, we did it during the angiogram. The ETP was 18. Of course, we needed to make sure that this was done at the time of the procedure. The creatinine levels were normal, no overt bleeds, and of course, we had a discussion with the patient in a heart team approach. And so the plan today, this is the plan. Can I see the next slide? So the next, our plan was, of course, to take a bilateral access. So we went femoral because we knew that there's a lot of work that needed to be done in this case. One of the access was for, of course, the intervention, and the other was to keep for hemodynamic support if needed. We had the venous line also ready. We have an anesthetist at the head end who's there to support us in case there's a need to shift to an anesthesia, to general anesthesia. So the plan here was to wire the LED and, of course, make sure that we try and open up the in-stent restenosis of the circumflex first. Once we do that, and if you're able to achieve that, the intention was then to do a debulking with a cutting balloon. Now the stent in the LED, in the circumflex, seems to extend up to the proximal part of the circumflex, but does not seem to extend up to the ostium of the circumflex. And therefore, the intention was to do an OCT or an imaging in the LED and look at the ostium of the circumflex. And of course, if you open up the circumflex to image it from within the circumflex also, the calcium in the LED is diffused right from the proximal to the mid part also. And therefore, the thought was that we would probably put less stents, the better. And with the mid LED, we could get away with a physiology to tell us that we didn't need to do anything. We'd probably want to leave it without a stent there. we would have to have all the armament for dealing with calcium, including cutting balloons, high pressure balloons, and intravascular lithotripsy. The intention would be that if at all the ostium of the circumflex is clear, to avoid putting a stent there and get away with a DAB, and if at all stent the left main from the LAD. And there's an OM which is, or the ramus or the high OM, which hopefully should not get compromised. But in case there's a compromise, we are ready to do a final triple kiss with 2 guides and 3 balloons. So this is what our plan was, and this is how we proceeded. So we've done some work till now, and can we go to the screen and show them? So please feel free to interrupt and ask us and guide us whenever you feel there's a need. So this was a 7 French EBU that we started with. But again, go next. This is with a micro catheter and a Gaia's first. This did not seem to make any headway, and therefore I changed over to an Amplats. Now, what is important also is to understand that the left main is, the entire aorta is calcific. And once it's handling an Amplats, one has to be very careful that one does not end up causing a dissection. And gentle guide handling is the key here. So they switched over to an Amplats AL.7, and with the help of Corset and with a Conquest Pro, I managed to make up entry into the proximal cap. Quickly switched over from a Corset Pro, Conquest Pro to a Gaia first. Next. This is the Conquest Pro, and the wire is now exchanged. And this is the Gaia first, through which we managed to enter into the distal true lumen. Next. So then this we did a wire trap and removed the Conquest Pro, and then managed to, with a Guidezilla guided balloon, managed to dilate the proximal part of the stent. Next. So this is a small balloon, a 1.1 balloon. Next. Next. Yeah. So this is how the circumflex could be tackled. And then we did an imaging in the circumflex. So this is a wire exchange from the Gaia into a Grand Slam wire. And then a debulking was done with a Wolverine balloon. This was actually a non-compliant balloon first, and then a Wolverine balloon. So this was a 3O balloon. We went up to almost 18 atmospheres with this. There was some sort of spasm in the distal part, which did not give away despite use of a lot of intracoronary nitrates. And eventually we could do an angiogram, OCT imaging in the circumflex. So my colleague Bikash would just show us the OCT images.
So we did that OCT, the circumflex, and you can see it's coming from the distal to the proximal part of the circumflex. And the idea was to see how the instant restenosis looks like, and also to look at the circumflex proximal part. And if you look at this, the stented area there, if you look at 1 o'clock and 12 o'clock position, so there are some hyperplasia and proximal, and you see there is a circumferential intimal hyperplasia in this particular part, which was the most narrowed part of the circumflex. And this area was quite narrow. You can see that, and the area was about 1.49 millimeters square, with a lot of intimal hyperplasia was there. And they came again proximal, and you can see the proximal part, it's fairly 4.95 millimeters square at the ostium. And so
I think you've come to the left main.
yeah, okay. This is the ostium, yeah, also ostium. So it's about 4.9, and now coming to the left main. So the ostium was fairly well, free of disease, and the maximum area, the area which was stenosed inside the stent, there was a lot of intimal hyperplasia in that particular area. And then back to Aftab again.
Yeah. So then, based on the IVUS on the OCT images, we decided that there is still a lot of, despite our use of a Wolverine balloon, there still seems to be a lot of area which is still unexpanded, especially in the proximal part of the circumflex stent. And I don't know if can they show us that the boost? No. Okay. So we did a boost imaging. Unfortunately, I don't think so they can show it here. But the OM stent seems to be arising just after the origin of the circumflex stent. And next slide. We went ahead with a high pressure dilatation with an OPN balloon here. Next. Okay, so then after this, I think we interrogated the LED with an IOS with an OCT.
With OCT, yeah.
Vikash can go ahead and tell us.
So we are going to show you the OCT of the LED. Can you show, Bala, can you show the LED OCT, please?
So there's a problem with the OCT. The guide was sticking in that area of the turn there, and I had to do a gentle pre-dilatation there to get the guide down. So there was a calcium there that was holding up the OCT catheter.
So the LED was actually diseased even if further down, and the area was pretty small. And you can see there is a calcium in this particular picture. From 6 o'clock to 9 o'clock position, there was about, there was a deep calcium there. And we're coming much more proximally. You can see some superficial calcium as well as the deep calcium in this OCT picture. I'll come proximal, Bala. And we are coming much more proximally. You can see there is about 180-degree arc of calcium. And in the most stenotic plaque part of the proximal part of the LED, the area was only 2.18 millimeter square with a nearly 180-degree deep calcium in that particular part. And you can see here that calcium is deep and it's spreading from 6 o'clock right up to 2 o'clock position. Up to 2 o'clock position, there is a calcium in the proximal part. So that was the condition of the LED before, then over to after.
Yeah, so I think the calcium, the LED is again, it shows a lot of arc of deep calcium, and this is a high calcium score, something that probably we would need a debulking with or calcium bond efficient with an intravascular lithotripsy. So that is what exactly we did. The reference vessel size in the mid LED was a 3O, and therefore we took a 3O balloon and did an intravascular IVL in the, can you go to next please? Yeah. Next. Okay, this will come back. Okay, so just while we were waiting for the IVL, what we did is that we went and did a post dilatation in the proximal part of the circumflex stent, that area which had not really expanded despite the use of a Wolverine balloon. And this is a 3O OPN balloon, which is a high pressure balloon. I went to 40 atmospheres almost. And you can see that at the end of it, there was a little better opening of the stent, but it still seemed to show some amount of restenosis there. And this is what the final angiogram at the end really looked like. So this is the OPN balloon after the full expansion. Can you put it down? Yeah. So it seemed to have given away quite adequately. Next. And then while we were waiting for you, we went ahead and did an IVL in the LED. Next one. So we dilated all the 80 shocks throughout the artery, starting from the midpoint, and then went ahead and treated the proximal LED. That was the tightest point, where we needed to give at least 30 pulses of energy there. So this is what we are finally at. So we've done a pre-dilatation of the circumflex ISR. We have done an IVL of the LED. And I'll just take a final shoot for you now to say how we are placed position right now.
We need the OCT after that IVL as well, so you can show that as well.
Ario Cordal. So we did an OCT run post IVL also, and we could demonstrate the cracks in the calcium necessary for us to say that the OCT, the IVL really has done its job. You want to play OCT? Yeah. So this is where we are right now. So what is your further suggestion for us? So the plan for us was that the plan would be to go and stent the LED. We would have to stent right from the mid part, probably take a 3O stent, since the reference vessel diameter distal is 2.8, and then proximally take a 3.5 and extend the stent onto the left main also. The circumflex is something that I don't wish to intend to stent given a choice, and probably I would want to do that with a DB and leave it as it is. And that is how I would look at it. Any thoughts, any suggestions? I'm going to give a stent for the LED. 338. Dr. Srinivas, are you there with us?
Yes, sir. Anything? Great job till now. You've opened a very complex retroverted circumflex, dominant circumflex. You've got it open. The whole issue was exactly where is the proximal stent in the circumflex. So because if you already have struts there, then probably a DEB may be a reasonable solution. Let's have Elvin and Ashish's view on this. Elvin, since you're watching this.
Yeah, I'm watching this, and the only comment I have to make, first of all, is when you start working, even if you're working for a CDO and you might need the lumen, you had a 7 French, I always put a wire in the LED. So whatever happens, might you have a dissection or something, especially that in this calcified areas, you have the LED protected because circumflex was already
That's a great point. Yeah.
The second thing is that I see that there is there is a stent in that marginal. And I see that after every dilation you're doing for the circumflex, that stent is being slowly scratched. So you have lost some lumen in the ostium of the marginal. So that area is more vital than the posterior area or the posterior basal area of the ventricle. What that marginal is going through is to the posterolateral area, and that gives more to the heart pump function than the CTO itself. So I will make sure that you don't damage that, and that also keeps you off from putting another stent, so it'll make two struts of stents before that ostium of that marginal, or if you call it a ramus intermedius. And that's why I will also be more in favor of doing depth for the CDO.
So would you like to consider optimizing when both the vessels with maybe a kissing DEB or maybe one DEB and a non-compliant?
I will do that kissing eventually before starting to work in the LED, because otherwise it will be too late for that.
Yeah.
Anil, can I ask a question?
Please.
Yeah, so you open the CTO now, and now the DEB would be a better choice, or putting in another stent would be a better choice because this is a CTO?
I don't think having a CTO or not having a CTO is all that important. What is important is how much of the major vessels are you likely to jail with another stent. Secondly, we already know that the performance which has been here, I don't think there's any head-to-head comparison data which tells us that a stent is better than a DEB or DEB is better than a stent. So it's really a judgment call, and if you've already got stent struts there, then maybe, for example, in Kirti's case, I would have been very happy after the result was obtained that you had eliminated the neointimal hyperplasia, you got everything evened out, and there was no dissection, nothing left to be attacked with a stent to finish with a DEB. We know that it's still a technology in evolution, but if we have faith in it, then we should subscribe to it. This is probably a good reason, especially in a bifurcation point. The point which Elvin made, I also realized that we should not compromise that large ramus. So maybe doing a kissing balloon, optimizing the two vessels, and then going ahead and doing the LED. And even at the end of the procedure, you're still not confident of the result of the circumflex, then you can always come back.
There is also distal to the circumflex stent, the previous circumflex stent, there is a dissection now, so these might be sealed. So a stent in the distal circumflex that it just opened could be necessary.
Yeah, that
point is, my point, Dr. Anil, is the circumflex stent coming up to the
Yeah, that's right.
That's where the imaging, that's what he asked after. What about the imaging? What has it told us about where that circumflex stent is coming
from the ostium?
Pardon, I didn't get you again. Can you tell me again? Ask me again.
So after, how far is that circumflex stent from the left main?
Yeah,
or from the large ramus?
Unfortunately, we cannot really show you the images here. We did a stent boost, which becomes an easier method for us to know where the stent is landing. So the obtuse marginal branch, or the ramus, as you may call it, in fact, starts just after the OM, the stent in the circumflex. So it's something like a TN protrusion that has been done in the circumflex OM. And the circumflex stent does not seem to extend to the ostium, at least on the OCT. So there's an area which is sort of disease-free between the proximal part of the circumflex stent and the left main.
So have you damaged it by any chance? Could you have hurt it by your balloon dilatation and aggressive with an OPN at 40?
Yeah,
That's a pretty aggressive balloon
Precisely,
dilatation.
that's my point.
Yeah, so we've been very careful.
Precisely, that's my point. I mean, you are done.
Yeah, so I read your point, Anand. Yeah. So I'm just repeating your point in a different way.
Yeah, no, that's why I said we've been very careful to stay within the stent and not come onto the proximal part. So this is something that I've been very careful with. Okay. Wait.
Okay. Very full.
So what I'm going to try to do now, so I've stented the mid part of the circumflex, mid part of the LAD. And the intention now is to wire protect the OM1 because I agree that that's a major artery, and the last thing, that's the only flowing artery that we had earlier, and it'll be a disaster if we manage to lose it or really cause a stent occlusion there or a compression there. The last angiogram that was done with the circumflex did not seem to show any major problem there. But that's the precise reason why we kept a double guide there. And one has to be careful with this porcelain aorta to make sure that one does not really cause any problem there.
But why the double guide? Because you want to use a ping pong for possible trissing? What is it? Why are you taking a second guide?
Yes, so we can of course wire it within the 7 French. You can get 3 wires for sure. That's not an issue. But in case we end up doing a final kissing with 3 balloons with one 7 French sometimes becomes very tight and maybe become a little bit difficult. And therefore, the intention is to use 2 balloons in one and probably do a kissing.
And probably a ping pong guide.
Ping pong guide technique. Yeah.
Are you going to stent it from the left main into the LAD? Because there's a lot of dissection of the ostium of the.
Yes, the LAD is going to be stented. Yeah, the left main is going to get a stent of this into the LAD.
Aftab, I think you can decide finally what you are going to do and tell us. Then because we're nearing the time, then we can come back and review the final pictures later.
Sure. So the plan therefore is to wire all the 3 arteries. So we already have wire in 2. We're going to wire the obtuse marginal branch also. The next thing that I would probably plan to do is to do a DB in the mid part of the circumflex beyond the stent. So as I think we've looked at the OCT, there are some flaps there which have been created by a gentle balloon dilatation. But I'm not very keen on putting a long stent there because the proximal stent inflow has already been affected, and putting a long stent there is not going to really give us a good outcome. The flaps that I see in the mid part of the circumflex are non-flow limiting, and therefore I'd probably just do a DB there. This is the final result in the circumflex. I wonder if you can see it there. So the mid part beyond the stent of circumflex will get a DB. My proximal part of the circumflex, again, I'm very, very keen to just do a DB and leave it rather than putting a stent there. And eventually, I'm going to do a final kissing with a DB.
I think after most of us feel that distal to the stent in the circumflex, where there is a visible dissection which was actually flow limiting at one point in the PCI, you should put in a stent rather than a DEB. The proximal, we'll leave it to your judgment.
Yeah.
What do you say, Alvin? Do you agree?
Yeah, actually, wherever.
Yeah, that's what I wanted to say. It's exactly that. Yeah.
Yeah.
I think let him work in peace, sir. You had Ajay's presentation.
Yeah, Ajay, we actually messed up Ajay's presentation because he went to the cases and got excited. So Ajay's got a very, very important talk.
Yeah, so we'll work and we'll get back to you later on. Then.
Yeah, okay. Sure, Aftab. Great case, by the way.
Mute Kolkata. Go for a talk. Go ahead.
Am I audible, sir?
Yes, please go ahead.
All right. So,
make it full screen. Make it full screen.
Yeah. Is it full screen? Is the angiogram running?
No, it's not at full screen.
Okay. Is it full screen now?
Yes, full screen now. Go ahead.
Okay. So our brief for today is to look at ACS, whether we treat only the target lesion or look for a complete revascularization. There's been a great deal of discussion on this topic over the last few weeks, and I'm glad I can see lots of teachers and seniors, Dr. KD, who's done a lot of work in this particular field. It'll be a pleasure to interact with him and see what we've got. So this is a story of a 35-year-old male who came to us with an inferior wall MI, and this is what his RC was like. You can see that the mid-RC, this is after he'd been given a lot of anticoagulants and antiplatelets in the emergency. So although he still had ST elevation, the RC was definitely the culprit lesion, but this is what his left circulation was like, with the proximal LAD showing an intermediate stenosis and the proximal circumflex showing an intermediate stenosis, with some disease in the OM coming off in the distal OM as well. The second case, 76-year-old diabetic hypertensive dyslipidemic with recent inferior wall MI, RWMA RCA but normal LV function, elevated CKMB and troponin. This is what his RCA was like. And again, we see the left coronary artery showing intermediate stenosis in both the proximal LAD as well as the proximal circumflex. Multi-vessel disease in STEMI is associated with poorer long-term prognosis. Earlier recommendations said only culprit vessel revascularization. Newer trials suggest better outcomes with multi-vessel PCI. But even across the world, there isn't consensus on what to do. The American recommendation being selected patient revascularization, and the European recommendation being routine revascularization prior to hospital discharge. This is seen in about 50% of patients who present to us with a STEMI. The culprit lesion in the ACS is often clear. There's a clear recommendation to treat the culprit lesion. The non-culprit lesion wasn't so straightforward except over the last decade and a half. Questions remain as to the modality of assessment, the timing of assessment, the timing of the PCI or intervention if the patient is a candidate. Can physiology help? These are all the questions that we're going to try to answer over the next 10 minutes. Assessment can be angiographic, physiology, imaging, functional, astrology, many techniques. The timing of assessment and the timing of PCI. Now, how do we normally assess the non-culprit lesion? We look at angiography, physiology, imaging-based and assisted, coronary angiogram-derived fluid dynamics, non-invasive CT-based techniques, or at a later date, functional assessment with stress echo and nuclear medicine-based. These have all been established and they have place in therapy in various parts. We're going to look at physiology particularly. There are some issues with physiology in the acute situation. There's a potential mechanism for increased non-culprit coronary artery resting flow in patients who present to us with STEMI, and mechanisms for decreased ability to produce coronary hyperemia in the non-culprit vessel, essentially because of increased local vasoconstrictors, a blurred hyperemic response to the kind of agents that we use to produce hyperemia, microvascular compression and edema by remote edema, and increased LVEDP that increases the transmural pressure. Now, we do know that these are all the options available. What is available as far as assessment of the non-culprit lesion is concerned? Angiographic assessment that has advantages of being immediately available. There's no need for a pressure wire software processing. But there's a mismatch with functional assessment. So there is an issue as to whether we actually need to do it or not. And this often leads to overestimation of the non-culprit lesion, even allowing for the oculostenotic reflex. CFR, which is a very attractive concept, but does it distinguish between epicardial and microvascular disease? And it might overestimate the non-culprit lesion severity in the acute setting, and thus has limited clinical use because it varies so much with heart rate, blood pressure, and so many other physiological parameters which are not always well controlled. Fractional FFR, which has the advantage that it is recommended to guide revascularization in stable patients and has a mountain of data to support its use in patients with stable angina. But it may underestimate non-culprit lesion severity in the acute setting, and there remain questions about its ability to prognosticate in the long term. IFR, which has the advantage that hyperemia is not there, but it may overestimate the non-culprit lesion severity in the acute setting, and we may end up doing more where it may not really be required, testing PDPA with the same kind of caveats as the IFR, and the QFR, which is a newer technique of computational fluid dynamics, but there's a problem because there's a mismatch with the functional non-culprit lesion assessment. Now, I've just chosen this study because of the simplicity, and it also illustrates one of the problems. They looked at 100 patients with acute MIs and looked at FFR of the non-culprit lesions and repeated the same measurements after a mean of 35 days. 14 patients IMR was measured as well. The values were not statistically significant, but even this one small study, when one looks a little more closely, 2 patients who were less than 0.8 at index, were greater than 0.8 at index, were then less than 0.75 at follow-up, with absolutely no difference in the 2 groups in the corrected TIMI frame count, the percentage stenosis, MLA, IMR. And 10% of the lesions actually crossed clinical cutoff values and thus made it a little difficult to interpret. This means nearly in 10% of patients, we really don't know whether the FFR is reproducible or not in this tightly controlled study. Now, thus physiology obviously changes from the acute setting to the subacute setting to the stable setting. And in what way does it change? The CFR continuously increases, but as I said, this is subject to so many other variables that it is a little difficult to interpret if we don't know exactly in which part of the natural history the patient comes to us. The FFR has a tendency to underestimate the lesion, becoming significant in the stable setting when it might have been insignificant in the acute setting because of the problems with hyperemia that we discussed. And the IFR actually overestimates and thus might turn out to be significant when in a stable patient, it might be with a similar situation as the same patient, it might not actually be significant. Now, if we look at multi-vessel culprit only revascularization versus multi-vessel revascularization with complete revascularization, there have been 10 trials in this meta-analysis of 7,030 patients. There was actually no difference in the two groups between all-cause mortality, but there was a lower risk for reinfarction, cardiovascular mortality, and repeat revascularization. Not much difference being there in contrast nephropathy and major bleeding amongst these two groups. But if you look a little more inside within this meta-analysis, multi-vessel PCR definitely appears safe for complete revascularization following a STEMI. Non-culprit lesion, when addressed correctly, decreases revascularization. One large trial did show some mortality benefit, but the meta-analysis only shows benefit with respect to revascularization. Can we make a little more precise decisions based on physiology? The studies that used FFR for evaluation of non-culprit lesion only with angiography were PRAMI and culprit, and FFR guided were Dynamic 3 Primalty and Compare Acute, and some of the patients in complete. Now, all of them showed across the board that there was an improvement in patients who underwent complete revascularization compared with the control group, which had no further PCI, ranging from 23 to 9% in PRAMI, and Dynamic 3 FFR was 22 to 13%, Compare Acute was 20.5 and 7.8, and complete was 7.8 versus 8.9%. Well, we do know that it is safe to defer a PCI in stable angina, but what about acute coronary syndromes? This is not exactly STEMI, but in a large meta-analysis, it appeared that deferring a patient based on an FFR in the acute coronary syndrome was almost as good as the benefit size of benefit was quite significant as compared to the stable angina patients in both groups. Thus, deferring a patient seemed to be fairly safe or an acceptable strategy in patients with PCI, with ACS in the non-culprit lesion. What about the natural history of FFR of non-culprit lesions? It does seem to predict long-term events. In this another large meta-analysis, the FFR of less than 0.8 untreated actually had the largest number of events and the lowest event-free survival. So obviously physiology does have some role. FFR plus angiogram, 31% of Dynamic 3 Primalty actually did not need PCI as compared to the angiography, and 44% of Compare Acute did not need PCI. Did angiography alone guided trials, that is the PRAMI, the culprit, and to some extent the complete overuse the PCI? But the hazard ratio was similar in all trials. So it appears that as we look at larger and larger numbers, with an FFR guided strategy, we have similar results with fewer lesions intervene. So whatever we use, the safety of the modern PCI seems to be so good that the results kind of even out in the end. Clearly, complete revascularization reduces the need for revascularization in the short and intermediate term with doubtful results on mortality. Physiology, thus, if we look at all the meta-analysis, if we base it on IFR, 1 in 3 of the treated non-culprit lesions would not have been significant at 30-day follow-up. But when we base it on FFR, 1 in 5 deferred non-culprit lesions would be significant if we follow them at 30-day follow-up. So thus physiology also has its limitations. What about imaging? Now, since Dr. KD is there, I'm going to borrow some of his slides, but this is something else which shows us that the presence of a TCFA in obstructive compared with non-obstructive non-culprit lesions actually gave a more adverse event. This is obvious and intuitive, but non-culprit lesions which are obstructive are more likely to be TCFA on statistical analysis in this particular meta-analysis that was published in Circulation. And 7.3% of patients had an obstructive non-culprit lesion containing TCFA in this study. The combined FFR negative lesions and divided them into two groups, the TCFA negative and the TCFA positive, who were given OMT, and they looked at their primary endpoint. which were essentially cardiac death, target vessel MI, clinically driven TLR, or hospitalization due to unstable or progressive angina, versus FFR negative patients who had no TCFA, that is the group A versus group B. And there was a large 4.7% reduction, or a hazard ratio of 4.7% as far as adverse events were concerned, out to 546 days in the patients who had TCFA as compared to those who did not have any TCFA. In an interesting sub-study of what he's shown, actually the event rate in patients who underwent FFR along with revascularization was actually lesser than the FFR negative patients with TCFA who didn't undergo anything and had a 13.3 versus 9.7, although the two groups were not significantly comparable. Thus, addition of imaging to physiology gives us intuitive and interesting data. Obstructive plus TCFA is the maximum risk. Imaging clearly adds to risk stratification. The treatment path for non-obstructive TCFA as yet, though, is still unclear. We have imperfect prediction models, and it's possible that little more analysis of CT, biochemical markers which are going to emerge, the near-infrared spectroscopy, thermography, etc., are going to add a little more to our ability to prognosticate, although we don't know what to do about them. Although I did listen to Dr. Greg Stone with interest when he showed us some of the absorbed 2 follow-up studies in patients who underwent angioplasty with BVS for TCFA. This has probably reignited the debate on vulnerable plaque and the vulnerable patient and what we need to do about them. Now, when do we assess the non-culprit lesions? We have several opportunities at the index event with angiography and physiology, at the initial hospitalization with angiography plus physiology plus imaging, or at a staged time when we have non-invasive available as well and functional assessment available as well. When do we intervene? Again, we have multiple opportunities at index procedure, before discharge, staged at a time between 3 to 45 days. The ACC-AHA says that there's no randomized data at this time to support a recommendation with regard to the optimal timing of the non-culprit lesion PCI. But 4 out of the 7 trials that were looked at in the meta-analysis actually looked at this intervention prior to discharge. Complete definitely showed that whether it was done staged or whether it was done early, the benefit of complete revascularization appeared to be independent of timing in patients who had significant lesions. And there were very few events between the index procedure and non-culprit lesion revascularization. If you look at a risk-benefit analysis, this is what we should be doing for every patient. Hemodynamically unstable, we individualize, and at this time, there are too many variables to make generalizations, I feel. In a patient who's stable, definitely do the culprit lesion only. The risk for unforeseen complications which are tolerated less well in acute situations ensures, and also the out-of-hours time at which such patients usually come, prudence is probably the first most important step. If the other lesions are really critical, it's probably good to consider at the time of the primary PCI, somebody who has an RCA infarction and a 90% LAD, and it continues to have features which are unstable at presentation, we'd probably do the LAD as well, or definitely do it pre-discharge. Complicated lesions, definitely staged procedure. All others need to be individualized. What happened to our patients? This is a patient for whom after we had finished with the RCA, we first did the FFR to the OM2. We opened the OM2. The OM2 FFR was 0.72. Thereafter did the FFR to the circumflex OM1, which was 0.9. The LAD pre-PCI was actually 0.74. And this was confirmed on the RFR as well. So that was fixed. Post-PCI, as Dr. Ashish had shown, we always do this after the PCI. It was 0.9 in this LAD. After we finished with this RCA, we looked at the left diagnostic. This is what it was like. This is the second patient. And we did the FFR first to the circumflex. The RFR was 9.7. The FFR was 8.9. So we didn't need to touch the circumflex. The LAD didn't look so bad, but we just couldn't place the FFR wire into the LAD. After that, we thought we'd do some imaging. The OCT catheter could not cross over another wire, which we managed to place. The decision was made to do a plaque modification because there was obvious calcium. And that's what we did. The wire was exchanged, rotablation performed. Thereafter, the OCT was done post-rotablation. I'll quickly go to the images instead of showing the whole picture. We showed calcium cuts and the maximum thickness.
You can please conclude faster because all the CTO people, all the doctors are waiting. We have to see
all
one
right, sir.
case also.
So I'll just show this is what we did post-PCI. And the FFR we repeated again in the circumflex. In summary, factors governing immediate and staged are stability of the patient, lesion localization, likelihood of procedural success. Image-guided demonstration of high-risk class may prompt early intervention. We must do it early. might take last slide is complete revascularization is definitely beneficial. Timing of assessment is governed by the baseline risk. Timing plus by risk plus cost plus local expertise and other factors will decide what is done exactly. More data is forthcoming, and this decision making is likely to be refined and improved with imaging, invasive and otherwise. Thank you.
Thank you, Ajay, for accepting and doing a great job even in short notice. I wish I should say that, but thanks. Can we see Apollo 1 minute before we go on to the next session? Because we promised them that we would just see them.
Ask one question to Ajay.
With you, we can briefly tell what you have done in a minute or two, and we'll go to CTO.
Yeah, so I think
you can use the 6 lines to do guessing.
Hello?
Go ahead.
Yeah, so what we have done after you left us is that we reassessed the circumflex OCT, and well, we do agree that there is a lot of dissection in the mid part of the stent of the circumflex post stent. So we've stented that area of the circumflex with a balloon with a stent there, and this is the result in the mid part of the circumflex after the stent. The proximal LED, you can see that there is a dissection caused by the IVL, and we needed to stent that also. So I just wire protected the OM with another guide there, and this is the stent from the left, the LED to the left main that goes in there. So it's a 3-0 distally and a 4 proximally, and the 4th stent is now being deployed. We've done a pot with a 5-0 balloon. So this is a 5/8 pot that is done in the left main. And now I've just recrossed into the OM through the circumflex and the left main stent, and managed to secure that. So this is through the other guide that I've had there. And this is where I am right now. Now the problem is the ostrum circumflex. I still think that I would probably leave it with a DB rather than putting a stent there, because with already 2 layers of stent, putting one more stent is really going to compromise the large ramus there, and that's not something that I want to do. So my plan would be to just do a DB in the proximal part of the circumflex and leave this with a final kiss, where there's going to be, it's probably going to be a triple kiss with the 2 guides and the 3 wires there.
Okay, Aftab, great case, and thanks for showing it, and complete it carefully, and hope everything goes well. Thank you. We have to leave because Dimitri and all other operators are waiting, and again further live cases will follow.
Oh, sure.
Can you cut now Kolkata and make it gallery? Welcome Dr. Dimitri and all of the colleagues of his, and he was very kind to design CTO program and run it for us, and all other operators from US. Hope I'm audible. Yeah, they all were kind to give their valuable time and come and educate us, because I thought in India there's a lot of interest in coming up for CTO sessions. So that's why I requested Dr. Dimitri, who conducts the CRF CTO course there, and all other colleagues and Indian colleagues also joined as panelists. I think with this, can you have Dr. Dimitri? Saurabh?
Yes, Srinivas, can you see me or hear me?
Yeah, okay. Go ahead, sir. I think other panelists from India, Dr. Arun, Suryaprakash and Kaparthi are in the case, Dr. Nikhil, Dr. Damodar, Ganesh, others also can join. And with this, I request you to take over and conduct this session, sir.
Well, first of all, I would like to thank you for the invitation. It's a great pleasure and an honor. We've been working for many, many years and done cases in India and worked through webinars. We have a distinguished panel consortium here and the great speakers. Just because of time issues, I would like to just say that we have 3 lecture sections, starting with basics, then going back forward to tools and techniques, and then complication managers and advances, which is one of the most popular, so to speak, sessions. And without further ado, I would like to introduce my very good friend, colleague, and prior trainee, Dr. Darshan Doshi, who leads the complex PCI and CTO program at Mass General, to educate us about update in CTO PCI, what we've learned, and where we're going. Darshan, the podium is yours.
Dimitri, thank you so much for that kind introduction. I have the distinguished pleasure of talking about the salient CTO-PCI literature. It's unfortunately a 10-minute talk, so it's hard to encapsulate the true breadth and depth of what we've actually learned and where we need to go in that time frame. But what I will do is highlight some of the important studies from the past year or so, and then sort of touch upon areas where we still don't have data and need to further investigate. These are my disclosures. So we know that the two aspects that really make CTO-PCI unique compared to traditional angioplasty is the fact that one, CTO operators must know how to go retrograde, and two, how to leverage the subintimal space to complete CTO-PCI. And so the data around retrograde CTO-PCI and then also subintimal stenting has been marred with some controversy. So I want to highlight some studies specifically focused on that first. So the first study I'm going to talk about comes from Manos Brelakis and his team. It comes from the Progress CTO registry, where they looked at around 4,000 patients that underwent retrograde CTO-PCI and compared them to antegrade only CTO-PCI. And what they found, which one would expect, is the fact that in order to complete higher JCTO CTOs, more retrograde techniques were required. But when we performed retrograde techniques compared to antegrade only techniques, the procedure time was longer, there was more contrast volume given, there was more air karma radiation, and the fluoroscopy time was greater as well. And then when you looked at clinical outcomes, specifically things like procedural success, it was lower with retrograde cases. In-hospital MACE events were also higher, death was higher, acute myocardial infarction was higher, the need for emergent reintervention was higher, the need for pericardiocentesis was higher, driven by greater perforation in retrograde cases as well. Now, the issue with Progress CTO was that it was a self-reported registry with no core lab. In contrast, the Open CTO study took 1,000 consecutive patients undergoing CTO-PCI at large volume centers and had a core lab that basically adjudicated the outcomes. And so an analysis led by Sanjog Kaura and with Dimitri looked at retrograde CTO-PCI compared to antegrade only approaches from the Open CTO registry. And just like Manos's study, essentially those undergoing retrograde cases had a higher JCTO score, nearly a point higher. And then they also had worsened in-hospital outcomes. So technical success was lower with retrograde, procedural success was lower with retrograde, MACE rates were higher, the clinical hematomas, pericardial effusion, pericardial tamponade, and cardiogenic shock were much higher with retrograde approaches. And so when you look at the MACE rates, and so the dotted line here, any retrograde approach compared to antegrade only, and the MACE rates are higher for retrograde approaches. So the survival is lower here. But the interesting thing that Sanjog did was basically he excluded those patients that had an issue in hospital and looked at only those that were able to be discharged home. And what he found essentially is the fact that MACE rates, when he did a landmark analysis, were exactly the same. So what this kind of points to is the fact that you take an upfront hit with the procedure, but if you have no issues from the actual procedure itself in-house, then subsequently your outcomes are very comparable to those as it pertains to MACE compared to those that are going antegrade only approaches. The other aspect is looking at the quality of life. So what we do know definitively is that CTO-PCI does improve quality of life. Unclear about a mortality benefit, but a quality of life benefit cannot be argued. And so here, what you can see is that patients that require retrograde techniques actually have worse Seattle Angina Questionnaire scores. So they have more physical limitation, more angina frequency, worse quality of life, and ultimately their summary score is lower. However, after undergoing CTO-PCI, the change in baseline is the same whether you went a retrograde or an antegrade approach, meaning that both approaches really improve quality of life. Now, not to beat a dead horse, but Megali et al. Basically did a meta-analysis of 12 studies. And again, it highlights the same sort of thematic points that the other two studies showed. One, that retrograde requiring procedures had lesions that were longer, more complex. The procedure was also longer, requiring more contrast and more fluoroscopy. In-hospital events were also higher. But interestingly, one of the things that they found was that the long-term outcome at 48 months in patients that underwent retrograde CTO-PCI, they had a higher rate of myocardial infarction. They also had higher target lesion revascularization and also target vessel revascularization, but similar risk of long-term mortality. So ultimately, all in all, it basically shows that retrograde CTO-PCI is needed to complete CTO-PCI, but it is associated with greater in-hospital events and potentially with worse and long-term outcomes. Now, shifting topics a little bit, looking at dissection reentry techniques. So one of the main concerns that a lot of operators had was, if I stent the subintimal space, are the outcomes going to be similar to those if I am able to stent into the true lumen throughout the entire CTO? And so there's been controversy back and forth. And last year, Simon Walsh and James Spratt performed a study called the Consistent CTO Study. Now, this study took approximately 210 patients and then divided half of them in patients that underwent dissection reentry techniques called DART, either antegrade or retrograde, and then those that required no dissection reentry. And then they confirmed their crossing pattern via IVUS. This was adjudicated by a core lab. But when they asked the actual performing clinicians to say, how do you think you crossed, 1 in 6 was wrong in the way they crossed. And then these patients were followed up 1 year with both OCT as well as angiography. And what they found was that the lesion length was obviously longer in those that required dissection reentry techniques. They were more likely to have had prior CABG. They were nearly a full point higher in their JCTO score. The stent length was also longer. But the MACE rate at 2 years was exactly the same, kind of, again, sort of pointing to the fact that whether you use dissection reentry techniques or not, that the outcomes are fairly similar, but that for more complex lesions that you really need to leverage dissection reentry. Now, one of the things that we know that has been sort of dogma is that you really need support and you need large catheters in order to do your CTO PCI. Certainly, when I trained, it was not uncommon to use 2 8 French bifemoral sheaths. But Cambis and colleagues from 5 different European centers performed a retrospective analysis where they looked at CTO-PCI procedures that were fully transwrist. So they used either the radial or the ulnar in one hand, in 2 hands, or a combination, compared to a conventional transfemoral approach. And what they found was that, again, this was a retrospective analysis, not a RCT. What they found is that for low, medium, intermediate JCTO scores, that the utilization of the conventional and the fully transverse approach was statistically no different. And their primary endpoint was a combination of vascular complications and major bleeding. And this was vastly in favor of the fully transverse approach, that you had a lower primary endpoint. But this was not driven by major bleeding, but mainly by vascular complication. And when you looked at vascular complications, it was predominantly just a local hematoma. So again, potentially there may be some benefit to using a transwrist approach if possible, but it's really driven by vascular complications and specifically local hematomas. In the same vein, colleagues from a center in the Netherlands said, hey, if the transwrist is potentially better, what if we use, quote unquote, a minimalistic hybrid algorithm? And so in this scenario, what they did was anyone that has a JCTO score of 1 or less, they then only used a single 6 French transradial for AWE. If they failed and there were interventional collaterals, then they would try to cross the collaterals, and if they were successful, then they would put a second transradial guide in to perform either retrograde wire escalation or reverse cart. But if there were no interventional collaterals, then they would upsize to a 7 and potentially then put a 6 French transradial for contralateral injections or upsize to an 8 French from the groin. And here they found again that they had acceptable complication rates with the minimalistic approach. Now, one of the things that we know with CTO-PCI is that these cases tend to be longer, require more radiation, and can potentially lead to orthopedic injuries in the future. And so the colleagues from Mid-America Heart Institute attempted to perform CTO PCI using the Corindus GRX robotic system. So what they did was they took half of their patients in this analysis, and they underwent CTO PCI via the conventional route. And then the other half, what they did was they crossed manually, and then they would then allow the robot to complete the rest of the procedure. And what they found was that when they used the robot, the fluoroscopy time was lower. The radiation was obviously lower. The cockpit time, which is the time that you're out of lead, was higher. And the major adverse events were no different. There were no deaths in either, so there was nothing else there. So this sort of hints to the fact that maybe using a robotic system, particularly after you've crossed, may be advantageous to operators in the long term. Now, one of the things that has been frequently cited is collaterals. And so, it's not uncommon for us to hear that, this person has a CTO, but they have robust collaterals to the CTO. So they really don't need an intervention there. And so in this study, what was done is that the CTOs were crossed, and then after they were crossed, an IFR wire was placed. This kind of recapitulates a lot of what Gerald Werner did with FFR. And what they found was that almost every CTO that was crossed was grossly ischemic. The average IFR was 0.33. We know that a cut point of 0.89 is used to intervene. So this was grossly ischemic, despite the fact there were collaterals. And that almost all of the patients that underwent CTO PCI had an improvement in their IFR to 0.93. And those that were still below the cut point, the vast majority, it was a focal lesion that you could treat and then get above that threshold. Now, the last study I want to talk about is specifically regarding the use of antegrade fenestration and reentry. This is a technique that Dr. Juan Russo will be going over shortly, but essentially what it entails is that if you have a wire in the subintimal space and you're not able to reenter, what you can do is use a balloon on that same wire in the subintimal space and then use a second system with a microcatheter and a polymer jacketed wire. Inflate the balloon on the original wire to create fenestrations from the subintimal space into the true lumen. And in this registry, Lorenzo Azzolini and colleagues basically found that that they were able to perform AFR and were successful nearly 2/3 of the time. And so they used a hybrid algorithm, and they say that potentially AFR has a role when you're trying to do ADR and you have stingray failure, or a stingray is not available, or if you're trying to do RDR and you fail, then AFR may potentially fall within this paradigm. Now, in the interest of time, I'll stop there. But one of the things that you see that is still missing is a definitive RCT in the favor of hard endpoints. So again, there's quality of life improvements. There are other secondary endpoints that may potentially be beneficial by doing CTO PCI, but we don't have one that shows a true mortality benefit as of yet. So ischemia CTO is an ongoing RCT. Noble CTO is another ongoing RCT. And so they will sort of hopefully kind of guide us further. Now, I showed you that retrograde CTO PCI is associated with higher MACE and complication rates. So we still need additional strategies to mitigate those rates. We also need greater innovation in both techniques and tools. So there's obviously a great deal of research that's going on right now for new devices. Some of the devices that we use readily today weren't even available when I did my fellowship in CTO PCI, and it wasn't even that long ago. So the field is continually evolving. And then ultimately, obviously everyone listening today is interested in CTO PCI, but how do we institute best practices around training? How do we do proctorships appropriately? How do we get remote CTO PCI training out to others? These are still questions that need to be answered. And, CTO PCI as a field, since it started, decades ago, is starting to become much and more refined, but we're still scratching the surface of what it has to offer. And again, it's people like the people on this panel, you out there, that are ultimately going to be able to sort of drive the field forward. Thank you so much for your time. I'll stop right there.
Thank you, Darshan. That was a great talk. There's obviously a reason why you're a leader at MGH and a great academician and a great operator. Always proud of you. We will move to the next talk. My dear friend and colleague, Dr. Amir Masumi, who's going to be joining me starting in September, building upon an already excellent program that they have at Morristown Medical Center, and try and build their complex PCI/CTO PCI program and the mechanical circulatory support. He's going to talk to us on how to build a successful CTO PCI program. Amir.
Hi, thanks for your kind introduction and this invitation. I'm going to talk briefly about how to build a CTO program, which Darshan touched upon in his conclusion remarks. As he mentioned with the literature review, the CTO procedures are beneficial for patients in these regards: relief of symptoms, improvement of ventricular function, more and more we're learning about that, reduced incidence of late cabbage referrals, and improvement in event-free survival. However, when we are talking about program building, we need to have allies with the institutions and administrations, because that will determine the success of any initiative and program. What are the benefits for the institutions and administration is the name recognition, branding, positive economics. I think Dr. Karmpeliotis decades ago showed the benefits that and the revenues that CTO programs will bring to the hospitals and institutions. But we need to remember, as the technology is improving, we'll have more ancillary testings, ancillary services will be involved, heart failure team, for example, cardiothoracic surgeons, vascular surgeons. So we'll have more of a concentrated, higher level care that will ultimately improve the patient satisfaction, and they will have all the care in one place. Also, it will increase the procedural volume and referrals and in reduction in readmissions. So there will be a mission, and that mission is that these are higher risk cases with the greatest complication, and are least desirable to be intervened upon. But if we promote a complete revascularization with indicated hemodynamic support, which these two are the pillars of CTO programs, we'll see the benefits for the institutions, but ultimately for our patients. Regardless, what we've learned from most of cardiology, but more specifically from the valve team approach, is a team approach. And that team approach or heart team approach needs to have experienced interventional cardiologists, cardiothoracic surgeons. This is a bidirectional partnership, which is crucial. We need, adequate cardiac cath lab environment and staffing. We need mechanical support backup, imaging and specialized testings, and also critical care, both nursing and specialists, which will ultimately dictates the success of the program. And with support of administration, we'll be able to not only build, but develop and progress the program. In terms of the administrations and how we try to identify the gaps, we have to see what are the flaws with the current care delivery. First of all, we need to identify our capacities and capabilities. This is not for every single cath lab or every single institution. So we need to identify those. And then we should remember, it's not only for CTO or complex PCI. In general, it will elevate the overall quality of optimum PCI. And that's what should be the message for the entire cath lab and patient care. Then we need to identify what are the costs. Equipment, cath lab time, turnover will be longer. We need to have skilled team members. These are definitely, the retentions are a little bit more costly. We need ongoing education that will add to the cost. We need coordinators, additional staff that are not only familiar with the procedures and the needs, also they will be in direct contact with the referrals, educating the community and our patients. And also we need marketing targets. And also, we need to know what are the potentials for increased reimbursement. This has been done before, and we have our TAVI programs as a great experience. In terms of the team approach, we need to train specialized physicians. These are the ones that are familiar not only with CTO procedures, but also how to manage complications, how to address the patients, how to talk to the patients prior to the procedures, and have like a educated and a collective decision with patients and families at the center. We need to have dedicated CTO days, designated complex PCI rooms. The environment, it should be spacious enough in case of complications that other teams need to come in. Safety and radiation is another one that Darshan touched upon, and we need to appropriately stock the rooms. We need dedicated cardiac cath lab staffing. As I mentioned, retention is important here. Huddles and pre-procedural planning, it's crucial, because it's not only the operator or the assistant, it's the whole team. Our nurses, post procedure, everyone should huddle and know exactly the game plan and know what are the strategies, plan Bs and bailouts, complications, and how to address those. And also briefing, that's very important. We need to review our cases. We need to learn from our mistakes and our victories. And also we need to have a systematic approach with quality measures as well. And also in terms of educational and academic environment, we need to have M&Ms, and hopefully everyone will be elevated and learn from the strategies. So in conclusion, the ultimate goal is to improve patients' outcome. But we need to identify the gaps. We need to know our capabilities and create opportunities. We need to have a team. This is not a one-man show. We need administrations. We need good partners within different different disciplines, medical disciplines, ancillary teams, cath lab staff, and coordinators. And these are the novel skills that also we need to learn. We are physicians, but we need to learn business planning, how to do good marketing, and this should be evidence-based to educate the patients and the families and the referrals, and we need to learn how to manage our team members. Thank you.
Thank you, Amir. That was a very good and comprehensive talk, touching on all aspects of how to build a program. And as you said, that extends beyond CTO program building, but complex PCI, mechanical circulatory support, shock, advanced heart failure, interventional heart failure, and so on and so forth. So if Arun is on board and can hear me, Arun, you've been one of the most skillful operators I've worked with. And I would like to ask you briefly, within 20 or 30 seconds, to tell me what data do you think that we need, not to convince only ourselves that we're doing the right thing, but also to convince the broader interventional and cardiology community that opening up a CTO is beneficial to the patient and safe?
Oh, first of all, fantastic talks, and thank you, TCT in India and TCT and Dr. Srinivas Kumar in particular for having me involved. I mean, it was kind of touched upon in the previous talk about, essentially getting hard outcome data. I mean, I would love for that to be shown, but I'm kind of skeptical if we are ever going to have a large enough trial to actually see, real hard outcomes and a reduction due to CTO PCI. I mean, due to all the reasons that we already know about. Now, if we can convincingly show people that we are reducing ischemia and symptomatic improvement, in a good, well-designed stuff, and then, kind of set this to rest. And I think symptom relief is a lofty enough goal. That's one. And the other one I would say is that in the impaired EF patients, many times when we have shown viability, if you can show convincing, that might be a population where you could show, like either improvement in EF or any of the surrogate outcomes that might show that these would translate into better hard outcomes. I think then we'd have a better job of convincing our partners that don't do CTOs.
Thank you. And I would also say that we need to prove and do our best to make sure that we make the procedure safer. Because over the last few years, I don't think that we have moved the needle the right direction. If you look at more recent CTO trials, either the registries, single center registries or multi-center registries, still the complication rate is an issue, and we have to work a little bit harder on this. And Dr. Surapakars, are you on? Is Dr. Surya Prakash, I'm sorry if I'm correct, mispronouncing, is he on the panelists? Or Dr. Kapardi?
You know, there was some confusion. Actually, I was in another room, and then I don't know. I actually re-logged in, and that's how I got here. So I'm not sure if they've been sent to the other room for whatever reason. So I will.
Is Dr. Parshur or Dr. Damodar or Dr. Kumar among the panelists? This is the list of panelists that I have.
Dr. Arun, you are in the right room. Yeah, I think, Dr. Dimitri, we can move to the next presentation.
Okay, I just had a question for Arun then. Just 10 seconds. What is the biggest obstacle based on what we heard from Amir in order to build a successful CTO PCI program? Just 10 seconds, please. If you had 1, 2, or 3 things to say.
So, I mean, in India, I mean, I think there are a lot of myths surrounding CTO PCI. I mean, the one that we talked about, the collaterals, it was in the talk before, what IFR. No, thinking that collaterals still are enough to reduce ischemia and symptoms is probably the biggest misconception, I would say, in this part of the world. And of course, the other one that, I mean, you kind of hit the nail on the head about safety and saying CTO PCI is dangerous, which, I mean, it is compared to regular PCI. It has a higher, peri-procedural risk rate, but it can be done relatively safely under expert guidance. I think it's still a concept that needs to be bought out here. I would say those are probably the biggest two.
The only thing I had to add is that when we talk about high-risk PCI, if we see the complication rate, for example, in SVG PCI or rotational thorectomy, the numbers are not that vastly different.
Yep.
And with that, we'll move to section 2. And my good friend and prior trainee, Dr. Emad Hakemi, who's practicing in Cleveland Clinic, Florida, is going to talk to us about antegrade wire escalation and antegrade techniques overall. Emad?
All right. Can you see my screen?
I can see your beautiful face, but not your screen yet.
How about now?
Yes.
All right. Good afternoon, TCT India, and thanks for the organizers for this generous invitation, and thank you, Dimitri, for.
Dr. Ahmed, it's not on a presentation view. Can you put your presentation?
Ahmad, if you want to go to display settings on the top and then switch. So.
Yeah.
I think you were good there. You just have to go upper left-hand corner. There's a tab that says display settings. Click down and then click presenter view.
Display settings.
There it is. Yeah. Click on that and swap. Yep.
Got it. Thank you. All right. Thanks a lot, Dimitri, for the invitation. Thank you, TCT India, for organizing this. So my name is Imad. I have no disclosures. The way I look at antegrade wire escalation, it's a stepping stone to whatever comes afterwards. It's one of the initial learning skills that we have to master before we start building on that skill. And that's something that Dimitri hammered a lot during the training that I went through with him. I'm presenting a case that shows some of those skills that we're going to talk about. Bifemoral access. This patient has, as we see, a large RCA system that has CTO in the mid segment. With some bridging collaterals, it's hard to know here or appreciate if there's actual antegrade flow in the true lumen or just a lot of bridging collaterals. There's left to right collateral supplying RPL systems with another distal CTO in the RCA territory just before the RPL start showing up. Again, different areocrany shot showing the RPL system where the second CTO is present and actually shows the magnitude of this RCA system. We decided to go obviously antegrade. This is the usual way we always try to achieve the recanalization of CTOs, turnpike microcatheter. And for this case, initially we tried the Fielder XCA. We thought might be a microchannel that we can actually get into and advance into the more distal part of the vessel. Fielder XTA did not actually achieve that purpose, so our next wire was Pilot 200, where you make a very micro bend at the tip of it, obviously, and you start trying to reach that distal vessel, trying to get into that, staying within the true lumen of the vessel, which sometimes is not an easy thing to do. The reason we picked initially the Fielder XTA, it's a pretty low tip load wire, hydrophilic. Doesn't give you a lot of tactile feed, but pretty safe when you want to go through those micro channels, trying to avoid the bridging collaterals, because you don't want to advance those wires into the bridging collaterals, can complicate the procedure, obviously. We thought initially that this wire did not have enough tip load, so we escalated to a Pilot 200, which has a 4-gram tip load, also polymer jacketed hydrophilic wire. Not a lot of tactile feedback, but a lot of the times if you just spin the wire, it can actually find the channels you're looking for. Again, being careful not to go into those bridging collaterals. Unfortunately, also the Pilot 200 did not achieve what we wanted to achieve. So the question became, now what wire should we actually try to go? Would you go for a stiffer wire? Would you go with a less hydrophilic wire, give you more tactile feed? And you know, all these questions go through your mind when you're doing these cases. Decided to go with a Gaia 2, which is basically a 3.5 tip load wire that has a tapering end and it's pre-shaped tip, 1 millimeter bend at the end of the wire. At the end of the wire is 0.1 wire compared to the body of the wire, which is 0.14. It's hydrophilic, but it's not polymer jacket, and it gives you reasonable tactile feed. And this wire, I mean, it depends on you ask, but most of the time we try to actually steer it and direct it towards where we want it to go rather than spinning it. And this wire actually was able to go through the mid portion of the RCA CTO into the distal vessel. But as you see here, you can see some stress on the tip of the wire, making you think, okay, probably I'm not in the true lumen here. So what options do we have here? So now we traversed the first portion of the CTO, but now we're still not able to re-enter distally. If you start going through the antegrade wire escalation, some techniques will depend on leaving this wire in place, so it works like your guiding wire, so you know where you go with the next wire. So this is called a parallel wire technique. This is one thing you can do. Other strategy you can go after is ADR, where you basically use a Stingray catheter to re-enter in the true lumen. What we opted to do before we start going into more of those complex techniques is by redirecting the wire into the true lumen. We had again, here we see the stress in the wire tip, knowing that we are in an subintimal plane. So we decided that we had a good faith that actually a lot of these procedures, you need some good faith, and in addition to your experience and luck. We had a good faith that we actually can be able to re-enter the true lumen without utilizing the parallel wire technique or the ADR techniques. Using the Gaia wire, in which case this is a demonstration of it. Basically, the Gaia 2 wire traversing into the true lumen. You can clearly see here that there's no stress on the tip of the wire, so you kind of feel more comfortable now knowing that you're in the true lumen. And this is a retrograde shot showing us clearly that the Gaia is now in in the PDA vessel. So now we started. Basically, became a case of you dilate, you IVIS, you size your stents, and you secure that what you just achieved with stents. And here we clearly see now the PDA system coming. There's a very short CTO that we thought those two PL systems are big enough vessels to target for revascularization at the same setting. Again, you go with a microcatheter. You park the microcatheter just before the proximal cap, and then becomes an issue. Okay, now what wire I should use? Here we don't really have microchannels to go after, so going with an XTA doesn't really make a lot of sense. You can either pick a Pilot 200, which is a relatively safe wire, which is something you usually like to do, going safer wires first, or you go with heavier tip load wires. In this case, we attempted the Pilot 200 to puncture the proximal cap and the distal cap into the true lumen. That did not succeed. Again, the Gaia 2 was the star of the day in this case. Which basically, because it's a very short segment, we thought that it's going to be a good wire to use and try, if we were lucky, we go into the true lumen or not. In this case, this was achieved. Once you have the wire in this lumen, we just basically did a POVA, re-establishing flow into that RPL vessel. So this case, in summary, basically demonstrates what the thought process of what wires you pick initially when you try to finish a case. Antegrade wire escalation is the first stepping stone for whatever comes after, and it's a nice thing to actually master that technique before you start building up in other skills. Thank you all for your attention.
Thank you, Matt. That was a very instructive case. We all know that integrated wire escalation in all registries is the most frequently used technique, and we need to know how to do it right. And we're going to come back on the discussion session because I need some comments from you guys on the Gaia wires and who should be using it and what is different with Gaia wires as opposed to other wires. So we're going to move ahead with, again, one of my former trainees, Dr. Juan Russo, who's going to give us a little bit broader view and maybe more advanced techniques on undergrade recanalization and focusing on some of the newer techniques that are out there. Juan?
Thank you, Dimitri, for the introduction. I'm just going to share my screen here. Is it in the right format?
Yeah, looks good.
Perfect. So thank you for the opportunity to present. I'm going to present on antegrade strategies and how the field has advanced over the last couple of years. So this diagram basically highlights some of the different strategies that we can use in order to address CTO PCI through an antegrade strategy. As Darshan was mentioning earlier on, as the CTO becomes more complex through the JCTO score or any sort of scoring system, we start relying more on retrograde strategies. But I feel that the antegrade field approach has advanced to a point that we're allowed to tackle more complex CTOs without necessarily resorting to retrograde PCI. So as per the Progress CTO registry, the antegrade wiring approach remains the most common approach used primarily in about 69% of cases, associated with the technical and procedural success of approximately 88%. And through new strategies, we're able to tackle antegrade CTO PCI in more complex lesions. And this is highly based on imaging, whether it's CT coronary angiogram guidance or IVIS. Targeted wire-based dissection reentry, which I'll highlight in future slides, and then use of novel device-based reentry. So when it comes to IVIS guidance, an ambiguous proximal cap can definitely make a CTO PCI more difficult. And as a result, is one of the potential characteristics of the CTO PCI that may push an operator to pursue a retrograde approach. Now, with the use of the eagle eye, we're sometimes able to effectively identify the proximal cap, and often the proximal cap reveals a shorter CTO than one would have envisioned, as well as a cap that is not very calcified. So this is an example of where an eagle eye was used to identify a proximal cap. Here's a proximal CTO of the RCA, and there was a branch that kept on basically limiting antegrade wire escalation, as the wire would keep on going into that branch when we were trying to penetrate the proximal cap of the CTO. In order to identify the proximal cap and prior to converting to a retrograde strategy, we used a workhorse wire to deliver an eagle eye into the side branch. And then we were able to identify where the proximal cap was, and it seemed like a pretty viable antegrade wire escalation strategy. And then through a second wire, we delivered a turnpike spiral, and then used pilot 200, which was initially unsuccessful, and we escalated to a Gaia third, which allowed us to penetrate the proximal cap of the CTO. Because the eagle eye basically is manual deployment, here on this IVIS, you can actually see the eagle eye in the side branch. And as we pull back, you'll see the proximal cap of the CTO coming in at about 4 o'clock. And you can see that the wire penetrates the proximal cap at about 4 o'clock. And we get a lot of information here, not a lot of calcification in the proximal cap. And we can see that the wire appears to be true lumen in that area. With this information in mind, we were very comfortable in advancing the turnpike spiral. There was a little bit of a tortuosity in the mid-segment of the RCA, so we de-escalated to a pilot 200 to try to traverse that part of the CTO. And then ultimately, if you look at the cine on the right, we're able to identify that the distal part of the wire was in the true lumen. And this is what the CTO PCI looks like at the end, with no need to resort in this situation to a retrograde strategy. The beauty of it is that the procedure, as Darshan was mentioning, often retrograde PCI can take longer, more radiation. This procedure actually started and ended quite quickly, and again was mainly guided by the use of IVIS to identify the proximal cap, and essentially converted what may have been a complex CTO PCI into an antegrade wire escalation procedure. The other part that's important is to use IVIS to identify the optimal point of reentry. So the optimal point of reentry is very important because you need to ensure whether you're going to commit to stenting versus doing an investment procedure. And in addition, there's new data suggesting that loss of side branches, important side branches, which were defined as branches more than 1.5 millimeters in diameter, can lead to increased MACE at 5 years. So here we have a CTO PCI, again, of the proximal RCA. You can see that there's retrograde collaterals from the stroke, but they're mostly epicardial and don't appear very palatable. This CTO PCI was attempted about 2 times prior by a CTO operator and then referred to our center for a third attempt. I wasn't the primary operator initially. You see here that the plan was to basically try an antegrade approach again. A 7 French JR4 was chosen, which made the procedure a little bit more difficult because of the lack of support. They tried penetrating the lesion with a Gaia. You can't really see it too well from the cines, but in the distal RCA, there was quite a bit of calcification. And they were unable to penetrate the calcification with wires. They kept on going into the subintimal space. And as you can see on the cine on the right, there were some issues with support. Even with the guide extension, the 7 French GR4 kept on being pushed back. They also attempted to deliver a recross, and then ultimately I was asked to help by trying to deliver a stingray into this lesion to see if we could re-enter below that chunk of calcium. So I too found that it was very difficult to re-enter or to actually move the wires through that calcium. So ultimately I attempted to knuckle a wire, which is successful in getting me into the subintimal space, into the distal RCA. But as you can see on the cine on the right, we were in the subintimal space, just proximal to the crux of the heart, and we definitely wanted to preserve that PDA. We tried again to deliver a recross and also tried to deliver a stingray, but were unsuccessful. So we ended up using a Gaia third to try to re-enter the true lumen through a wire-based approach. As you can see on the cine on the left, we get an impression that we might be true lumen. And then on the cine on the right, we also suspected that we could be true lumen in a side branch, but we weren't entirely sure. As the procedure progressed, we started losing retrograde visualization. We were wondering that whether we had extended a dissection and whether we should abort the procedure. But just at the very end of the procedure, the wire, which I believe was a pilot 200, ended up going into what seemed to be a retrograde collateral, one of the epicardial collaterals. So at that point, we were wondering whether we were in true lumen, how big the dissection plane was, and then where we had re-entered the true lumen, whether we were going to lose that important PDA, because if we were true lumen, this would have been the RPA. So this is a case where we are able to gently balloon and deliver an IVUS catheter. I apologize for the IVUS images. We're using a Volcano for this procedure. But interestingly, the IVUS catheter showed that the wire distally was not only in the true lumen, but also that it had re-entered the true lumen prior to the takeoff of the PDA. So we didn't even need to resort to an investment procedure. We felt that we could safely stent into the distal RCA, avoid the bifurcation, and then get a good CTO PCI result. So the IVUS proved to be indispensable in this situation to give the patient an optimal CTO PCI. And this is what the procedure looked at the end. Again, the stenting was just done proximal to the bifurcation, and we're hoping that those vessels at the end, the PDA and the RPL, will remodel now that the CTO is recanalized. Now, there's also an evolution in antegrade dissection reentry. Previously, a lot of the strategies, part of devices like the Stingray, was in a non-controlled manner, but there's now a push to use antegrade fenestration reentry to be able to achieve targeted wire-based recanalization of CTO PCI. And this procedure was initially described by Carlino and now further studied by Lorenzo Azzolini, who I thank for lending me these slides. So basically, an integration reentry relies on using one wire to enter the subintimal space and then delivering a second wire into the distal cap of the CTO. This can be facilitated by a dual lumen catheter. Then there's delivery of a one-to-one balloon through the initial wire to essentially create transient fenestrations in the intima in order to create a channel into the true lumen. And then once this channel is created, the balloon is deflated, and through a microcatheter or polymer jacketed wire is advanced into the true lumen. And the reentry can be facilitated by the use of IVUS again to size the balloon, and also by the use of cutting balloons if you're having trouble creating those fenestrations. So this is a case that Lorenzo provided to me. So it's a CTO PCI of the mid-RCA. You can see that there's quite a bit of bridging collaterals in the mid-RCA, and then pretty good retrograde collaterals from the left system. Now, they used a Turnpike LP and Fielder XDA to try to traverse the CTO, and they were successful in getting distal to the distal cap, but the distal part of the wire was in the subintimal space. Now, in this situation, they would have to resort to dissection reentry or try to essentially reattempt antegrade wire escalation or use part of the wiring. But in this situation, they decided to go for antegrade fenestration reentry. So here, they've shown how they deliver a second wire into the distal cap of the CTO. That's shown on the left. And on the right, you see that they inflate a balloon one-to-one across the distal cap of the CTO to create those transient fenestrations. And then on the cine on the left, you see that now that the fenestrations are created, they're able to deliver a polymer jacketed wire, which in this case is Pilot 200, and they're able to get into the true lumen of the distal vessel as shown on the cine on the right. And after that, to complete the procedure successfully. Another option, as opposed to wire-based reentry, is to use device-based reentry. And traditionally, we've been using a Stingray, which I have found successful for a number of procedures, although I do find that this device can be difficult to deliver, particularly when there's significant calcification in the CTO. One modification that I've resorted to use, and I know that other operators are using too, is that the stick and swab has been increasingly switched for a stick and drive approach. I do find that sometimes when I use a high tip load wire to enter into the true lumen, I'm pretty convinced that I'm in the true lumen as per retrograde cines. But then at times there can be difficulties then inserting a polymer jacketed wire. So this stick and drive approach essentially consists of doing the stick, and once you feel that you've gone through the intima, you create a 180-degree twist in the wire, and then advance the wire through the true lumen of the CTO. Obviously, this has to be done very carefully because if there's significant disease at the distal bed, you can actually extend the CTO. So it's a procedure that's more effective in cases where the distal bed is large and not diffusely diseased. Now, another increasingly used device is the recross catheter, which has a number of advantages compared to the Stingray. So one of it is that it has a port that includes a stylet, which makes it more deliverable. And it also has a core wire that makes this device more easy to deliver. And as a result, it can be used in CTOs where there's calcification. So essentially, there are two ports. So the stylet port leads you to an exit port about 8 millimeters from the tip.
Juan, can you wrap it up for the sake of time, please?
So this is just an example that I used that was lent to me by Sandra Kalra. So this is a CTO PCI of the RCA. A lot of calcification, difficulty entering the proximal cap. Sanjog used a Carlino technique to soften the proximal cap and essentially get into the subintimal space. But unfortunately, when he got true lumen, but didn't cross the distal cap yet. So when advancing his wire, he got into the subintimal space, distal to the CTO cap. And as you can see on the cine on the right, Sanjog delivered the recross catheter with the mid port pointing into the true lumen past the distal CTO cap, and he used a Judo 6 to poke through the intima into the true lumen, which you can see on the cine on the right, and then ultimately delivered a polymer jacketed wire, a Mongo, that you can see here delivering into the distal RCA. And here you can see the results of the final CTO. So take-home messages is that an antegrade approach has evolved to a point that we can target more complex CTO PCIs. This is largely based on the use of IVIS to identify the proximal cap and points of reentry. But then more advanced wiring-based techniques to reenter the true lumen, as well as device-based techniques, can increase proceduralist success with an antegrade approach, allowing a higher complexity of CTO PCIs to be targeted and antegrade. Thank you.
Thank you, Juan. That was an excellent presentation. We're going to move on with Sandro Carra from University of Toronto to talk to us about one of the most important aspects, I think, of CTO PCI and any complex PCI, which is the utility of intravascular imaging. So, Sandro.
Okay, everybody can see my screen? Thanks very much to all of my colleagues and for the gracious invitation to speak today regarding IVUS in CTO-PCI. The changing landscape of CTO-PCI and complex PCI in general requires us to step out of our comfort zones and insist on becoming better every day, getting better techniques, better with the technologies, adopting new technologies when we can find them to make our procedures safer and more efficient. So in CTO-PCI, the traditional uses of IVUS in this and in regular areas have been the typical things we talk about. What are we treating in the way of plaque composition? What's the vessel size in the way of your stent size selection? Where are you going to put your stents? How are you going to optimize your outcome? Are you sure that you can do the procedure without cracking the stents open along a big calcific shelf that you failed to prepare? But the reality is in CTO-PCI, where we leverage things like the subintimal space, we leverage things like the retrograde approach, we leverage the entire size and structure of the vessel, we have to change our thinking to be able to image all of those aspects of the case to really get optimal outcomes. So we've all seen this figure, and this is no new information to anyone that's going to be listening to this talk, I'm sure, but these are the four sort of fundamental pathways that we use to cross CTOs, either retrograde through the wall, antegrade through the wall, most commonly antegrade through the plaque, and most rarely retrograde through the plaque. But when we think about how we can use IVUS to facilitate these processes, we think about dividing them into facilitating crossing and then defining the tissue, the anatomy, and exactly where we are with our gear. And so I'll present a few cases here and we'll see if we can illustrate those things. So this first case is called Through the Looking Glass, which we've seen a little bit of previously. This is a case that Dimitri and I did together some years ago, where you have a fairly large obtuse marginal branch chronic total occlusion with a very ambiguous proximal cap. You can tell that the distal circ is down here. You can tell this guy comes up somewhere. There's nothing but epicardial left collaterals filling this. And we all know now that a much better approach to this might be IVUS guided proximal cap puncture and even STAR rather than going retrograde through an epicardial from a safety perspective. So looking at these diagnostic films, as I mentioned, there are largely left-to-left collaterals, but there's a fairly big, healthy landing zone. So this also becomes a very acceptable case for ADR, so long as you can actually get into the proximal cap without putting a hole in the side of the vessel. And that's the really big challenge that we're dealing with here, isn't it? And that is safely entering the CTO target zone. So selective injections were done here to define all of the collaterals to see if there were any safe things that we could use. And then we consider the hybrid algorithm and the usual things that we always consider when deciding which strategy we're going to use. Ambiguous proximal cap suggests retrograde might be better. Poor distal target suggests either retrograde or antegrade, depending on what part of the target is poor, whether or not there are good collaterals or bad collaterals. Bad collaterals might suggest you go towards antegrade, right? So in this situation, there was clearly an ambiguous proximal cap. That would suggest antegrade, but that would suggest against antegrade and go to retrograde. But then there was a poor distal target. So that would go against retrograde and say, let's try antegrade. And then there were appropriate interventional collaterals for some people, but they were largely epicardial. So that would maybe suggest retrograde for some or antegrade for others, right? So how do we get clarity here? And that's where you can use the intravascular ultrasound to perform the IVUS guided proximal cap puncture, where here you mark the proximal cap with the IVUS fluoroscopically. If you have a large enough guide and a thin enough IVUS, you can do this on real time. And then you puncture at that fluoroscopically co-register landmark using a directed penetration wire into the proximal cap. And then you can confirm with your retrograde injection that you've successfully entered the structure of the vessel. Now this is clearly subintimal where you can see this separation between the wire and the vessel. But that's still a win, right? Because we leverage the subintimal space. This is confirmation on the IVUS as we pull it back that we are in fact in the vessel architecture with our entry wire, right? This wire is well within the CTO segment in the interplaque area. Then it comes down to what we know how to do, which is deliver a stingray and then perform antegrade dissection reentry. You can see the dissection and reentry wire exiting through one of the side ports of the stingray with a true lumen wire position. We can confirm with IVUS, and in the interest of time, I'll move through that to yield this final result. Okay, so that's one way. That's facilitating entry. How about if you're coming retrograde? Well, this is the fundamental diagram describing reverse cart or retrograde dissection reentry, where you get two wires in opposite sides of the vessel, but both within the subintimal space. And then you take a balloon along your antegrade wire, destroy the tissue planes between both wires so that you can then move your retrograde wire into the same space as your antegrade wire. So the top 5 reasons for difficult reverse cart: there's a small balloon, the balloon is too small, the vessel is larger than the balloon is smaller than the vessel, it's a small balloon, and you're chicken. These are the words of my mentor, Dimitri Karmpeliotis. But the real reasons for a difficult reverse cart are reverse carts not performed in the optimal position. There's too much vessel tortuosity, so your wires can't connect because you can't torque. There's too much calcification, so you can't actually create a common space. The balloon dilation is not performed all the way back to the true lumen proximally. And then knuckles have caused big hematoma, so the space that you're using is large and your wires become far apart. So obviously you want to try to perform reverse cart in an area where your wires are closest together. And so this is a way to do that, right? So this is one case where it's fairly nasty looking CTO, very proximal cap there, with reasonable retrograde interventional collaterals from the septum. So the retrograde ends up being crossed without too much difficulty. This is sort of a usual standard septal type of configuration, as you can see. And then once we've confirmed retrograde wire position, we're very near to the proximal cap. There's an antegrade Carlino that's performed to get going and a retrograde Carlino that's performed to get going. And then you now have, in this dancing view, knuckles, both retrograde and antegrade. So in the same tissue plane, in the same structure of the same vessel. And so now you're able to perform your reverse cart. The challenge is, you can't seem to make the connection. Why is that? And how can you sort that out? One way of sorting that problem out is to advance an IVUS and confirm that not only are your wires both in the subintimal plane, but here is where they are the closest together. And in this situation, it actually almost seems as though they're in the same plane, right? So you may wish to then advance or retract your base of operations to find a place where the 2 wires are in different tissue planes so that you can then perform reverse cart and ensure that one wire can enter the other tissue plane. One way of facilitating this as well is to bring a guide extension catheter down on your antegrade wire to the point where you know the 2 wires are in a slightly different tissue plane, and then you can almost drape the antegrade subintimal tissue across the top of your guide extension catheter to create a drum that you can poke into when you've identified the optimal space to do your connection on IVUS. So this was the inflation at the optimal point, and these are your final results on the right side here. That's what it started with, and that was the end. And as a, I'm just going to skip through this last case because this second last case because we reviewed this already through one of my colleagues. But this is another way of defining the use of IVUS, and that is to understand the anatomy that you've created. So this was a diagnostic angiogram for CTO that I did some time ago. And unfortunately, for a variety of reasons, we failed. And so we had to do an investment procedure. And when we did an investment procedure, we dissected into multiple tissue planes. So you can see you have TIMI3 flow into this RPL system. You have TIMI3 flow into what I think is the starting of a PDA. There's a couple of different branches coming out. We're reasonably happy with this, and we decided we're going to go ahead and invest. Now he comes back 8 weeks later saying, I'm feeling better, but not 100%. But shockingly, what you see is 1, 2, 3, 4 branches towards the end of the vessel now, whereas before you only had 2 real branches at the end of this vessel, right? 1, 2. So you now have double the number of branches, right? This is why he feels better. This is probably the lesion that's causing him his problem, this 90% proximal. There's a nice myocardial blush distally. The challenge is there's a big dissection flap right in the middle of this large bifurcating branch distally, and that dissection flange goes all the way up the vessel. So how do you manage this problem? Because if you stent in the mid vessel and you cover the entry point of this probably false lumen into this true lumen channel that then differentiates into multiple true lumen channels distally, it's like you're going to have to pick one of the kids, right? Where you're going to shut something down. So one way to optimize this is by identifying by IVUS where the precise connection is between all of these lumens and stenting just proximal to that, given that distally there's TIMI3 flow into all these branches, and proximally you have a tight lesion that's likely responsible for the patient's symptoms. So when we review the IVUS, and I'm just going to scan backwards quickly here, we see that here we're true lumen, and here we're false. So what we need to do is fluoroscopically co-register right there, which is the connection between the true lumen and the false lumen. And that helps us identify exactly where we're going to end up putting our stents, right? The rest of this is all true. There's a small segment of false up top there, right? And so that's what we ended up doing. We recognized that this was a massive vessel, and we placed a big proximal stent just proximal to the area that we co-registered with the IVUS to define where the connection was between all 4 of those lumens, 2 of which were supplying one set of dissection planes, 2 of which were supplying the other. And after stenting, all 4 branches are home. He continues to have a very nice myocardial blush. These all connect to the true lumen, and he's back to work and asymptomatic a year later. So IVUS allows us to clearly delineate not only where we need to make connections, but what the nature is of the tissue that we're creating and the tissue that we're stenting. And then, of course, where the connections occur between the various lumens that we're creating during CTO-PCI. The use of IVUS now is no longer the new way, it's the standard way. And to really do CTO-PCI well in the future requires precision and requires us to use the very best techniques and technologies at our disposal. Thanks very much for your time and attention.
Thank you, Sanjay. That was an extremely thorough description of the use of IVUS. If I have a question for you, is IVUS an option in these complex cases, or is it a must? And in what percentage of your cases do you use intravascular ultrasound when you do CTO?
Yeah, that's a great question. I mean, in my opinion, and I realize that there are differences in different markets across the world, but in CTO-PCI, I IVUS 100% of my CTOs because they're too difficult. The procedure is difficult as it is, right? Why make it harder by trying to guess, right? The tissue is calcified. The tissue is difficult to expand. The tissue is difficult to understand. So, you know, we need more information than the angiogram provides. I recognize that even in the North American environment, the average uptake of IVUS is like 12% versus in Japan, it's, you know, over 90%. Why is that? Well, it's not because operators are so much better in Japan than they are in the US. It's because of the fundamental differences in the system and reimbursement and time and logistics. And we as physicians, I think, need to just move beyond that. If we're going to take on these complex procedures, we just need to accept the fact that we have to do them right. There's recent evidence coming out showing that if you lose a 2-5 side branch in a CTO, your MACE rate goes up, so that you should never have done the case in the first place. These are the types of things that the use of intravascular imaging can prevent, and the use of intravascular imaging can, you know, facilitate in the way of safe procedures. And that's really why it's an absolute must in, you know, the 90% of procedures that I do it in. The only ones I don't do it in are the ones where the patient's too sick or we're doing something else or I can't get the darn device down. And that's the minority.
I couldn't agree more, and it's also beyond safety and success, but also durability of the procedure. So I personally use 100% intravascular imaging in my cases.
Yeah.
One second quick question, I would give this to Ahmad, if he's still on. Ahmad, talk to us a little bit about the Gaia wires. Is this just another wire, or do people need to have some kind of familiarity both with the engineering and the way it should be used? Because we've seen some great results with the Gaia wires, but we have also seen some not so great results. So what's your advice? Do they need to get some proctoring? Do they need to go through some modules? Is it the same wire or is it something different?
Thanks, Dimitri. Yeah, I mean, Gaia wires are not first choice wires for anti-graded wire escalation. And the reason is, I mean, that's my personal opinion, is it has tapered tip. It does give you that tactile feed that sometimes you miss with the Pilot 200, for example. But the fact that it has a tapered tip, it can go into microchannels or bridging collaterals that, unless you're sure that where you're going with an when you go antigrade, it can cause harm actually and perf. So it is also like the Gaia 2, for example. It's 3.5 grams. It does have a lot of tip load, so you can actually develop that, deploy that tip load into a lower area, so it gives you more penetrating force. But that could also could be a weapon against you if you don't know exactly where you're going with that wire in. I think there are safer wires to use initially before you pick the Gaia wires, like the Pilot 200, for example. So before using it, I think yes, asking your more experienced operators, getting proctored about it a little bit, also is a very good idea.
Yeah, I agree with you. I would add that in addition to the tactile feedback, which is not that great with the Gaia either, it's also a visual feedback, as you showed in your case when it's a little bit stressed and so on and so forth. And also they can exit through the body of the CTO, which is very almost unheard of with the hydrophilic wire. So my recommendation, my advice to operators is that it's not just another wire. It has different properties and they need to know exactly how to use it, and there are modules and there are proctors, and they need to seek advice before they use them. Also, the Gaia Next wires are completely different animal. They have higher tip loads. So what used to be Gaia 2 is now Gaia 1 Next, and the Gaia 3 is an extremely penetrating wire, so people need to be very, very careful. And the last brief question, if we have time, is for Juan. Can you give us some tips and tricks to increase the success of antegrade dissection reentry, like avoiding, for example, antegrade injections, or using routinely a guide extension, or aspirating before you do your reentry, and so on and so forth?
Yeah, so it's a very good question. I mean, at my center, we use predominantly an antegrade approach. I really feel that as you pursue antegrade reentry, you need to be aware of the size of the subintimal space that you're creating, particularly in obviously ADR, because it may actually not only lead you to fail, but even if you succeed at getting the true lumen distally, you might be left with doing either a more complex stenting strategy because of the degree of the dissection planes, or resorting to investment procedure. So I would say one of the main things is to try to reduce the size of the subintimal space. Sometimes you can use a guide extension to try to prevent the amount of antegrade flow going into the dissection plane. Obviously, I would avoid basically antegrade injections at all costs, particularly when you feel that you've re-entered the true lumen. And then the last technique, particularly when you're doing ADR, is to focus on doing appropriate straw, because often it can increase the viability of dissection reentry. So I know that we use straw all the time with the Stingray, but with the recross, there's the opportunity to basically do almost live straw as you try to poke the subintimal space, because even in between wire exchanges, you can actually get seeping of blood into the subintimal space. So I would say straw would be first and foremost for ADR. But I think the most important thing is to be always mindful about the subintimal space, even as your procedure progresses, by, again, using a guide extension, preventing antegrade injections, or even as you do wire escalation, to be cognizant of the knuckling, because often, as you knuckle through, if you're not using an ADR, if you're trying to do antegrade wire escalation, you're creating a subintimal space that's large enough that ADR procedures will not succeed at a later time, even with straw.
And I would add that just stay tuned, because there are new re-entry devices that are in the pipeline right now that will do exactly what you said. They will allow more effective straw, essentially aspirating the subintimal space and restoring visualization of the distal vessel, and making kind of collapsing the tissue plane so that you can make the re-entry easier. And also, don't forget the crossbows, which I don't think it's a very good starting device. But once you get into the subintimal space, if you want to complete your last 2 millimeters of dissection, it's only a 1 millimeter automatic knuckle, so to speak, catheter, and that facilitates re-entry by reducing the amount of injury to the subintimal space. So be very, very careful. I agree with you with the amount of damage and hematoma that you create to the subintimal space. Thank you very much, gentlemen, and then we're going to go into sections. Yeah, go ahead.
The interruption, sir. We will move on to live case, and afterwards we will continue with the lecture, sir.
You want to go down now to the live cases?
Yes, sir. Live case. Both the live cases are ready. And
okay, of course. Do you want to introduce the panel? Because before we had some panelists that they were not on board.
Yeah, one second. Yeah, I would like to welcome the chairpersons of the live case, Dr. Sanjog Karla, Dr. Dimitrios, and Dr. Aditya Kapoor has structured some emergency. And I would like to welcome other panelists, Dr. B.C. Kalamat, Dr. Satyendra Tiwari, Dr. Naveen Garg, Dr. A.K. Srivastava, Dr. Narasaraju, and Dr. Sridhar Reddy Pitti. And over to you, Dr. Dimitrios.
Okay. So as I see, we're going to go with Dr. Kapoor from Medanta Hospital, Delhi. Is that the first live case?
Hello, everybody. Are we audible?
Yes, you are.
Yeah, thank you very much. And good evening to all of you. And some lovely sessions in previous 3 days with TCT India. I think it's a privilege to be here presenting this live case from Vedanta. I'm joined by my full team. He's Dr. Himanshu Dabral, Dr. Saqib, Dr. Tejbir. So all of us are showing this live case from Vedanta. So thank you for having us here. I'll start with the historical aspects of this case. Dr. Saqib, can you go through the slides?
So this 60-year-old gentleman, a known case of type 2 diabetes mellitus and a known case of coronary artery disease, presented to us with chief complaints of angina on exertion, NYHA class 3, and dyspnea on exertion, NYHA class 3. On 8th of July, this patient had a sudden onset chest pain for which he sought a medical consultation at peripheral center, and he was referred to the Vedanta and diagnosed as ACS. So next slide, please. On arrival at Medanta, we did a 2D echo which showed akinetic LAD territory with LV ejection fraction of 25 to 30%. Subsequently, coronary angiography was done which revealed triple vessel disease. And then cardiac PET was done which showed some hibernation in the LAD territory. So based on these findings, patient was advised to go for CABG, but in view of comorbidities and refusal by the patient to go for CABG, he was planned for multi-vessel stenting with stenting to RCA, bifurcation stenting in the LCX and OM, and stenting to LAD. Now
I think the plan would make sense once we show you the angiogram. So can we have the angiogram? Yeah. So this is the angiogram which we have done 2 days back. As you can see, the right coronary artery is very critically narrowed in the proximal segment. And there are significant collaterals, filling up the septal branches of LAD. And almost it seems that LAD must have occlusion in the proximal segment because there are good collaterals reaching to that segment of LAD. Next one. So these are all RCA shots. Yeah, next. 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 Okay. And this is the left system. So it's extensive disease. Next. Okay. Next. Okay. So this is LAD, 99% subtotal occlusion. There is some thrombus in the mid segment. And the distal segment is very faintly visible. TIMI 1 flow. Come back. 1. Yeah. And this is areocaudal view, also showing us there's a significant and critical disease in the circumflex also. and the upper obtuse marginal is also ostially narrowed, plus there is a critical narrowing in the circumflex also. So I think that also makes a good bifurcation lesion in the circumflex, and LAD is, as I mentioned, is subtotal occlusion. So as far as history narrated by Dr. Saqib, I think this patient had anterior wall MI about 20 days back, and now he landed up with heart failure few days back with us. So we stabilized this patient. On echo, LAD was fully akinetic. We went ahead with the PET cardiac. It showed a significant hibernation in the LAD. We discussed all the options with the patient and patient's family, CABG, as it's a triple vessel disease, extensive disease. But at no point family was ready for surgical intervention. So we are all here, and also we discussed with our surgeon. Since LAD was akinetic and EF of around 25%, they were also not very keen going ahead with that. But since there is a hibernation, we are all set to show you the revascularization plan. So can we have some inputs from the panel here, and then we show how do we plan and how are we going ahead?
Well, that's an excellent case with a lot of points of discussion. One of the key things here is what are the hemodynamics of the patient, like a right heart cath, cardiac output, and whether he has a presence of a thrombus in the LV, and what the peripheral vasculature looks like in case you need support. That's part one. The second thing is whether you're going to do most of the revascularization in one setting. Second is what areas are viable, and if you're going to stage, how you're going to start. So I will pass it over to Sanjog just for a very quick comment so that we can let you work, because that's the most important part of the live case, not us talking, but you doing the work.
Yeah, no, nice case. I think a patient who has demonstrable indication for revascularization with all of the salient points that were brought up by Dimitri a few moments ago. I guess the question that comes to my mind beyond all of the points that Dimitri had just brought up is, depending on the hemodynamics, if the hemodynamics are deranged at the beginning end of the case, so you put a right heart cath up and you define that the cardiac output is poor, but the pressures are high, do you stop and do you take the patient off, optimize? Or do you go ahead? Are you going to use mechanical circulatory support, or is it, a secondary access when doing the case? And then are you going to start with the LAD? Because arguably, if it's already hibernating and you're not encumbering anything, you're not going to have much in the way of injury to the myocardium. If you get into trouble, you're going to go after the RV first, or the RCA first, because it's arguably the biggest bang for your buck and gives you the biggest backup.
Yeah. So I tell you about the hemodynamics. The patient had been clinically stable for last few days, although we have been diureting the patient and getting him decongested. At X-ray showed mild congestion. Pressures were okay. There was no tachycardia. So as per plan of revascularization, as Dr. Sanjog just mentioned, we went ahead with the RCA first, as it's a very simpler lesion, and we have already stented that. I'll just show you a few shots of that once we have done a RCA stent, but I think nothing eventful in that. So RCA stent has gone fine, and it's okay. But about doing the LAD first, we also thought that, but sorry, I haven't shown you a spider view. Can you show a spider view? There is an ostial involvement of the LAD also. Yeah. So LAD ostially is diseased. So now what we have done, after stenting the right coronary artery, we have wired the LAD, dilated the LAD with balloon 20, 15, and established a perfusion into the LAD. And then we plan to go ahead with the bifurcation circ. As you know very clearly, if we stent the LAD, there may be half a strut into the left main, and we may face difficulties getting the hardware into the circ. So that is the plan. Please show next. Now the procedure. So I'll just show you that how does the perfusion look like after we have dilated the LAD. This is the RCA stent that has gone in uneventful. I'm not interested in showing this. Next. Please go next. Okay, next. Next. There was slight issue wiring the LED at one point, but again, nothing, not a big effort. So wired the LED, then wiring the circ, then dilated the LED to maintain a perfusion. Next. Okay, so this is that balloon dilatation of the LED is not visible, but I'll show you how it looks after the balloon dilatation. So then we wired the circumflex. As I mentioned, because of the ostial involvement of LED, we do plan to put stents into the circ and do the bifurcation stenting here. So wired both and then dilated with the Wolverine cutting balloon Boston, the ostial of obtuse marginal first. This is 2.5 into 12 Wolverine, and we have done the cutting balloon of the ostial obtuse marginal first, and this lesion also into the circumflex. Next. 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 So this is how it looks now. Next, show the LED also. Yeah. This is how the LED looks. There are good septal branches, although on echo it looks akinetic, but I think there's a significant hibernation in this area. So this is where we are at the present moment, and we do want to showcase the bifurcation stenting, that how do we plan for the circumflex. Okay.
Dr. Rajneesh, this is Aditya here. Hi, good evening.
Hi, Aditya. Yeah.
Hi, and hi, Sanjog. Good evening. So
Good evening.
I think that's a great strategy, because doing the RCA first is not a bad idea at all. It's a simpler lesion. I just wanted to ask you quickly: is there some disease in the ramus as well? Because I'm sure you leave the ramus alone, I guess.
There is some disease in the ramus also.
Probably you will leave it alone, isn't it?
Yeah, that's what we are still thinking that whether to touch that or not, because it's quite complex otherwise.
Yeah,
and we know the guy's LV function is 25%.
Don't want to.
So yeah.
So look forward
Keeping in mind there's arguably no reason to do everything all in the same procedure, right? Within contrast limitations, radiation limitations. Particularly, it's interesting, this whole concept of multi-vessel PCI in the context of poor EF, in our experience, whether you're on support or non-on support, they go in with an ejection fraction of 20%. And by the time you have IVISed and optimized and taken high pressure balloons up, you walk out with an ejection fraction of 15% or 12%. And that's directly indexed to the number of vessels that you're doing and how well you're hemodynamically optimized at the beginning. So you can make the argument that if the ramus is certainly diseased, but there's nothing in front of it, and your bifurcation stenting is limited to the circumflex territory, or you're going after the LAD and you've done the right, then there's nothing wrong with keeping the guy in hospital for a couple of days, bringing him back, staging the other two vessels. If you're on support, it's a slightly different discussion, I think. Any thought to have been putting up a right heart cath and monitoring the pulmonary pressures during the case to try to define whether or not your hemodynamics are changing?
I think yes, it's a nice thought, and we all think of that. And so given that, we first check the echo with the IVC and pressures of the right side, there was mild TR. So PA pressures were 30 to 35 at the time of starting the case. So yes, it's in our mind. We have lines ready, but not at the moment. We haven't gone ahead with this right heart just prior to this case. And next show. Come caudal, please. Little more caudal.
Actually, coming back to Sanjog's point about multi-vessel PCI and how hemodynamics change during the case. We recently launched under Greg Stone in the US the Protect 4 randomized trial, which is going to answer a lot of these questions, like whether you have a CP impella in with or without right heart cath, and there are several sub-studies on it. Is going to make a difference. It's a strategy trial. We've already enrolled 3 patients, and a lot of these questions, hopefully within the next 5 years, will be answered. Right now, it's pretty much just a judgment call.
So I agree, having a support is always good, but somehow the financial constraints still exist in India with some patients. So we were unable to take that call. But yes.
Yeah, it's not to suggest though that for this case you have to have hemodynamic support. I don't think that's what's being suggested at all.
Yeah.
Because the lesions themselves are straightforward.
What I said, Sanjog, is that there is equipoise
Agree.
And that's why we're doing a randomized trial to try to answer these questions. I'm not suggesting that it should be done one way or the other. I'm just saying it's an unanswered question.
Yeah, completely agreed. I think that was the point that I was about to make as well, is that, one is not suggesting that that you need hemodynamic support. I think what we are suggesting based on clinical experience is that you need a good understanding of the hemodynamics before you go into the case.
Well, yeah. So this is what we plan. We just plan a mini crush here, the bifurcation of circumflex, and we are in with both the stents. So the longer stent we are planning to be mini crushed with the shorter stent into the obtuse marginal. Check.
And so this is a classical mini crush, as opposed to doing a rewire and kiss before you crush with a stent.
Check. Okay, go on the longer stent, 2.5. No, this one. This one, yeah. Huh?
This is one.
Huh? This one. Okay, just check. Next second.
Dr. Kapoor, did you perform intravascular imaging in any of the vessels before your stenting, or just to assess the size of the vessels and whether you actually need to do a bifurcation stenting? Sometimes
we do plan to use imaging, but as I mentioned, there's a LAD infarction, EF is down. So we want to open the vessels first, and after stent, I think I'll show you the imaging part. I'm sorry we didn't use it prior because of the slightly borderline hemodynamics, although it's okay, stable, but still, with the recent infarct and, okay, go on this 2.5. Yeah, go up, 6, 8, 10, 12, 14, down. Come in this area caudal. Check. Okay.
I guess the challenge without intravascular imaging here is the stenting strategy that you've chosen. There's a pretty good going size mismatch between the proximal part of the circumflex and that branch.
On the same.
So depending on what your stent strategy and your stenting platform is, you've got to make sure that you can actually expand your proximal stent to address the size needs of the proximal circumflex as well as into that first OM.
Check. Okay, so this is one stent we have adequately dilated. We're going to take this wire out. Okay, let's now fix the other stent. Check. Okay, give me caudal, please. Okay, keep it here. Keep it here. Come back. Yeah. Caudal. Okay. Yeah, I agree. There is a discrepancy in the size here. The proximal circ looks much bigger. And so we have taken a 3O stent here, although I was thinking 2.75, and we do plan to just deploy it at a lower pressures, 5 or 6 atmospheres, and then dilate inside. Check.
And what's the platform of stent that you've chosen?
Onyx. Both the stents are Onyx. So they have good expansibility, we know. Go up. 4.
Actually, for the audience, that's a very important point, because you need to know what stent you're using, because not all stents can be post-dilated to the same degree. So it's critical knowing which stent you're using. Because, for example, a 2.5 Zions will not go to the same size as, for example, a 2.5 Synergy. So you really need to know how much you can expand your stents.
Yeah, so I think with Onyx also we're pretty comfortable that it can go up higher in size. The 3 can go up to 4 easily. So I don't think that problem is with Onyx. See, this is how it looks once we're deployed. So still I agree that proximal circ looks almost 3.75 to 4. So this is, but now we are going to dilate it inside with 3 first at a higher pressure than 3.5. And now I think I can show you the after dilating it with 3.5 in the proximal circ, I can show you the OCT picture of this place, and then go on to do the LED.
What is the creatinine of the patient, Dr. Kapoor?
Creatinine is normal. It's 1.0.
Yeah, I think the case of going, I think that the description, at least on this side of the world where intravascular imaging is used, is typically pre-PCI to define your landing zones, define your stent size. And I think arguably, once you've done your stenting and you've actually put balloons up in these low EFs, you've achieved the stunning of the myocardium that you're worried about. So at that point, putting more gear down the vessels, I think, it depends on which side of that equipoise argument you sit on. You could argue that it's actually more hemodynamically perturbant to bring the devices down after the stents are in because you've already irritated the heart. But the main point that was just made by Dimitri, I think very nicely, was that if you're going to choose afterwards to do your imaging, you have to make sure that the stent platform that you've chosen has expansibility enough so that even if you're wrong, you have enough play within the stent sizing to be able to get appropriate stent expansion proximally. Because we know that one of the #1 reasons for poor outcomes in what we do is we choose stents that are too small.
The other comment I would make is that in a case like this, I would personally not use OCT. I think OCT is a phenomenal imaging modality.
Agreed.
But someone who is hemodynamically compromised and we're giving contrast, adding 20 or 30 more cc's of contrast is probably not the most prudent thing to do.
I agree with this aspect. Obviously OCT requires some more contrast and a high pressure injection into the coronaries. So we also thought of that, but somehow our IVUS was not fully functional today. So OCT is right in place.
Okay, so end of argument then.
After this dilatation, I'll show you the OCT. Go up. 6-8.
Like I'm getting a message from the organizers that the other live case is also ready. So we can either switch over there for a moment, or if you think you're going to do the intravascular imaging right away here, we can.
Right away, I think I just required 2 minutes to show you the OCT. We're ready with that. Okay, show
Sounds
me.
Good.
Show this stent boost. Okay.
You're going to recross and do your kiss, right, Dr. Kapoor?
I'll do that.
So why don't we move into the other case?
Okay. You can do that.
And then you recross. You do your final kiss. You're probably going to do a pause before recrossing, and then we can have a more comprehensive idea of what has happened so far.
Yeah, that also is fair. That also is fair. Yeah.
Thank you. Thank you. So let's move to the next case, please.
Okay, go up here. 6-8.
Good evening. Good evening.
Good evening, Dr. Kumar. This is Dimitri here with
Dimitri, Sanjog, and Aditya Kapoor. Actually, I'm from Kerala doing a live case now. We'll just show the case directly because actually we have crossed some. We wanted to show everything, but we were thinking that you come back at 8:15, so we started a little early. So can you just show the
slides? Yeah. Good evening to all. Our patient is a 52-year-old male. Next slide. Next slide, please.
Next.
Yeah, he's a 52-year-old male who had a recent inferior MI. He underwent angiogram elsewhere, which showed a LAD CTO and an RCA 99% lesion, and subsequently underwent a primary PCA to the RCA with 3.5 into 24 tests. And they had attempted PCA to the LAD in that same sitting, but it was they failed. And so now the patient is being admitted for reattempt CTO PCI. Next slide. So this is the ECG. ECG, we can see that the R waves are preserved in the LAD, in the anterior leads, and there is some ERS pattern in the ECG. Next, his echo showed some RWA in the anterior wall, but the thickness was preserved and there was no scarring. The EF is 50%. Next slide. His hemoglobin is
Have we lost the feed there?
Lost the audio.
recrossing the wire into the circumflex to do the kissing.
So
And
score is 2.
Now today's angiogram will show is Sanjog and excellent collaterals from the antegrade. Can you just show the angiogram today?
So this is a
Yeah, but we were thinking that we will be just doing an retrograde CT intervention and demonstrate that. But you can see that minimal flow from the antegrade as well as the retrograde.
It looks like there's a connection there.
Excellent connection. So we actually took a right coronary, right catheter. Can you just show that? So excellent connections. So next shot. Excellent connections and multiple collaterals. Now, you know, Sanjog, actually it can create problem also. At the same time, it is an excellent connection. Almost all the connections are collateral CC3 or CC2 minimum. So we just took a wire. Actually, I took a Caravel with a filled FC wire. Probably the approach will be different. Actually, that was not the vessel I was just looking for. That's not the connection I was looking for, actually. No, that is not.
And so you chose an upfront retrograde approach here.
Actually, I was thinking that will be because in the teaching program, we thought one of the retrograde cases to be shown. That is why I was thinking that probably I could have gone integrate also, but this was not the vessel, but actually just a little distal part is the ideal collateral. So I went here, I just entered the right track. To my surprise, the wire went very fast to the upper branch, that is to the LED. To my surprise as well as to my luck.
And the wire that
we actually planned
the wire that you chose?
The cyan black was the plan to wire, but actually it's taken a filter FC only. We did not change the wire, but it has gone easily. My plan was to take a cyan black. Usually my wires are cyan black, Suho 3 and XTR are the wire for septal channel crossing. So it is Caravel gone easily up.
And just as you show the pictures, can you comment on your technique to bring the Caravel through the septum? Are you gently pushing it? Do you spin it? Do you do a combination of both?
No, Sanjog, actually, I will take the wire into one of the major septal artery down or a diagonal artery down and then take that. But luckily the wire gone down, so I was not having any difficulty. Can you show the next one?
That's an important point to make, is that this is not a microcatheter that's meant to be spun, and the tip will break if you spin it.
Yeah. So next, this actually gone. Now the septal collateral, I saw that, just did a check. Till now I am not doing any check to avoid unnecessary contrast usage. So next, so this I was checking, then I understood that I can push the wire, and now I saw there is only a little movement. Next, this is the first check I did. I made a different deflection of the wire. Because I know that the wire should went, and now the wire went in. Next, so I just checked whether I am in the right place or not. Yes. Now I came back. Next. So this is the place I just went. I understood I am in the LMCA because of the roomy LMCA. So I did not take any antegrade wire till now because there was no need of anything. Now I understood it's a roomy one. I made some changes in my wire positioning and the catheter. I think next, same thing.
Yeah.
Oh, it is a.
Oh, have we lost the audio again?
So, Jog, while they come back again, what do you think? Would antegrade approach? What would you do? Would you attempt an antegrade first, or you would go retrograde?
Yeah, so I mean, we're giving that some thought. Dimitri, I know, is on the line as well. I have to admit, having been a part of the retrograde paper that came out of Open, which is a registry of 1,000 cases with nothing but expert operators who do over 100 cases a year, we demonstrated pretty clearly that retrograde complications are higher than antegrade complications in the short term, and this is a 5-minute antegrade case. So I don't think that I would take a retrograde approach as my primary approach in this case. I think that it is worthwhile mentioning that there's a side branch, a decent sized diagonal coming off in the middle of the occlusion segment, right? So if you're not going to go retrograde true to true, if you, let's say you end up subintimal antegrade and then you decide to come back retrograde, then it's going to be important for you to make sure that whatever connection you make, you're going to do with a guide extension catheter proximal to the ostium of that branch. Absolutely. So that you own that branch, and you don't end up losing it.
Because I agree, but Dr. Dimitri, even I may be wrong, but I felt there was a strained channel antegrade as well.
There was.
I was a co-author with Sanjog and Darshan's paper. Actually, I was the senior author on that paper and several other retrograde papers. This is an antegrade case. And retrograde obviously can be used as a bailout. I'm sure they're going to do great. The great operators, very experienced, but for the broader audience and for the didactics of the session, this is not a retrograde, primarily retrograde case. I also didn't like the fact that there was a lot of manipulation of the wire close to the left main without clear understanding of whether I think it was a C on black, was true to true or not. That would be a point where I would probably throw another wire in the circ and then IVUS, identify the ostium, and then maybe put an antegrade wire and a guide extension. One of the most catastrophic things that can happen in a situation like this, trying to re-enter into the left main, is not to re-enter in the right place and shut down the circ. But again, I'm sure the great operators are going to define this is just points for the broader audience.
I think as a general point, if I'm ever coming retrograde from the right to the left system, I always have a safety wire down. Always, always, always. There's a safety wire down whatever donor vessel I'm in. And there's generally a safety wire through the left main if I'm coming retrograde up from the right system. And I have to make a connection anywhere in any of the proximal vessels, because I think the risk is just, it's not worth one wire to endanger the left main, particularly when your occlusion in the LAD is relatively close to the ostium and the ostium is diseased, because it's, you know, I mean, the nature of a Xi'an black wire, it's a relatively soft tip wire, but it's polymer jacketed, right? So you have no tactile feedback. And that means it's going to get into plaque very, very easily. And even if you end up coming out true to true, if you have a dissection plane that you create unbeknownst to you, and that dissection plane advances, and you then don't end up doing intravascular imaging to define where that dissection plane starts and ends, you may end up having troubles with your stenting as well, right? And that's just yet another reason to keep a safety wire down. So I think we're still off on the audio. Is that correct? If so, then why don't we move over to the other case? Okay, we can move back over to Medanta, please.
Yeah, so should we go ahead?
There we go.
Is it our turn?
Hi, Dr. Kapoor, we're back. We're having some audio issues with Mediterina and Kerala, so we're back with you.
Yeah, so we'll tell you how we have done the next steps. Please show it from 4 or 5, views back. Please show. So we recrossed the wire, did the kissing after doing the pot, and after the kissing, we have taken the OCT image, which we are going to show it to you. Please show. Come back, come back, come back, come back, come back. Yeah, please more, further back. Further back. One more back. Yeah. So this was here. Once we stented, I did the pot with 3O balloon at 22 atmosphere for the proximal edge, and then recrossed. Next. Yeah, so this is a wire recrossed. Next. And then this is a kissing with 2.5 into this is a 2.5 10 balloon, and then that is a 3 balloon. So at balanced pressures, this is a kissing done. Next. And then can you run the OCT image, Gaurav? So after this, we have done the OCT. Yeah. So is it visible? OCT is visible on your screen?
Yep, we can see it.
Yeah. Come back, keep coming back. Okay, so this is the distal edge, a very minor, but I think it's very small, and it looks well opposed, well expanded. And this is the lumen of the other branch across through the strut. Yeah. Next, please come back. And here also, where the vessel was looking bigger, it looks well opposed. So after the pot. And this is the fine. Yeah.
What was the balloon size you used to pot proximally?
3O balloon at 22 atmospheres. I was thinking 3.5, but then visually it was looking good. The balloon dilated in that segment. So now OCT.
So you have your OCT. So what is your what's your diameter from external elastic lamina to
the
external elastic
proximal
lamina?
segment diameter of the stent? Yeah, here. No, slightly,
ultimately,
slightly distal, slightly distal. Slightly distal.
Ultimately, we know that it's not really the apposition that we worry about acutely, right? It's the expansion. It's making sure that we make the stent as large as we can. So if we're, that's right. So 397, right? So you have some room to make that bigger.
3.57.
Right. So you still have some room to make that bigger, particularly given that OCT discounts the size in comparison to IVUS, right? It's systematically undersizes.
Yeah, I agree.
Do you think it's reasonable to take a 3.5 balloon up there?
We can do that. 3.5 balloon. 3.5 balloon and the same 2.5. 3.56, yeah. And then after this, I think we'll tackle the LED. So as I mentioned, we have to start from the ostium, but I'll give you a kissing balloon with 3.5 and 2.5 balloon. You know what's happening. So it's not only 3.5 with the 3O balloon with pot. We have also given a cumulative 2 balloon dilatation. So that is probably that's the reason it looks well opposed. But I think we can do 3.5 and then do the kissing again. Have the two balloon.
I mean, if you look at the sort of more contemporary bifurcation data, they will suggest that you do a final pot after your kissing balloon inflation to make sure that your proximal vessel circular, right? So if you've done a kiss now and you're satisfied with your kiss, what's left is the proximal pot with your 3.5, right?
I hate to disagree with you, Sanjuk, but I don't buy into this final pot. I know there are some shear stress studies and so on and so forth that if you make it circular, you may have some advantage, but I'm not really convinced. So I don't routinely do a final pot. I think the most important thing is to do a pot before you recross, so that you make sure that that you recross at the right spot.
You know, Dimitri, for what it's worth, I never used to do that proximal pot as well. It's been great working with Vlad Javik here, who's a bifurcation expert and is part of a lot of those larger trials. And what I've noticed with him on imaging,
10-12 down.
When I have not done the proximal pot, it's not so much that the stents aren't opposed; they look great, but that there are stent struts that are pointing downwards into the lumen between the joint point of the two balloons. I don't know if that makes a difference because the minimal lumen area is pretty big, right? But I've convinced myself that if you don't have that and you can create that with a single balloon that you probably have open already on the table, there's nothing wrong with doing that.
Okay, go on to 2, 4, 6, 8, and 3.5.
Although for the record, that's not as visible on IVUS as it is on OCT.
3. Down. So we have done both the steps. So I agree there is some debate that, to end with the final kiss. So I've done pots and then the final kiss. Pot again done with 3.5 at 14 atmospheres, and then the kiss again with 3.5 and 2.5. Please show the kiss again. And now I'll show you the angiographic view. May not do the OCT again. So it was not, apposition wise, it was not, I won't say that we found a malapposition, but still I think as the vessel size was looking greater, so we have done it. The reason I said, although we have done the pot at 3, but cumulative balloon inflations might have attained that size which we wanted. So this is the final picture of this bifurcation. Yeah, I think it's looking pretty clean, and I hope all of you would concur with this. And now I'm taking the wire out.
So you've done the right now, you've done the circumflex bifurcation. How much contrast have you used? How much radiation are you at? What are your hemodynamic indicators right now?
So can anybody tell the radiation part? Contrast is right in front of me. I think we have done 120 ml, 120 ml up till now. Somebody can give an answer on the radiation part?
Radiation 6449 milligrays.
Sorry, did you say 6449 milligrays? So 6.4 gray?
Yeah.
So 6.4 gray is a fair amount of radiation, particularly
that's
when that's a massive amount of radiation.
That's a lot of radiation, and you've been working in the same view,
A
for
similar
the most part of the bifurcation.
Okay, Dimitri, can you comment on sort of what the guidelines are in North America when you cross 5 gray?
Well, there are not really guidelines. I mean, the less you use, the better. The issue here is that once you get at 6.4 gray, and with modern equipment, you can actually map the radiation entry zone into the skin. But 6.4 gray is a lot of gray.
Yeah, that's a fair amount of radiation in one spot.
Yeah.
We had a mandatory reporting protocol actually, where we had to do follow up for radiation skin injury at any point beyond 5 gray.
Of course, we have the same protocol as you remember, but it's not like a strict hard.
No, the hard cut, I think in the States defines 10 gray as a sentinel event, which for the audience is the same thing as cutting off the wrong leg if you were to do a surgery. So
yes,
so 6.4 is more than halfway there.
Yeah, and the issue is that it changes. It differs from state to state and from country to country. So people who perform complex PCI need to consult with their physicists and make sure that they know the exact limits of what constitutes a sentinel event, because it's a big deal. Not only legally, but for the patient as well.
Yeah. There's a series or a paper that was published by Steve Balter at Columbia, whom obviously we both know very well, that documented the nature of a radiation skin injury following a 10 gray procedure. And you see those pictures once and it's humbling. The patient described it as the feeling of someone putting a hot baseball bat into his back all the time. So I think it can't be overstated how important it is to make sure that the radiation is watched very carefully.
Now, the other issue here, besides the radiation, is whether you do a crossover or you try to nail the ostium. And in all honesty, I think that's where intravascular ultrasound is of paramount importance. And personally, I'm not trying to nail ostia. I'm just doing a crossover if the ostium of the circ is normal.
Absolutely agreed. Exactly the same thing I do. I think if you have a landing zone that you can define by intravascular imaging, that's fine. Otherwise, there's little tax to crossing over into a left main and making sure that the stent is EEL to EEL sized.
And we also know that if you have ostial LAD disease, in the vast majority of cases, the plaque extends to the distal left main. So the patient may come back 6 months from now and with restenosis, in segment restenosis in the left main. So I think it's not worth wasting time, radiation and contrast if you have good information from intravascular imaging to just do a crossover into the left main.
So while the important discussion is going on radiation and radiation protection, I think I'll stick to my case. We have done a LAD stent also starting from the ostia. Can you show the views? Yeah. So previous view, previous. So this is the positioning. Next. Yeah. So next. Next. No, come back. Next. Next. Yeah. So this is the stent deployed right at the ostia. I think hardly any protrusion, very minimal into the left main, but we have well covered the ostia and AP cranial view. Next. Okay. This is how it looks. We are on to going ahead with the post dilatation with 3O balloon. We have taken a 2.75 based on the distal sizing.
We'll let you do that and do the imaging post while we move over back to Dr. Pratap at column.
Sure.
I think they're back up, and we'll see you then. Looking forward to your final result.
Yeah.
So we can move over now back to Mediterina in Kerala.
Sanjay, can you see us?
Yeah, we can see you. We can see you. Dimitri, myself, and the entire panel are here.
Please. This was the position we left. Actually, the wire is going inside. Can you see?
Yep, we can see it. We were discussing the strategy that was used when the audio went out.
No, this is actually the next one, I think. This is the wire. It actually went inside, and we just kept the microcatheter as possible as, I think, next we cross. Next. We crossed in this one. No.
So as you did this, any thoughts about putting a safety wire down the circ and or using a guide extension catheter towards the ostium of the LAD?
No, this is actually when we crossed, and then we did a balloon dilatation, a trapped, and then next is actually we took the microcatheter is inside, naturally as normal retrograde intervention. Then we put a wire inside, that is actually the RG3 wire. Next, we escalated the wire. After that, we kept the microcatheter. It's actually almost at the septal mid part, so that we wanted to check tomorrow any problem is there. Then we did a balloon dilatation, keeping a wire in the circumflex. After balloon dilatation, we did next. We actually saw the vessel is actually having a competitive flow from the other side. Then we put an antigrade wire. The same wire from the circumflex we have taken, one more wire by the time. Next, we took IVUS. This is the IVUS. Can you just show the IVUS? IVUS, can you show? Okay. So Stalin, explain.
We can see the distal LAD is almost like a 2.25 with very minimal plaque.
Probably underfilled.
Yeah. Now we can see some significant disease over there. Fibrofatty, mixed plaque, some amount of calcium we can see at around 3 o'clock, 2 o'clock. Now again the calcium is increasing. You can see here it's almost 1 quadrant of calcium, 2 quadrants of calcium. And again back we have a significant disease over here. Now the vessel is looking almost like a 3O. We have almost a 180-degree calcific nodule protruding into the lumen. And I think this is a part of the CTO. CTO is almost like fibrocalcific CTO, long-standing CTO. Can see some minimal dissections probably because of the balloon dilatation or maybe because of the previous intervention. We don't know. Yeah, again, it's a mixed fibrocalcific plaque extending almost. We are almost reaching near the osteoproximal part. Yeah, here the vessel looks like almost like 3.5.
3.5, and distally the vessel is only 2.75.
Yeah,
and we
plaque is extending. We can see here the
almost up to the ostium. This is
you can see the circumflex coming from the 6 o'clock to 8 o'clock position. LMC is disease-free.
Totally free of disease.
Looks like a 4.25 vessel. Yeah.
So the next shot, can you just show? We decided to take a cutting balloon. We removed the total left system. We actually checked an injection to see that the septal collaterals are okay. Then we kept the microcatheter in the septum. That is actually the way to be done because we don't want to damage that till everything is out. Then we remove the septals, the right system. Then we actually took an injection and see, because of the calcium and the nearly 180-degree calcium, we decided to take a cutting balloon. We took a Wolverine 2.5 because the distal vessel is only 2.75. We don't want to take a 3 or 3.5 because it is a distal vessel is only 2.75. We took a cutting balloon. Next. This is actually the position we are now. We are actually doing a cutting balloon. Actually, Sanjog, you can make comments.
So I was going to ask you actually, and Dimitri, please let me bounce this off of you. Do you routinely, once you've crossed and externalized, take a dual lumen catheter and flip antegrade, get rid of your retrograde gear? Or do you generally do your work on your externalized wire?
Usually we can actually, I do like a dual lumen catheter like Crusade and all. Here actually I was very much almost sure that I can pass with a single wire without even an external double lumen catheter. The way I do usually take a double lumen catheter, then keep the wire and take the wire into the antegrade, especially to the LED easily.
Sure.
But here, actually Sanjay, you can see that you can also pass the wire.
Sure.
Here.
Sure.
So,
I guess the point I'm making is, do you flip antegrade or do you work on your retrograde gear?
Yeah.
I think it depends upon several factors. Sanjog, one is how well the retrograde gear is tolerated by the patient. Second is, do you really own the vessel, or how close to the distal cap you are? And then if you're dealing with a bifurcation. So what you can finish your case, most of your cases on the externalized wire because it gives you the best support. But if you have issues with ischemia or bifurcations or things like that, then I use routinely a dual lumen catheter in exchange for an antegrade.
Yeah, Dimitri, only point actually I just wanted to stress this actually. If you have a vessel lumen which is underfilled, distal to the entry of the septal collaterals, then you require a wire go to the antegrade. Otherwise, you can finish everything by the, if the retrograde, the septal collateral was distally and the vessel disease was totally in the proximal part of the that is RG3, then everything we usually finish with one wire and we don't take another wire here. And naturally, in this case, we require definitely a wire into the circumflex. That you agree with that? Correct?
Why do you think the flow in the distal LED is a little bit suboptimal?
That is basically because you have an excellent collateral coming from the right system. So as long as the vessel is not well opened up, you may have a flow coming down from that side. Once you take a 3 or 3 millimeter stent or 2.75, proximally we have to dilate with a 3.5 millimeter balloon in the proximal part. Then definitely I think antegrade flow will be very good. You can make.
We look forward to. Yeah, no, we look forward to seeing this. I think we've got about 5 minutes left in the live cases before we've got to go back to our didactic lectures. So
you can take, what is the length of the stent?
38. So what's the stent size that you're going to choose if you're going? Now I believe distally the lumen was about 2.25, right? But EL to EL it was a little bit bigger.
And then 2.65 actually. 2.6.
There we go. Okay.
We actually going to take a 2.75 into 38 stent.
Okay. Good.
This 38 and proximally we will dilate with a 3.5 millimeter balloon. Can you take a 2.75? Okay. We are going to take a Synergy 2.75 stent directly.
Okay.
Stent.
So the 2.75 Synergy platform will go to 3.5.
Yeah. We can actually make the proximal part 3.5 and actually in the mid part we can dilate 3.5 at a lower pressure and the proximal part we will go high pressure with 18 or 20, so we get an excellent result, keeping the wire in the circumflex.
I think one good trick to try and figure out why the flow in the distal LED is not perfect, most likely is as it was said by Kumar that it's a good collateral. You can put a balloon in the right coronary artery and occlude at low pressure the collateral and then take a picture, and that will answer your question. Then you can see the entire LED or target vessel fill, and then you have no questions whether there is a significant lesion further down or a second occlusion or any complications from the stent.
One point, Dimitri, but another point is actually you may be pushing on some of the materials which is in the proximal part and that create a slow flow display. That is also one possibility we should think about in this case. Can you just come to the RIO point?
So that's sort of where I was going as well with the flip to antegrade, right? Is I often flip my retrograde systems to antegrade, but I keep my retrograde guide in place because I would rather put the balloon up in the antegrade segment towards the the distal cap and plug the CTO vessel and take a retrograde injection to prove that you've got a good, healthy distal vessel, then do the opposite of instrumenting the donor vessel, because at that point you've got a vessel that's arguably not diseased, and you're instrumenting the non-diseased vessel instead of the one where you're going to end up stenting it anyway.
Yeah, but if you put a small balloon at low pressure, 4 atmospheres, and you occlude the distal flow at the main collateral, you're not going to injure the vessel.
Yeah, I don't disagree with you. I don't disagree with you. It's, I think the point is that we can always use collateral flow to identify whether or not our distal vessel is good, and that works in either direction. So here, that's interesting, right? So you have a stent up now, and you still have a fair amount of competitive flow distal, which is unusual when you have a totally recovered lumen in the target vessel.
It's possible actually, Sanjog. It may take some more time because actually the collateralization was wonderful in this case, because you could see that multiple collateralization, even though patient had angina, but the collateralization was very good, right?
So I think, yeah, so this is one of those perfect opportunities where if you had a guide retrograde or in your donor vessel and you put a balloon up inside that LAD stent and occluded it, you could take a picture and figure out how far that flow comes up. If that flow doesn't come up, then you're dealing with distal embolization or a dissection or something distal.
We have taken a 3.5 millimeter balloon. Positioning. Ideally, you have to take a clear stand and understand whether we are in the right place.
So Dr. Pratap, I think at this point we'll maybe switch back briefly to Dr. Kapoor just to see his final result, and then maybe we'll come back for your final result.
If you're coming back, we can show the IVAS last.
Super, super.
Thank you.
Yeah.
Thank you, Sanjog. Thank you, Dimitri.
Thank you.
Yeah, hi Sanjog. So we are back again.
Hi.
Yeah. So I'll show you, we have done the post-dilatation of the LED stent and have taken a OCT run. So can we run a OCT video here? Yeah. So this is the OCT video of the LED stent. Yeah. So looks good here. Again, well posed. It looks reddish, you know, and at this segment, but there is some ectatic segment, and we calculated the vessel was 3.5. So we have dilated after that, which I'm not showing. So after this OCT run, we have dilated with 3.5 at around 16 atmospheres, and we're coming back and see the ostial placement. It looks pretty good. Just half a strut into the left main. Yeah. Yeah. So this is the LED complete stent, and this is the final angiographic shot. Can you show the final angiographic shot? Next one. This is the leocaudal view. Next. No, previous. Yeah. And this is the final shot with the LED. I think it looks fine with us, but any comments, we'll be happy to take it.
Great, congratulations on a very nice case. What were your final contrast and radiation numbers?
Final contrast was 150, and the radiation is 9391.
So almost 10 gray.
Yeah.
Okay.
So I think that part is still, you know, we are way behind in India. We are not using those radiation protecting covers because of the cost perhaps, but yes, that's in discussion now, and that may be the case in every case further on, and you know, with the discussion with the management. Yeah,
very, very nice coronary result. Probably worth following the patient up post-operatively in 6 to 8 weeks to make sure that the skin is healing, and you know, I look forward to understanding what a repeat echo would look like in him to see with better flow down the LED whether or not that anterior wall wakes up.
Yeah,
I think that's an excellent result. I would say that you should extend the follow-up for radiation injury beyond the 6 weeks. So you do it at 6 weeks, and then make sure for at least a year that you follow the patient periodically, and that you avoid any non-critical any more procedures.
Right.
Yeah.
Right.
There's if you're absolutely pushed in the setting of STEMI or something along those lines, learned this from Dimitri. You can take a rad pad, cut it out, and place it over the area where you radiated previously, so that you don't radiate over that area, and then choose a different angle. But I think at 9.39 gray, I think it would be important to avoid any additional procedure. Certainly staging that ramus, these kinds of things would not be a procedure you would do for the foreseeable future while this patient's skin declares itself.
Right, well taken. Yeah.
Thank you very much.
Yeah, great to be here.
Congratulations on an excellent result.
Thank you from all of us from Medanta. Thank you.
Congratulations. Thank you for having us.
Congratulations on an excellent result.
Thank you. Bye.
So Sandro, should we go back on section 3?
Yeah, I think that's a reasonable thing to do. I think that's a reasonable opportunity to transition there.
Let's make sure that we keep it as short as possible.
Yeah.
I think you're up
we'll tighten it up.
next. You're going to talk us about retrograde updates.
I am indeed. Give me just a quick second here and I'll make sure that I have my slides available.
So we'll go to Dr. Pratap and go to lectures, or after lecture we'll go to Dr. Pratap.
Is he immediately ready to close? I think we're ready to go ahead with the lectures. Dimitri, if that's okay with you?
I
if
think
he's still got work to do.
After your lecture, we can go back to Dr. Pratap, I think.
1 minute, you can, no, there is, everything is finished, just show one shot and come back, finished.
Okay.
If you can come back to us, we'll show the IVUS and finish it off. Okay.
Okay.
Can you just show the IVUS?
Yeah, we can see the IVUS, the distal edge is okay. And here it's a fairly well expanded stent in the distal part.
There is some more expansion required.
Yes, in the mid part we need some more expansion. Here we can see significant.
You dilate the 3.5 only in the proximal part.
Again, you can see that the calcium is causing the eccentric luminal opening. Yeah, again, this is okay. The luminal area is okay.
Can you just go fast and?
Yeah, in proximal part you can see a well expanded stent here. Again, coming back to the ostium, I think it's well covered. It's just covering. There's probably just one strut protruding, and LMC is okay.
So can you show the final angiogram? Can you go to the angiogram?
Go to the angiogram.
This is the final angiogram shot. And can you come back to arteriocaudal and last shot we'll show. And we will do some more work in the distal part of the stent and then finish it off. Sanjay, Dimitri.
Wonderful. Thank you very much.
Yeah. Thank you for actually the
enjoyable case to watch.
Thank you, Sanjay. Thank you, Dimitri. Thank you, Aditya Kapoor. Thank you. Bye.
Thanks for having us.
Thank you for having us. Congratulations on your result.
Thank you. Bye.
Okay. Switching gears then, Dimitri, is that okay if we bring up the slides here?
Yes, please go ahead.
Thanks. Can we mute the live case site then, please? Great. Okay. So I will try to keep this as practical as possible. I think we heard a lot of really good data review from Dr. Doshi, my colleague and friend, who discussed a lot of the contemporary retrograde data. So I'll start with a case. This is an RCA CTO in a post-CABG patient, and I'm going to put out there that this is not one of those, technically marvelous, very, very difficult, crazy cases. The idea is to go through the thinking exercise to decide whether or not we are applying the most appropriate and most contemporary evidence. And if we're doing so, are we thinking about whether or not we can start to predict trouble before it happens and how we might prepare ourselves? And so I might kick it back to Dimitri intermittently during the presentation to see if we can get some comments from the panel. So this is an 80-year-old with previous CABG and previous PCIs to the circ and left main, who comes in with CCS class 3 angina because of a very tight lesion at the ostium of a vein graft that's severely diseased. He has a tight RCA CTO. You'll see here, there's your severe disease at the ostium of the vein graft. This vein graft's been intervened upon previously, so the decision was made to go after the native. And you can see that this vein graft is, it makes a pretty good retrograde conduit. It's a very reasonable angle of entry back into the distal RCA, but this is a long, complex, heavily calcified chronic total occlusion. So the questions for thought are, is retrograde the right approach to recanalize this CTO? Is that really the primary approach that we should take? What are the predictors of using retrograde techniques, right? So when is it that we should really be thinking about these types of things? And what are the outcomes of retrograde CTO PCI? So we're all very familiar with a hybrid algorithm. We've talked ad nauseum about the way we select what our strategy is going to be. And in this case, I think you've got a very appropriate interventional collateral. You do have a distal target that's quite badly diseased. And then you do have a fairly long lesion. And so this is the type of thing that would steer us more towards a retrograde approach than an antegrade approach. When we look at the contemporary outcomes of retrograde CTO PCI from Progress CTO, what we take away from these 1,300 patients that have been enrolled in this operator reported registry, we see that almost a third of them actually need some form of retrograde techniques to achieve technical or procedural success, right? With failures occurring still within the registry, of course, but looking at 1,300 patients with only 76 technical failures and the rest are successes, it really speaks to us out of this group of 400 patients that retrograde techniques are germane to achieving optimal success rates, right? So we need to know how to do this. But does that mean that we should just do it on everyone? Well, we know that technical success rates in retrograde procedures are lower than technical success rates and procedural success rates in antegrade procedures. And with that, when we look at the actual procedures themselves, because of the technical aspects of retrograde procedures, the amount of equipment that's necessary, the fact that there is fine technical manipulation that's required, it's not surprising that procedural times are longer in retrograde procedures, as is contrast volume, as is higher radiation, right? And we just had a nice discussion through the live case about how important it is to control our radiation and minimize the amount of radiation that's being imparted to the patient. And what we also recognize is that when we look at the Progress CTO data, MACE rates are double almost in retrograde, almost triple in retrograde procedures than they are in antegrade procedures. Now, this is an operator reported registry. There are more data out there, but consistently what we see is that retrograde procedures seem to be associated with higher rates of complications. Now, not necessarily causal, but we'll get into that in a moment. When we look at technical and procedural outcomes, what we see is that as cases get more difficult, right? So your JCTOs become your JCTO5s, the need for retrograde techniques to achieve technical success goes up, whether it's a primary retrograde approach or it's a secondary retrograde approach. And that's an analysis that we did as part of that paper in CCI last year, where we looked at retrograde outcomes from OpenCTO. In this particular paper by Tajetti and colleagues out of Progress, they found, just as we discussed, that the procedure time, contrast volume, fluoroscopy time, et cetera, goes up, and that procedural complications when retrograde techniques are used are substantially higher than when only antegrade techniques are used, right? And that's marked by 1.66% pericardiocentesis versus only 0.3% in the antegrade approach. And then similar findings with acute MI, not systematically measured by postoperative troponin rises, but in those in whom they were measured, and even a higher rate of death. So clearly we've got to be careful when we feel like we need to pull these techniques out. This is a lot of what we found in the OpenCTO analysis that we did as well a few years ago as our group. We found that the cases in which retrograde techniques were used systematically had higher JCTO scores. So these were indeed more complex lesions, and that technical success rates were systematically lower when retrograde procedures were required, not surprisingly, because they were arguably more difficult. But we found the same thing, right? Our MACE rate was 10.8% in this expert operator registry versus 3.2% in the antegrade only group. And as Darshan presented, what we found was that though retrograde techniques were very important to achieve high success rates, the early on hazard of retrograde could not be ignored, or the procedures in which retrograde was used could not be ignored. But importantly, if you got out of the initial in-hospital period and followed these patients out, their outcomes were no different than those in whom just antegrade techniques were used. So the important part to understand is that it's the upfront hazard that we really have to be careful about. And that then comes down to predicting complications in our procedures before they happen, not getting the patient out of hospital and then something happens afterwards, right? So that really makes that upfront peri-procedural period very important. And most importantly then, in the individuals who have used retrograde techniques, who arguably have more complex disease, these are the individuals who benefit most in terms of their differences in the Seattle Angina Questionnaire domains on their quality of life, right? So when you're treating complex lesions, you're still doing patients benefit, but the key is to recognize that there is an upfront hazard and we've got to avoid it. So this is our case continued. Okay, this is the retrograde injection. We've got a retrograde wire up. Okay, that wasn't hard, right? That took just a moment. And then as we move forward, we start running into the typical calcification that we see in these post-CABG patients. So our retrograde Carlino was performed. This is a retrograde contrast injection into the body of the vessel to try to loosen some of the tissue and facilitate wire entry into the vessel architecture. Okay, and we tried that and we did some more, right? Because the first bit didn't work. It got even more aggressive with it. And then we were able to advance this, what ended up being a reasonably large retrograde knuckle up into the subintimal space. This was a radar wire, and that's really the only thing that we were able to get a knuckle going with. We didn't have a Mongo wire at this time. Otherwise, that would have been the wire I would have used because of its construction and how it's purpose-built to achieve that. So as we wired retrogradely towards the antegrade guide, our antegrade knuckle was advanced. We did the usual dancing picture to prove that we were in the same space, which we were. We had a little anchor balloon in the antegrade, in one of the conus branches there to help us get that antegrade knuckle in. And then performed reverse cart using a 3.5 balloon. Nothing too exciting here. I used a Pilot 200 to exit, externalize, do the PCI with IVUS guidance at 3.5 and 4.0 millimeter non-compliant balloon post-dilatation. And then we've got this guy at the end here, right? So now there is a small perforation in this vessel. Okay. So Dimitri, I'll kick this back to you now, and I'll say, knowing that there was a complication, was retrograde still the right approach here? Was this complication predictable? And in post-CABG complications, are they a little problem or a big problem, particularly with perforations?
Well, CABG patients are the most complicated ones. And if you look at registries from different parts of the world, the percentage of CTO-PCI performed in post-CABG patients differs. For example, in Japan, it's less than 10%. In Europe, it's low 10%. In our series, we have post-CABG patients almost 45% or more. Yeah, which reflects different approaches to the initial problem. In some areas of the world, they go directly to CABG and then do PCI. In other areas, they're more aggressive with PCI and then they do CABG if the PCI fails. So here the problem was the calcium. It was not the retrograde. And I'm not sure whether you had done this case antegrade or retrograde would have made much of a difference. We did know going into this case that this is an 80-year-old patient, which is a risk factor for complication. The length and the JCTO is also a risk factor. And the presence of calcium independently is a risk factor. So I think that a complication of this type was kind of predictable or kind of expected. It's not a surprise. Could we have done something different, maybe with intravascular ultrasound to try and modify our balloons and the way the area we make the connection? Yes. Are they a little or a big problem? They can be a big problem, especially if they occur behind the left atrium, where they can cause compression of the left atrium. It's not like the virgin chests where you can tap these patients easily. So it can be a problem. On the other hand, sometimes you can get away with it because there are so many adhesions around that area that if you follow the patient for a long time on the cath lab with repeated echoes and prolonged balloon inflations, you may get away with it. But should they become a problem, then they are a big problem.
So there you have it, the words of an expert. I think the points that were brought up were precisely what I was hoping would be discussed. The key ones being, what are the risk factors for complications in this case? And if you have a small perforation, which ultimately, I'll skip over this because Darshan's already reviewed it. If you have a small perforation, which ultimately are pretty common, depending on which registry you use, they're between 4 and 9.8%. With exactly the predictors that we just discussed, longer lesions, the use of the retrograde approach, the presence of calcium, are they a complication that you need to be worried about if they're a tiny perforation and you conceal them, right? If you're prepared for them? Is that something that, I mean, obviously we want to avoid these types of things when we can, but the reality is when you have heavily calcified arteries and you're having to use dissection reentry mechanisms to recanalize these vessels where there are good indications, is it better just to be prepared for small perforations like this that you can simply address, right? When it's important to understand where perforations are going to occur. When in open CTO perforations were carefully analyzed by Tashi Hirai and his group, what they found through their review of the 89 perforations that were angiographic in the open CTO group, by sizing them, defining their shape as high risk versus not high risk, so clearing, fast filling, fast drainage. What they found was that most perforations seem to occur in the target vessel, not in the collaterals, but that those that occurred in the collaterals, particularly the epicardial collaterals, were often fatal. And so that's why we always say to avoid epicardial collaterals when you can. Try antegrade techniques, try the use of imaging, and then, if you have to, do your retrograde through an epicardial if there are no other choices, but recognizing that a specific informed consent discussion should come with that kind of a procedure plan. And then as far as predicting perforations go, this is the open clean score that was recently published by Hirai and his group again, where they defined out of the open CTO group, the predictors out of 8 upfront sort of factors that they had considered the predictors of perforation. And age was identified, as Dimitri said, who is also a co-author on this paper. Prior CABG was identified, low ejection fraction, occlusion length, and then the presence of calcification. So in our patient then, what we find is that he got 1 point for CABG, 2 points for a long lesion, and 2 points for age over 70 and 1 point for calcification. So he had a score of about 6 to 7. So that means your perforation rate is going to be around 1/3, right? So that's an important thing then to be ready for this case and to cancel the patient on, right? It's not a panic if you're ready to go, right? So in this situation, we were concerned about the calcification in the first place, and so we were taking short injections after the stenting was done between post-dilatations. Ended up doing a balloon tamponade for 20 minutes. It still leaked, so we put a large covered stent in and shut down the perforation. We'll skip over that for now. This was our final result. Right? We post-dilated this. You can see there's a bit of a leak there. So we post-dilated and it was fine. So the last question for thought is, this case had a small perforation with no clinical consequence and no change in the patient's outcome. Is this still a complication, or is it a predictable issue with the procedure? And do we need to reconsider the definition of significant complication in these types of high-risk cases? Retrograde CTO PCI remains critical to achieving high success rates. It's important for us to be able to move through the entirety of the hybrid algorithm when we try to recanalize these types of lesions, but we do need to be prepared for complications and for technical challenges like small perforations, because these are sicker patients, these are tougher lesions, these are longer lesions, and they require more equipment. And so it's important to maintain an awareness of all of these factors when doing the informed consent discussion with these patients, and then when bringing them forward for their procedures. Thanks for your time and attention.
Thank you, Sanjay. That was excellent. In my opinion, this is a complication. I think you treated it the right way, because the last thing you want is to have a localized tamponade that you're going to have to send the patient to a very, very difficult surgery in order to treat it. However, we do have data that long-term outcomes of covered stents, whether the older generation ones or the newer generation ones, are not great. So the bottom line is we need to try and avoid perforations that require covered stents. They're not benign. So in my opinion, acutely, you can say that you got the patient through the procedure, but long-term, we do have data that the risk of thrombosis and restenosis is very, very high. So yes, it was a successful overall procedure, but I'm not very happy by the fact that we had to use a covered stent.
Yeah, I think that the key point there is that some of these procedures are, if you're looking at a procedure that has a high likelihood of perforation, then the techniques that one uses to recanalize those vessels, I think, should be taken carefully into account. So maybe doing very aggressive Carlinos and these kinds of things to try to recanalize the vessels may not be the best approach. It might be better to spend more time on the antegrade portion to try to use the retrograde as a marker, for example. To try to avoid these types of perforations in these types of cases, that you're not ending up in covered stents.
Okay, that's excellent. And then we're going to continue with Dr. Raja Haytham, who's going to talk to us about more complications and management in a case-based fashion. Raja?
Good evening, everybody. It's an honor for me to be here straight from Montreal, Canada, with this esteemed panel of colleagues and friends of mine. So to segue a bit into Sanjog's talk, I'm going to present to you a nice case of a retrograde complication. And just before jumping into that, this is my disclosure slide. So we know that when doing CTO PCI, or matter of fact, any kind of PCI, you could deal with multiple types of complications, whether it is cardiac or non-cardiac. In this presentation, I will focus on one of the complications that we see, unfortunately, often, is perforations. You could have main vessel, distal vessel, collateral perforations. Here we will have a case of an epicardial collateral perforation and how to manage that. You're all familiar with this beautiful slide from Manos Brilakis' book about the perforation algorithm. As you all know, the first step is to inflate a balloon to occlude the vessel, manage the hemodynamic, have a pericardiocentesis kit at the ready, and notify the surgeons. Most often, these measures work very well. Unfortunately, when they don't work, you have to know what to do. One of the things is how to manage embolization with fat coils or other devices, and how also to use covered stents. So I gave a talk at TCT about the complication cart. This is what I have in mind. So you should have at least some of these tools in your lab if you're dealing with chip or complex PCI. So this is the case presentation. It's a 69-year-old male with traditional risk factors. He's known with coronary disease, a positive MIBI in an inferolateral territory. He was bypassed in 2000 with a Lima to his LAD and an SVG to his RCA. He also had stents put in after his bypass. He has an EF of 50% and a positive stress MIBI. His coronary angiogram from 2017 showed an occluded SVG to his RCA, a patent Lima. His circumflex that was stented was okay. And at that time, there was an attempt by another center to do antegrade wire escalation for the native RCA CTO. Unfortunately, it didn't work, so the patient was referred to our center. So this was a bilateral 8-French long sheet access for the case. So here what we see a long mid-RCA CTO with an ambiguous proximal cap, and we see that the distal cap is actually right at the bifurcation, which is, as you all know, a complexity factor. We also see that the main collateral feeding the CTO is a tortuous epicardial that comes from the left circumflex. So these are the setup shots. Here you really see well that epicardial collateral that looks interesting because it connects directly. But as you all know, especially in post-CABG patient, these collateral could be very dangerous. So before tackling that collateral, we decided to explore some other options and to see if there was some connections from the septals. Unfortunately, there wasn't. And as you can see here, despite the wire seeming to be in the right position, when you do multiple views, orthogonal views, you realize that actually it's floating in the middle of nowhere. So after exploring decently some other options to avoid that epicardial collateral, we ended up with some myocardial stain, which is actually heals pretty well by itself. And we finally decided to actually tackle that epicardial collateral. Here we have a turnpike LP, 150 centimeters, because we're retrograde, with a Xi'an guide wire, very carefully navigating that collateral, letting the wire do its work, and coordinating the movements of the wire with the systole and diastole. Unfortunately, as not often happens, this epicardial collateral was very fragile. And when we advanced the microcatheter, unfortunately, we had a perforation that you see right there in the middle of the screen. Now, this could be very dramatic for the patient, especially if it's post-CABG, because it could be in the retro AV groove and have focal tamponade, and it could lead to a disastrous outcome. So the first thing you do when you're faced with that is to control yourself, leave the wire in position, advance the microcatheter proximal to the perforation, and apply negative suction. Once that is done, then you have to think about how you will access this collateral from both ends, so from antegrade and retrograde. So in this case, because the native vessel is CTO, we went through the SVG that was occluded, and we wired it, opened it up, and gained access to the distal bed of the RCA in order to get access to that collateral that was perforated. So we put stents in the SVG just to give us access to that distal bed to manage it. Once we got that, we successfully advanced the wire and another turnpike LP retrograde, antegrade at this time via the SVG. And once we had access to the collateral, we deployed some pushable coils through a Renegade delivery catheter. nowadays we could use some coils that are compatible with the 0.014 microcatheter as a turnpike, for example, or a fine cross. One of the companies that I use is the Axiom neurocoils that are compatible with 0.014. So once we deployed these antegrade coils, we went back to the retrograde epicardial collateral management, and we have to be very careful there because there's not only one branch that was feeding that collateral, there was also other multiple little branches that I pointed out with the white arrows. So we had to access all these little feeding branches and actually deploy coils there as well to stop the flow to the perforation area. So as you see in the screen here, from the retrograde aspect, we have controlled the flow, we stopped it. Unfortunately, from the antegrade aspect, we still have a leaking that's persisting. So we went back antegrade through the SVG, and we actually decided to inject some thrombin on top of the coils that we already had deployed to really make sure that we stopped all flow to the perforation area. So here's the thrombin injection, 0.2 to 0.3 cc of 1,000 units per cc concentration. You flush it with a bit of saline, 0.1 to 0.2, and the thrombin will do its hemostasis work. So now we have a sealed perforation from both sides, antegrade and retrograde. We controlled all the feeding branches to the perforation, and we managed to avoid disaster. So my take-home complications, and I think Sanjog and Darshan and a lot of us spoke about this topic, retrograde access is useful to be able to complete cases, but unfortunately it's associated with a lot of complications. And as Imad had pointed out, and that Dimitri really taught us to do, is never try to do epicardial collateral unless you're very high volume CTO or chip operator, because these complications could make your patient die. And if you can't manage them properly, and if you don't have all the tools and tricks to deal with them. So always stay calm and composed, have a pericardiocentesis kit at the ready. Try to access your collateral from both ends if possible, when it's possible, and make sure to stop all feeding branches to the collateral. Use your perforation algorithm and use whatever tools you have to make sure that you control that area. So you could use coils, thrombin, covered stents, gel foam, fat, whatever you need to do to stop that perforation, you need to do it. So thank you very much, and I'll leave a bit of time for discussion with my good friends and colleagues.
Thank you, Raja. That was excellent. That was an amazing case and a great save, because once you have this perforation in the AV groove, you can compress the left atrium, and this can be a disaster. And it's very difficult to access surgically, even if you have excellent surgeons. It's a very, very difficult surgery. Can you speak, you described a lot of tools. Can you just for 30 seconds make a comment how important is to know how to use these tools and how to learn to use them before you're actually in a crisis like this? Because the last thing you want to happen to you is in the middle of the night to have to read the brochure about how to use them.
That's an excellent point. And actually, I went through this myself, because when I came back to my lab, we didn't have any coils. They used to call the interventional radiologist to come deliver their coils. So when I ordered the Axiom neurocoils, for example, we had a session with my colleagues where in vitro, outside of patients, we practiced deploying these detachable coils through a microcatheter, either a fine cross or a turnpike. So it's very, very important you practice outside of the patients in order to become very comfortable and for it to become sort of a second nature in case it happens in a case.
One other thing I just want to add is that the other place to practice it is in SVG intervention. So if you do a CTO PCI and you use an SVG and then you open up the native, but the SVG is still open, you can go ahead and coil that SVG, and that would be another area to sort of practice that.
Great.
Or just play with your friends in the interventional radiology suite where they coil vascular tumors all the time so that you can get some experience with these devices. The other comment I want to make is when you inject thrombin or beads or other hemostatic particles, you need to make sure that there's not backflash of this material into the main vessel, because you can have catastrophic myocardial infarctions. and then you don't rewire and keep a wire in place because the outer surface of the wire is going to be covered with this thrombotic material, and you may have catastrophic thrombotic of the entire coronary tree. So after you finish your thrombin or your beads or whatever you do, then you pull everything out. I even take the guide out and re-access without leaving a wire in place.
Great point.
And with that, we're going to go to the last talk. My dear friend Luis Ibarra from Canada. He's done tremendous amount of work under the guidance of Greg Stone and Stefan Renfriend and other experts from all over the world to come up with an ARC CTO document that was recently published in CIRC. And he's going to talk to us a little bit about the new language of CTO PCI. So, Luis.
Thank you very much for the introduction. Thanks for having me here. Going ahead with the presentation. So as Dimitri mentioned, this is an overview. This talk will be an overview of the paper that we published earlier this year in circulation, with some of the definitions for studies and trials in the CTO PCI field, the Chronic Total Occlusion Academic Research Consortium. Of course, this was a collective endeavor, so I want to thanks everybody involved. And so the CTO work was divided in 3 different sections: the key anatomic and procedural aspects, efficacy and safety endpoints, and the clinical trial design principles. And we're going to talk briefly a little bit on all of them. So we first need to define what is a CTO. Important here is to understand what is a CTO with typical appearance, so trials can compare apples to apples. I would like to highlight how 2 CTOs divided by an island should be measured, from the proximal cap of the proximal CTO to the distal cap of the distal CTO. And here I'm going to show you an example of such a case. We have 2 CTOs in the LAD measuring 6 millimeters and 13 millimeters, and if you combine them, it's going to end up with a CTO of 27 millimeters. We all know that 2 CTOs in the same vessel are usually one of the most difficult scenarios that we can face during a CTO PCI. So it would not be fair to compare 2 CTOs, short CTOs, with a single CTO in studies or registries. Another interesting aspect, and that generated a lot of debate, was the nomenclature for the vessel architecture. One needs to realize that the subintimal space is not really an accurate term for where our equipment is. And because of that, it was decided that we should use a more precise term known as extraplaque or intraplaque. Although the terms true and false lumen can still be used, but for segments before and after the CTO. Lesion crossing strategies were also defined. To mention here, we're not using the term escalation anymore when talking about wiring, either antegrade or retrograde, because as we all know, we tend to escalate, de-escalate, escalate again during antegrade, during wiring, antegrade or retrograde. So we moved away from the escalation name. It's also based on intention. It's not the real position of the wire. So it's all about, if you want to talk about real position, you need to do the intravascular imaging. And there are several other definitions on CTO devices and equipment, collateral channels, and some other lesion characteristics and complexity scores, and I encourage you all to take a look at the manuscript published in the circulation to get more definitions on those aspects. Talking about endpoints, it's interesting here. So we start with the crossing success, which could be either antegrade, retrograde, or just crossing the collateral. Once you achieve the crossing success, then you're aiming for the technical success, which would be a TIMI flow equal or greater than 2. If we remember the live case, one of the live cases, there was a debate if we had the TIMI 3 flow and whether it's a success or not. So the consensus of the CTO work was that because of the collaterals we have, not always we are able to achieve a TIMI 3. So it would be, although we have all the good features of successful intervention, not having a TIMI 3 flow would be unfair to the procedure. This will still need to be proven and in ongoing future studies. Also need to achieve revascularization of all distal branches equal or greater than 2.5. That's a complete technical success. If not all, then it's a partial technical success, and also residual stenosis less than 30%. And to achieve a procedural success, we'd have a technical success in the absence of in-hospital MACE, again, complete or partial, depending on the achievement of revascularization on distal branches. If you're studying devices, then you would choose a specific criteria for a specific device, whether it would be a crossing success for wires, for instance, or technical or procedure if you're assessing drug-eluting balloons or drug-eluting stents. When talking about these endpoints, death, stroke, bleeding, non-procedural MIs, those were really straightforward. But on the other hand, defining procedural MI specifically after the Excel trial wasn't that easy. So we decided to endorse the SKY definition, but also collecting all data so other definitions could be used as secondary endpoints. The procedures presented here are part of the initial therapeutic strategy if performed in scheduled fashion, and should not be considered adverse events. The time limit of which should be well documented in the chart. If a patient comes earlier than planned due to ongoing chest pain, for instance, that is considered an unplanned procedure and therefore a MACE. So just going briefly, we have a pre-index procedure where usually you treat non-CTO lesions. The index procedure, then the second index procedure, you might ask why not the third, because at some point we need to stop, otherwise you get a third, a fourth, a fifth. Then post-index procedure, a stage procedure to treat again non-CTO lesions, and we are allowed for optimization procedure to bring back the patient and optimize the final result we got in our intervention. With unplanned repeat revascularization, I'd like to highlight here the CTO-related non-TVR, which is a new classification for which is a new lesion in instrumented non-target vessel within a month after the index procedure. And there are several other endpoints. Again, I encourage everybody going to the main paper to take a look at this. Just highlighting the silent stent thrombosis, which is an occlusion that occurs with no clinical sequela, in other words, MI, TBR, or death, and usually is an incidental finding of follow-up angiography. On clinical design principles, which I find the most interesting part of this paper, there's a lot of discussion about inclusion criteria for CTO trials. Of course, it's going to depend on the population and objective of the trial. You have multiple that you could choose on. And so if you're assessing quality of life, if you're assessing MACE, if you're functional, change in ischemia, change in ejection fraction, you're going to choose your inclusion and criteria accordingly. And the same for follow-up. If you're assessing quality of life or functional outcomes, 3 months is okay, but if you're assessing durability or MACE, you'd want a higher, longer follow-up. In conclusion, uniform consensus definitions of cross studies provides greater consistency, more information and insights into comparative health outcomes. And it's important to say that CTO work is by its nature dynamic and will doubtless be updated in the future. Once again, thank you very much for the kind attention and for having me here.
Thank you, Dr. Dimitri.
Yes, thank you very much, Luis. I think this is a great piece of scientific work, and obviously it will help us have a common language across the globe and further refine trials and endpoints, and that's certainly going to move the field forward. Srinivas, I'd like to thank you so much. It's been a great honor and a pleasure.
No, we have been trying to do that. I request you to wait for 1 minute to do another important job for us. Actually, in the end, in the concluding thing, generally Dr. Sushil or Ajay would also join. Sushil was supposed to come, but he's stuck in cath lab, I was told. So as good things all come into end, we kept the CTO session because a lot of interest for doctors. That's how we kept this at the end and started with valve sessions. Thank you, Dr. Dimitri, for sparing your valuable time and designing the program and organizing all this for us. And a lot of interest, and about 1,000 plus doctors logged in your session, and the other 1,000, we also 900 or so were there in other hall, which we are doing nuclear cardiology and some interesting talks from Dr. Seres and Professor Ansriver. So after the end of it, what we normally do is to encourage people to continuously stay in halls. Before, in HICC, when we used to conduct, we used to have a barcoding system. So whoever stayed maximum in the hall, we used to give. Then last year, we started giving whoever is logged in for longer, though maybe sometimes you could log in and do some work, that's a different story. But our computer can only analyze when you have come in, when you have gone. So when we see who is the doctors out of 5,000 registrations we had because of COVID, or maybe most of it were free, only 900 plus were prime registrations. At any point of time, we were having somewhere in between 2,500 to 3,000 doctors, something like that, split in 3 arenas. And we are very happy. I also I don't want to be biased. So I made my AV team to get the names up, and I request Dimitri to read those names which come as a slide. So can you project that slide? Who is the longest people who have logged in for the long? This is a three-day course, as you understand, started from 3 p.m. to 10 p.m. We also had some enjoyment by some musical drummer of our country called Shivamani. He's a legendary person. So people enjoyed in the late after the imaging session yesterday. Can you project the, is it done? Can you make it bigger? They're not able to see it. Are you able to see it, Dr. Dimitri?
No.
No? If you share the screen, they will be able to see it, I think. You have to share the screen.
Sir, I cannot be able to share this screen, sir.
Okay, no problem. I'll read it, sir. Basically, the top 5 doctors who have enrolled maximum, who stayed in for a long time, almost every day, and full times are maybe few minutes difference are from each. Dr. Shabbir Ali is a cardiologist in one of the local hospitals here called OIC Hospital. So Dr. Kundu Rana, Dr. Farooq Jawar, Dr. Vandana Anasaren, and then Dr. Anasuya, all these from outside, I think. I don't know them personally, but Dr. Shabbir happens to be from Hyderabad. And congratulations and thanks for all your interest, Shabbir. And we wanted Professor Ansriver also to get involved in this. Sir is there, or did he leave? He's another senior person, quite experienced in QCA and always encouraged us with cure for modality. I think it has become too late. They must have gone. So I would like to just show, this is another iPad which we give, which are presenting to the doctor who was logged in for long. He's there, but somehow we are not able to get him here. We will send it to him. Thank you. And before we close, I request you all to watch this concluding video highlights, please. So this will be about a few minutes, and a lot of interesting things which are done. We try to make some small clips and present to you. Please watch this and enjoy before we close.
Thank you very much.
Thank you, sir. 12th edition of TCT India meeting.
Thank you again for inviting me. Thank you.
Behind me, Hendrik. It's certainly my pleasure and great honor to open this conference.
Please welcome. Meeting. I hope my pushing the guiding back.
A very, very good evening and namaskar.
TCT India, South Asia.
Severe hypokinesis.
Yes, slide. The miscellaneous, how you can make out. If you have a device that being perfused from the arch endograft, it is
Nishija, Prabhu,
as learning system, Dota, or Excimer Laser.
Germany and one from London. And then we had 20 odd cases. Dr. Ajit Mullasari also showed, he's here, showed interesting cases. A lot of very good cases were presented across, be it be valves or be it be imaging sessions, and some of the complex stuff which is shown also is quite appreciable. And the role of imaging has highlighted very much in doing the PCI techniques. And we in India now in the phase of structural heart therapy rising also, TAVR got already established. And now we are about to get into more comfort of mitra clip procedure. And that such of cases also were first demonstrated by Dr. Sai from Apollo Chennai. And we had excellent demonstration of that by Raj Makka. So I think that is the thing which we have to learn and adapt more for patient care. And one word of advice which I asked Marty Leon for youngsters to do, I asked him where is the scope for youngsters to learn more. He mentioned specifically he's looking for more therapies for heart failure, and we have to still do good work on it. And the happiest moment he mentioned in his life till now was where TAVR has proved supremacy and established itself. I think Greg Stone also highlighted us yesterday how to conduct proper group clinical research and how even the negative trials influenced him. And he said the mitra clip procedure, which helped in heart failure patients, he liked it the most. I think a lot of new therapies have come up in CTO space. And we were thrilled when Dr. Dimitri was with us, had shown some cases. Dr. Sanjog and all the faculty, be it Ajay, Sushil, and all other US faculty, and all the local faculty, always a great help. The great strength of the meeting, why 5,000 plus registrations happen and everybody comes together is not seeing me. I'm a small man compared to so many big people in the country, but basically the strength of academic program and the faculty, how it comes. That's how I thank each and every faculty. And some of the US faculty, I have to thank them enough. I don't know how to do it because they were not sleeping. Saurav Gupta, actually, I didn't realize the time change in other side of US. He got up and he was just all through there. So like that, Dr. Sanjog had to do some other work. Dr. Dimitri spared his all his time. So much efforts are taken by Ajay and Sushil and Greg Stone and Martilian. All that is a great support. And without all this, I think you have seen the last slide of our academic partners, what we call. Can you project that slide? Without, we can organize a program, we can get you good faculty, but obviously nothing with this COVID gave challenges. We tried to make various hubs across the country. PVRs on the big screens is a welcome change, I feel, where people need not travel and enjoy all these live cases on a bigger screen. So all this would cost lots of money. Apart from it, you have a very good AV team. They don't come without things. So, but not only the finances, financial support, and the major sponsors, obviously, I would appreciate Abbott, which has a leading stent maker in the country, and Medtronic also helped, and the pharma Lupin as I think a major contributor. Apart from it, we had all the regular pharma companies like Reddy Laboratories and many others like who helped in the program. Why I call them as academic partners is not only the financial support, but they get support from all the colleagues, coordinate for the live cases. Without that coordination efforts, it becomes very difficult. And all of us are busy. That's why I thank all the companies and all the company people. I think I immediately remember Subodh and Anil of Abbott, and then probably people from Medtronic also worked with Chandra and Nisha. And then we have Coronary Shiva and then Vipin. And to keep on telling names, it's difficult because already late. But what I do generally is I take at least two, three good people and try to give the responsibilities to them. Because obviously, if it comes to a few lakhs burden, others will kid on us. So we'll give the responsibility. The AV things were taken care by Lupin. And the transmission thing is taken care by one company, other things like that. So then anything else which was coming, I thought this idea, each hub I handed over to one of few of the pharma colleagues. And though its response was not that great, but it is a beginning. Each of the hub had about 40, 50. I think maximum response was in. I didn't want to push in too many doctors also in each hub, we wanted to have all the COVID precautions. That's how all the places had about 40-50 doctors only who came. And I appreciate all the patient logins and all the doctors who participated in this program. I think with this few words, if Dr. Ajit sir, you want to say any final concluding words or we'll play Janagana Mana later.
Thank you, Srinivas, for an absolutely wonderful conference. And during this COVID times, you really took on this job of putting this together. It's quite a challenge. And I really, whatever I could do and whatever I could attend, I really enjoyed this meeting. Thank you so much for bringing this meeting to us.
Thank you, sir. Dr. Dimitri, you conducted this, and Sanjog, I see them. If you want to say anything, one few words. I don't know, this platform is not allowing it. Yeah.
Amazing meeting. Great honor and pleasure to have us. Hopefully we can meet together next year. Thank you for having us. Congratulations.
Thank you, sir.
Echo all of those comments as well. I, as you know, really enjoy and relish the opportunity to meet with all of my friends and colleagues in India, and I hope that next year we can do so in person again. Congratulations.
Thank you. Everybody. Hope so. Thank you, Sanju. Can we all respect our national anthem and then we close the meeting? Can you play Janagana Mana? Those some South Asian countries.
Janagana Mana Adhinayak Jaya He Bharat Bhagya Vidhata Punjab Sindh Gujarat Maratha Dravida Utkala Vanga Vindhya Himachal Yamuna Ganga Uchchala Jaladhi Taranga तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Thank you. Namaste. Close.